various reputed textbooks. Today, he'll be enlightening us about hospital outbreak management. So dear colleagues, please welcome Dr. Mohammad Khalil sir.
Assalamu alaikum and a very good morning. I bring greetings from the city of Nawabs and Kebabs, Hyderabad. And it's really a privilege and honor to be invited as a guest speaker at this very holy place, Khaja Bandanawaz. And thank you for the organizing committee for inviting me. My greetings also to the chief patron, Janab Dr. Syed Shah Khusro Hussaini Saab and Muhammad Ali Al Hussaini Saab, Dr. Syed Mustafa Al Hussaini, who is the director, the patrons, the organizing chairman, Dr. Siddesh sir, organizing secretary, Dr. Bilal Ahmed and Muhammad Abdul Basir, joint organizing secretary, Dr. Juwairia, the committee advisory organizing committee, and also Nisar, who has been good with the hospitality, who picked me up and took good care. Having said that, at the outset, I would enlighten you with my talk on hospital outbreak management. Let me have the next slide, please. Yeah. This video is a very good educational video on how an outbreak can occur. Please, I would like every audience here to have a look on exactly how it starts, what happens, how the investigation, the cases, the vaccination, everything is covered in a nutshell. It's a very good movie by name Contagium. I wish everybody goes back home. It's free, available on Netflix, Amazon Prime. You can have take 2 hours from your life, worth watching. It was an outbreak on Nipah virus in US a long time back. So can I ask to just on the video, please? Okay, that was about your preparedness. But everybody has a story, if I'm not mistaken, from 19. Every family have a story, everybody has a story. There's not much in movie, but in real life we have seen this. It is a great pandemic in the history of the mankind. Very scary and all. So going to the next slide would be, can I have the slideshow please? Slideshow version, yeah. Objectives of the session would be, I would just enlighten you with some definitions because I believe in the concept of going to some fundamentals. The first 6-7 slides would be on exactly what we are talking about so that we can try to answer some questions on case scenarios through my slides. Then I would be giving you how important is to investigate outbreak and different types of outbreak, would be the hospital acquired or the community acquired, few case scenarios, or whether you are all with me at the mid of my talk. So during the first to 10 slides, you're going to go through my slides. Then I would talk on how important is literature search to do some homework for you to investigate in the present scenario, some tools to calculate, and finally I would summarize my talk. So having said that, yeah, some terms like you have sporadic, you have endemic, you have epidemic, and also pandemic. Though it's not concerned to my talk because my talk is on hospital outbreak management, but I thought why not just enlighten the participants with also few terminology like this. So anybody from the audience who can just give some comments on what sporadic is, or you would like me to come over there? Anybody's answering? Somebody answered it or your talk is what? Yeah, it was not audible. Can you come back again? Sporadic. Can you give an example of a sporadic infection? I will give you a chow chow for that. Is it called chow chow, what you serve in the morning? The sweet, it's very heavy. I mean, you greet us and you make us give a very heavy breakfast with a chow chow and a good tea, and you give a very comfort zone there. It's very difficult for us to come out of that comfort zone and come give a talk. What, Dr. R.C.? You feeling that comfort there in the chair? Sporadic is basically, it's a small outbreak. It's very infrequent. You don't know what can happen at what time. Please concentrate this, because my talk always would be very conceptual with facts and figures, and I want every audience here to learn something and go and apply that. So it's just that I come all the way from Hyderabad and just feel that honor and privilege to give a talk. No, I'm sorry for that. Everybody has here to learn something and go back home. So that's how the ilm and knowledge has to be spread. Fine. Where you have an infrequent outbreaks and very irregular, they're not consistent. And amongst the population, usually without geographic concentration. I mean, what I mean to say is, you don't have a limitation. It could be here, it could be somewhere else, another place. Now, this is a very good typical example of sporadic, where infections like tetanus, your rabies, or plague can occur. So, infrequent, irregular outbreaks without geographical concentration, then you should think it is a sporadic outbreak, right? Let's go back to endemic, where you have a geographical limitation. You cannot cross the boundaries. There are some areas, it could be some community or a country or a continent, where some infections are very localized and endemic. It is there by default. Like malaria in Africa, everybody knows. In Bihar, Odisha, or low socioeconomic countries, and even in India, it is endemic. Fine. Let's go to epidemic outbreaks, where there's an increase, and it's very sudden. You don't know. I mean, you're just sitting and the breaking news in the social media that there's an outbreak of this, that is like a MERS infection, or Spanish flu, yellow fever, or smallpox, measles, polio. These are very good examples for your epidemic, where it's very sudden. It covers a mass population, and it is what is normally expected above. So you don't expect, but it's more than what you expect, is an epidemic, a large-scale population, and that's epidemic basically. And pandemic is basically, I don't have to talk about pandemic. Everybody can write books on pandemic. COVID-19 disease is a very good example, and you have a smallpox or Spanish flu or H1N1, swine flu, and all these are pandemics which the world has seen. It crosses boundaries, it's beyond the boundaries, it covers continents. very fast it spreads. I mean, coming to the cluster, what exactly is cluster? You have a group of cases that are linked by same location or cases. They are either linked by cases or they are linked by a location. And you all have relatives or a family gathering, gone for a vacation outside or at the backyard, or students or employees have gone for a vacation trip. Then you can also talk about, these are small outbreaks. Small outbreaks, location and your event-wise it occurs, clusters. Cold flus, I mean, you had gone for a party and one of the relative or your member had a flu, it got spread to you and it's just a chain that's spreading a common cold or flu and stuff like this. So it's small clusters that happen with small gatherings. Whooping cough again, and people are having these days parties, weekends and all, so STD infections are also again a very good example for clusters, I mean chlamydias, HIVs and all. Having said that and believing that you have understood my second slide of the talk, let's proceed to the next slide. What exactly is an outbreak? Outbreak is where you have sudden and more than what you expect. Okay, you wouldn't have expected that this could have occurred in this way. An infection of an unexpected rate, and when you try comparing with your previous background check, it's huge, it's large, it's enormous. Or it could be occurrence of 2 or more epidemiologically linked cases of a disease like Japanese bee or measles, cholera or your plague. These are the infections where you have 2 or more epidemiological linked cases. So this would also be termed as your outbreak. Or you have a very unusual case or a very rare case, even a single unusual or a rare case would also be labeled as outbreak, like viral hemorrhagic fever or an Ebola. Okay, so these are the terminologies, that's how you define your outbreak. Yeah, let's know the difference between an outbreak and an epidemic. They look same, right? They look same. There's a minor difference. Outbreak is basically a small focal area, whereas epidemic is a large focal area. And outbreak is basically you have control measures which can be handled in a district level, whereas epidemic, it's a statewide level where this spreads. Yeah, what about outbreak versus pseudo-outbreak? This is very important, worth listening. Again, as I told you, key outbreak is more than what you expect. With clinical disease has to be there in outbreak, and that has to be substituted or substantiated with your clinical relevant data. I hope you understand. So outbreak is where you have clinical cases, patients with sign symptoms, and they are substantiated, they are proved, you have evidence based from laboratory, positive cultures. Whereas pseudo outbreaks, you don't have clinical sign symptoms, the samples comes, but you wrongly give as false positive reports. That is called a pseudo outbreak. Increase in reports or positive cultures without any clinical disease. Now, what could be the reason? Anybody? What could be the reason for pseudo outbreaks? So when you have a call from the consultant saying that, Dr. Saab, reports are coming like Staph aureus, E. coli, Klebsiella and cons, stuff like that, but I see my patients are all good. I mean, I am sending with another thing, but the reports are coming positive other things. So it could be because of when you just retrospectively go back and look into your lab and look at the cases and all, you come to know that new technician has been recruited, or a faulty technique being applied, or a new technology that has been brought into use and they are not well versed or experienced in handling that. Okay? So these are very, very important things that you should go back into your room, look in your labs, whether any new technician or new tool has been there, or a false interpretation of the reports. So these are the reasons for your pseudo outbreak. Or else they will give a wrong statistical data or wrong notion. Your data would be plagiarized or not accepted for publication also. Ward level, yeah, it can also happen the other way, at the ward level, where there could be new interns or postgraduates or faculty where they are not able to correct the clinical diagnosis, and they just send randomly the samples. Or they are not able to do the proper gold standard collection, transport, at the ideal time as per the policies and guidelines laid down by the hospital. So this is also one of the reasons from the hospital or the clinical bedside. Or it could be also the environment where you hardly check or look into that, the water being used to clean in the CSD for the endoscope or bronchoscopes or instruments, or simple tap water being used for your gram stain, your acid fast, or any other smears you made in a micro and pathology. So it's worth listening to this. Pseudo outbreak has to be there in your mind. Yeah, why outbreaks occurs is basically when the host susceptible and response are modified. A normal individual, because of his immunocompromised state, would be more susceptible, or individuals who are more susceptible would be going into low endemic areas, pick up that infection. Low endemic area, they are susceptible, immunocompromised, they pick up the infection, they come back and spread the infection. Or individuals go to an infection where there is endemic already, okay, and you get a fresh infection over there, you come back again, you spread. Or it could be simple because of contaminated water and food, and there will be outbreaks. So these are the reasons why outbreaks occurs. Types of outbreaks, community acquired when we are talking about the environment, food, the water, contaminated, and common source of or pool where people use it for the purpose. And talking about the hospital outbreak, which is my topic, would be same when the definition holds good. It's for the 2 or more infections. Infections epidemiologically related, or infections occur about the background rate. On the baseline, if the levels are increasing, the incidence is increasing, the risk rate is increasing, or you have an unusual microbe, a new amateur coming up in your lab. Case scenarios. Okay, let's go back to the case scenarios. Now, whatever you have heard, let me see if you've understood. Try to answer it yourself, or you can share it with the audience over here. There's one case actually. You are reviewing your surveillance data, and you suddenly notice a sharp, increase in number of hospital-acquired MRSs in one ward of your facility. Now what you do? It is typical that the ward identified 2 cases of MRSA per month. It is very typical that, okay, they're used to like 2 cases of MRSA per month, they keep on getting it. But suddenly, over the past several weeks, 2 cases per week is what they found. So while investigating daily activities in the ward, you notice inconsistent hand hygiene practices among some personnel. So do you think, you also note several of the cases recorded where patients sharing the room. So the 2 cases in a month became suddenly an outbreak of 2 cases per week. Now, what do you think? Is it an outbreak? Is anyhow dark over there? Only the person seen in this hall is me, because I'm in the spotlight. So you can answer right, wrong, whatever. I mean, it's difficult for me to come down there and locate. And yeah, is it an outbreak? Yes, it is an outbreak. Very good. So it is definitely an outbreak because the rate is more than what you expect. And also, as per the guidelines, any outbreak of more than 3 cases in a month, you should start declaring it as an outbreak. So as per the definitions which I have shared with you in 3rd slide, the case scenario goes for an outbreak. Let's look at the case 2. Recently, you worked with the emergency department to implement a new tool for identifying patients. You talk to your emergency department, sir, I want Vitec 2 scan, I want this, I want bacteria alert, I want Maltidorf, I want this, that. They gave you, and presenting with influenza like or biofire illness to prompt earlier isolation. You said, please give me this, I'll give you reports in time and very quick turnaround time. Over the next week, you notice an increase in number of patients being isolated for respiratory illness. I mean, you are excited, you are new in the market, you are MD qualified, and management is supporting you. You tell what you want, and they have given you, and you started reporting positive, 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 positive. And is it an outbreak? Is it an outbreak? Please say it. There are only 2 answers, no? Yes or no? The deadliest place in the hell is reserved for people who remain neutral in the world. There's a saying. So either you have to say yes or no. No, it's not an outbreak. If it's not an outbreak, then what is it? It's something, right? It is? Sorry, RC, what's the thing? Pseudo outbreak. Very good, right. Round of applause for them. Very good. It's a pseudo outbreak because new tool is there, or it could be a cluster also. It could be a small cluster which you have to investigate. comparing it with the previous data, or it could be a pseudo outbreak because there's increase in reports with a new tool being bought. And you have to just go cross-check whether there's a new technician that is inexperienced or faulty interpretation occurring or not. Because respiratory-like illness, they have not confirmed what it is. They're just thinking. It could be a common cold also. It could be just flu. It could be anything, influenza. Fine. Case 3, an hospital usually has 6 hospital-acquired TB per quarter. Now, however, 4 new cases have been identified in the past month alone. 4 new cases have been identified in the previous month alone. Is it an outbreak? Now you have to check your confidence level. Yes, Dr. R.C. also started nodding her head. It's definitely an outbreak. Because again, as more than 3 in a month is the lines in the outbreak, and earlier it was 6, now it has turned out to be 4. It's definitely an outbreak because more than what you expect has what is come out. So I hope we are all in the same platform. Everybody's with me. Everybody had breakfast. It was very good. You can have tea if you want. We can take a small break. Yeah, why investigate an outbreak? It's very important. You'll see what happens when you don't investigate an outbreak. Just leave, it's not my job. So to identify the source of infection, to control, to get correct diagnosis and get hold of the preventive measures. Proper infection control measures should be in place and ensure that preventive measures are applied as soon as possible. Common outbreaks in hospital include, everybody knows that, MRSAs, your VREs, multi-drug resistance, gram-negative bacilli, your Clostridium difficile infection, your gastroenteritis. So these are the common hospital outbreaks I'm talking about, which is my topic. When I'm talking about sporadic, endemic, epidemic, pandemic, those things are different, which I'm not touching upon. But concerned to hospital, most common hospital outbreaks would be this. Team is very important. Teamwork, conference or CME that is brought about at a national CME at Gulbarga, KBN today is really, I congratulate that the entire team has really worked nail and tooth to get a good ambience and get it rolled down with successful, so that's the mean you have a good team with good network, with good frequency. It has to be rapid response. It consists of infection control officer, an ID physician, or a microbiologist, an infection control nurse. It could be a member from the SPM department, PSM. Epidemiologist is very, very important with a statistician. Don't neglect anybody. Everybody plays a very, very important role. You are not only the boss. And you also have a clinician from, especially the broad specialty group, medicine, surgery, orthopedics, respiratory medicine. Then you have your pediatrics, OBGY. You have to involve all the head of the departments and in charges. HSCC committee member, who is the medical superintendent of the CEO of the hospital, also has to be a part because he is the key stakeholder. Laboratory personnel, who does the lab work. So other members, if you think it's the need of the hour, and depending on the outbreak, like the veterinarian people from the zoological unit or the, the biomedical waste people, the public health department, all have to be informed when there's an outbreak. So this form the team, and yeah, you have to be you should have a high index of suspicion. The 3 R's is nothing to do with the movie. It has to do with your read, review, and research. Always the 3 R's should be kept in your mind when you're doing investigating an outbreak. You have to read what exactly is happening. You have to do a research, go back, do a research, keep on reviewing your data, whether it's because you have to share it with the public health departments. You have to share it with your clinicians. Okay, you do not call a pseudo outbreak as an outbreak. So high index of suspicion should be there. Each department informs. The information actually comes from the department. The ICUs which call to you and tell, sir, I have been seeing reports over a period of months that you are isolating the same organism. Or it comes from the lab that you have been sending samples from the same unit, same ward, I am isolating same organism. It should be the other way around. It could be from the lab, it could be from the clinical departments, or the infection control team that picks up when looking at this, do the audits and all for the health indicators. So it could be from anybody else. Steps to investigate is a big list is there, everybody knows. You have to verify the diagnosis, you have to confirm the diagnosis, you have to inform key stakeholders, you have to management, you have to go talk to the medical superintendent, you have to construct a case definition, you have to define your case, collect the data, you should involve the epidemiologist and observe, review the patient care if you want. You should go back, look whatever patients were there, whom the patient has come in contact. All this is a big list. follow-up and communication findings. You have to communicate. Once you know the data, you have to communicate among the team. Periodical meetings have to be there. Yeah, as I said, literature search is very, very important. About 50,000 articles are published on outbreak management, is available on the net. You have to just go back, depending upon the nature of the outbreak and your hospital setup, go back, do a check, and also, because it's very valuable actually. Very valuable resource and used for educational purpose for, as well as preparing outbreak, because you don't know, it could be very new for you. So there are a lot of data base in your net, you can just go back and cross-check. Steps to investigate or suspect outbreak, verify if the outbreak really exists. How do you do this? Verify if the outbreak really exists. How do you do this? It's a definition, right? Compare the number of current cases with the usual baseline data. What was your previous data? What is the data in your locality, your community, your state or nation, whatever it is? Just have to check that, you have to confirm it. Next question I threw is, how do you confirm existence of an outbreak? How do you confirm the existence of an outbreak? The answer to this, check if any new techniques or new technicians or laboratory tests are introduced or not. You confirm it. Because it should not be declared as pseudo-outbreak. Third question, inform the key stakeholders. Very, very important. Don't just sit idle there only and think you're doing a great research and all. You have to involve the higher authorities in your hospital setup and also the public health authorities, because if it's an outbreak you don't involve, you will be sued and in the court of law. Fourth, identify the cases and collect information. How do you do this? You just have to define your cases first based on the population risk, what age groups, which sex they will belong, because you can publish a data later on, females or males, and which ages this outbreak is very common. Is there a pattern that is happening? We have to look at this pattern, and low socioeconomic status or high or middle class, because Corona didn't know who is Khalil and who is from where and what. It doesn't know any caste, creed, religion, age or not. It didn't spare anybody. So clinical data, when did the signs, symptoms occurred, and your frequency, duration of clinical illness, all these have to be collected. So it's a very meticulous work, very tremendous work and cumbersome work. The team has to roll down each and every area, corner, the surveillance data has to be collected to report, to analyze, talk with the epidemiologists and all. Search for other cases that may have occurred retrospectively. You have to collect data. Retrospectively, you have to go from laboratory reports, which is a good source. A medical record section, you have to go there at MRD department, take out the case sheets and your patient's charts. Physicians and nursing staff, you got to talk to them. You got to talk to them, who are the patients here admitted and all. Right. It's a very important chart that you have to prepare. You have to analyze each and every patient data. This is again available free of cost. Just Google it and you can just go to CDC website and you can download these charts, or you can prepare your own custom-made hospital charts over there. Hospital outbreak investigation abstract form. Each and every data has to be entered. Software is also there. Hard copies also can be, printouts can be taken, or you can customize your outbreak investigation form to know the data of each and every patient in detail, which is called line listing, in fact. This is a very important slide of my talk. Line listing is what is the backbone where you collect the patient's data and enter them in rows and columns. And as you can see over here, you have the ID of the patient, the diagnosis, which town he's from, age groups, sex, hospital, admitted or not, OP, IP, what was the clinical symptoms, outbreaks, IV drugs, what the drugs were given, what was the passive vaccination given, and what are the liver biochemical tests all. So all this, every spreadsheet with rows and columns of each and every patient's information over here. Right, calculate the rates. You just have to put the numerator and denominator. Number of new cases occurring in population during a specified time by number of patients who have been exposed to the risk of developing the disease. You just have to enter the, once you do the line listing, you will get the figures. You enter it, you get the incidence rate. You enter this, you get the attack rate also. Number of people who are infected by number of people who were at risk. So this will really come to almost a conclusion of what exactly has happened in your outbreak. Why some outbreaks end? How do you know that outbreaks have end? COVID-19 is end or not? WHO has declared 1 month back, no more COVID. No need to wear social mask. No need to wear social distance or wear a mask or all these things. We are back to a normalcy. Okay? So there's no more susceptible individuals. I mean, it might be that we don't know, but we are not susceptible. Because why? Everybody has exposed. Everyone has been exposed. So no more susceptible cases. 2, no more exposure to the source, because we have almost done whatever we have to the limit. No more source of contamination. So everybody now has learned how important hand hygiene, not only for himself, but also for take care of the surroundings. I mean, it has taught a lot actually. The good side of COVID-19, if you ask me, the good side is family gatherings were there. Everybody acclimated at the dining table. I mean, everybody avoided gatherings, shoppings and partying and all. They were back to that normalcy. People understood how important hygiene is, how important it is also to keep the surroundings clean. And your cough ethics of your personal cleanliness this is all what COVID-19 taught us. Then decrease their susceptibility. Individuals decrease because people have started getting immunized. People have got infection, they developed antibodies in their body. Okay, no more reinfection cases. Pathogen becomes less pathogenic because it has traveled through so many human beings. It has got either mutated or it has got attenuated. Like the virus which was in first attack, second attack, third attack, now people are hardly having or not, we don't know, hardly 1 or 2 cases might be somewhere at the nook and corner and somewhere. If you just talk, what are you talking, they said. I mean, talk something newer. So it's hardly any cases are there. Yeah, one good experience, 1 or 2 experience. How much time I have? 5 minutes is a good time, so I'm on knock. One good experience I would talk from my hospital in one of the where I work. Same thing which I shared with you, I was getting same organisms being isolated from the please listen, from the samples being sent from the same unit. When I just went and out of interest and passion talked to the neonatologist and said, this is happening, I mean, do you really think I mean, I'm worried. Same organism with the same antibiotic pattern and 5 samples, 5 staff for his. How it could be possible, I said. And all are MRSs. But they were like, then they woke up. No, we are not suspecting something like that. But you are sending reports and say, yeah, now he checked and said he was surprised. Then we did a cross-check and we collected samples from everybody. I mean, everybody, we worked as a team. The CO was informed. I mean, all these steps. Because normally I preach what I practice. I believe in that concept. So even the CEO had come, stand in a line, gave his nasal swab for screening of MRSA. I really appreciate that. I mean, that's good that you have to build that trust and bond. So everybody was screened and yeah, we could find a lot of people, nurses, diamas, housekeeping staff, patient attendants also, we called them, who carried this. I mean, there might be some carriers of MRSA, we didn't knew that. So they were screened and yeah, we isolated MRSA, we have reported, we did some data, we did line listing, and we started this treatment of advising them to stay away from the workplace. They were given leaves, they were kept in isolation, and they were reviewed only after they were clear of MRSA. We again did a recheck on them, nasal swabs, and to my surprisingly, even doctors were carrying MRSA, which they agreed totally, I mean, neonatologists. And even it was a good eye-opening for all of us to twice a day mupiracin for 1 week. Then we checked it again. Till they were free of MRSA, they were again come back to the jobs. But actually, really seeing in Western countries and hospitals which are JSI accredited, it is said that after your MRSA treatment, 72 hours, then 24 hours post-treatment, the vancomycin levels, therapeutic levels of vancomycin should be below the normal. And when you do an MEC gene, PCR, it should be negative. Then only the patient can be called back for the job. But in our setup, I don't know I don't know if we can afford that or not, but we did screening, swabs and all, they were found free of MRSA, they were asked to come back. So this is one good experience which we had. I can just share you with the live pictures which I could procure from the OBG, because OBG people also come down, because it's an NICU case, in-house deliveries and all. So those people also came down and we checked. And as you can see, almost all doctors are also here. Nobody was there. Then he is the CEO of the hospital. Then we had the OBG department. they had cons actually, and 2 people from OBG, they had catalase, coagulase positive. They were actually wanted the sensitivity pattern also. They wanted to see, and they thought, why don't you put antibiotic sensitivity to those swabs, those staph aureus which grew, and to my surprisingly, it matched the same which we reported for the patients. So that is one thing. Yeah, this was finally the report which was given, signed by me, and swab collected and all grew so-and-so's organism. There's another, how much time we have? 2 minutes, 1 minute? 1 minute. I'll keep the take-home message back, which is not important. Experience is very important. There was one more very reputed hospital in Tamil Nadu, I don't want to name, third most prestigious in India. I think you might have guessed already which hospital is. Third or fourth rank in Tamil Nadu. There was a transplant surgeon who said when infection control team went to them, what are you doing here, sir? We are from the infection control team and we want to do this. Get lost. There's no infection in my transplant unit and all since years. What people you'll do and all. So after 2-3 months, good surgeon, ultimate setup, lot of lakhs of money was spent. 3 months back, people were treated, they went back, suddenly they developed fever, they came back, and they died. Then he woke up. I mean, 1 death, 2 deaths, 3 deaths. I mean, surprisingly, everything was going good, and he came back, and the infection control team was brought in. They surveyed, they do surveillance, they got all the attenders, patients. Finally, it was found that, you won't believe, you won't guess it also, the ultrasound gel, which was used during the ultrasound scanning, was contaminated with Burkholderia cepacia in one of the patients when they cross-checked. And this was reported by infection control room. Then he had to stand up and salute the infection control room, the transplant. These are lessons which we can teach those adamant people and all. There was one more experience, but later on in the tea break and lunch break we can have. So the carry-home messages are, do not ignore or hide outbreaks, respond to the early warning signals, be quick and try to form a team, try to talk among yourself, lay down the guidelines, do a data, do a research work, try to control, learn about the disease, good steps and effective techniques. Clear recommendations should be formulated to prevent further transmission. Finally, at the end of each infection control prevention team, I think everybody should have this slide of hand hygiene, which is very cost effective, very simple, 30 to 40 seconds will save a lot of lives by preventing and a lot of cross infections. Thank you very much.
Thank you, sir. Thank you for equipping us with knowledge and tools necessary to handle hospital outbreaks effectively. With this, I would like to invite on stage Dr. Shilpa Pradhan ma'am, Associate Professor, Department of Microbiology, to introduce the next speaker for the event, Dr. R.C. Biloria, Consultant Microbiologist and Infection Control Officer, Lotus Hospitals for Women and Children, Hyderabad.
Thank you. To introduce our prominent speaker, Dr. R.C. Biloria ma'am. Ma'am did her bachelor's at Al-Amin Medical College, Bijapur, and she did her post-graduation in SVS Medical College, Mehboob-Nagar. Ma'am got a gold medal in 2013 in her batch at NTR University, Vijayawada. Ma'am is a certified NABL auditor and QMS as per ISO 15189:2012. She is a certified NABH assessor and an NABH internal auditor and QMS 4th edition. She is a certified infection control practitioner, JIPMER Pondicherry. She is a life member and faculty for KAHO for basic and advanced certified professionals in the hospital infection control. Ma'am is a faculty and trainer for Dr. Reddy's Foundation for Health Education. She is a certified auditor for CSSD by ACE at KAHO and 3M. She is an assessor for NITI Aayog project for government district hospital assessments, and she is a key opinion leader for SANMED Healthcare. Ma'am has stood first in the microbiology at NTR University in 2030 batch, and she is awarded as HIC champion for implementing the best infection control practices in private sector by JIPMER Pondicherry in 2020. She received an award for implementing the best CSSD practices for Sunshine Hospitals, Gachibowli, Hyderabad in April 2022. Ma'am is currently working as Infection Control Officer and Consultant Microbiologist at Lotus Hospital for Women and Children, and previously she was working in Ramzan Hospital. Ma'am was a guest speaker in various national conferences, workshops conducted throughout our country. Ma'am is affiliated member of Telangana Medical Association. She is a member of Andhra Pradesh Medical Council, life member of Indian Association of Medical Microbiologists and TAPC chapter also, and ma'am is a life member of KAHO organization also. So let us all welcome Dr. R.C. Biloria ma'am to deliver her lecture on Hospital Infection Control Committee structure, function and its responsibilities. Thank you. Please welcome ma'am.
Can I hear a warm good morning from you as well? Yes, thank you so much. At the very outset, I would like to thank Dr. Bilal and the whole organizing committee to give me this chance to stand in front of you to express my views. Thank you to the introducer for giving a great introduction for me. So without any further delay, I would like to start my topic which I was given is that to do any work, first of all, we need to have a team, right? To have this program here, definitely there was a long list of team members there, and I can see it has come out very well with the good team efforts which you have put. So, to start with anything, any program, we need to have a coordinated team members, right? Do you agree with me? Yes? Yes, okay. Okay, so to begin with, as Dr. Khalil has talked about hospital infection control, a very detailed aspect of something which comes at the end of a hospital infection control preventionist. That is, I think before the COVID start, none of us knew about the outbreak management. Thanks to COVID pandemic, now most of the people know about, and our job is very much simplified. But that used to be our job responsibility at the end. Last job responsibility was the outbreak management, because none of us knew about that. To start with, do you feel that hospital infection control is important? Yes or no? Yes. So, yes, it's a loud yes, but what I feel, working in so many hospitals, going to so many organizations, the answer majority of the people give is no. What Dr. Khalil said at the last example, what did the transplant head say? Please go out. We don't need you. Yes? This is the answer we get most of the time. We are the people who stand backstage to give safety to the patients and to the healthcare workers. So what I feel, the most of the time the answer comes no, but where the responsibility comes, where the importance comes, is when everyone gets a panic attack. When do they get that? One example is given by the sir only, when they get an outbreak, or they have a hospital-acquired infection, maybe a CORTI, there is a VAP, there is an SSI, or there is a needle stick injury, or there is needle stick injury, especially with a blood-borne virus-positive patient. So they rush to see where is an infection control preventionist. When there is an outbreak because of very bad pest control, right? So most of the time, the infection control people are remembered when there is a panic attack. This is what answer I feel after going to so many places, what I feel. But after this session, I want you to to be in a position to say and give this message everywhere that infection control is important from the base, from the plinth. You being a healthcare worker, whether you are a doctor, you are a nurse, you are a lab technician, anyway, how many doctors do we have here? Hands up. Okay, nurses? No nurses. Okay, students, medical students? Okay, many of you. So now you are stepping into a healthcare profession, or doctors are there. So the primary aim is what? We have taken an oath that primum non nocere, that we will not do the sick any harm. The person who has come to our hospital, we will not give an extra burden to him. We will not give any further infection to him. That is our oath. Okay. So hospital infection control is basically thought of being a department which is for the safety of the patient? I say no. It is for the safety of the patient, wherein we take care of majority of the hospital-acquired infections, yes, but to add to it, there are so many lawsuits nowadays. People are so aware of everything. Before a patient comes to you, he has Googled everything, right? Before he enters into a cabin, he has Googled everything, what all symptoms he has, what are the provisional diagnosis. They are so much aware through the social media, WhatsApp University, that they can sue us, sue the hospital for giving them any hospital-acquired infection or any mortality or morbidity because of that. So we need to take care of proper documentation through our HIC committees to take care of those lawsuits. And to remember, at the starting only, please, doctors, be aware, please counsel the patient about the present infections. I in my hospital have developed a protocol that whichever patient comes with a catheter or a ventilator who is shifted from other hospital, or is a post-surgery patient, or is on a central line, I take cultures in the emergency, so that I distinguish the infections which the patient is carrying from the other hospital to our hospital, so that we do not get confused after 48 hours whether this is our infection or this is patient's own infection from the other hospital, right? So we become more confident. Now, I was telling it's not about the patient safety only. It is HIC works for the healthcare workers. How? We think about the occupational exposures. It's a completely whole topic. We screen them, we give, at the time of joining, we give annual health checkups, and we definitely look strictly about the immunization protocols, especially for the hepatitis B. So don't ever think that hospital infection control is just for the safety of the patient. When we go on rounds, everyone gets afraid that they have come, these people have come just to bring us down, just to pull us down. No, it is for your safety as well. Okay, so it's not my guidelines, it's not your guidelines. What global strategies has given by the World Health Organization, that infection control program is a health system strengthening to deliver high quality care and improve patient and healthcare safety, both patient and healthcare safety. So whatever I will be talking, and if you need to do anything in infection control, please do not follow any guidelines left and right. Please, I always recommend to go with CDC or WHO guidelines, or if we talk about Indian scenarios, because many scenarios are like that we cannot follow Western guidelines, because ours is a developing country, our scenarios are different, our infections are different. Please go through NCDC guidelines and ICMR guidelines, so that you become confident in whatever you say. Okay, coming to the importance, now I must say that one organization which has given extreme importance to infection control preventionists and infection control department is NABH. People think about us, people call us, people want our advice only when there are NABH accreditations, or they want their hospitals to get NABH accredited. Let it be. I say let it be. At least at some level, they are coming up to the guidelines, they are improving the standards. So I feel this organization has given lot of importance, and many guidelines are being given through NABH. So this NABH 5th edition has many protocols which deeply teach us how infection control is important. So to start with, see there is a complete one chapter on infection control, chapter number 5 in 5th edition. On the first HIC element, the standard is the organization has comprehensive or coordinated infection prevention and control program aimed at reducing or eliminating risk to the patients, visitors, providers of care and community. Can you see the whole definition what I was telling you? It is not only about the patient safety, it involves also the visitors and the healthcare workers. So there is a complete one standard, and that too first standard, that we should have first a team and a program. Okay. So now coming to forming a team. So the ultimate aim of this team is what? It should make the healthcare safe. But let me tell you, it is a multiple task activity. One person cannot do it. One boss also cannot do it. Multiple partners, multidisciplinary team approaches with multimodal strategies. We have to gel up. We have to close the puzzles which are set apart to make a team. Okay? So, to coming to the main topic now, this is the team member, ideal design, because it can be different for all the organizations, but the core members are this. So, it heads by a CEO or a medical superintendent. He will be the chairperson of the committee. Then, HOD microbiology or a senior ID physician will be the member secretary. These two will be from the management side. Infection control officer will be the convener. Heads of all the main departments. Please make it a point that please do not make your HIC committee meetings just within 4 or 5 people. Involve all the departments. Then only your implementation of the whatever policies you make will be fruitful. Otherwise, they will say, when you start implementing the policy, they'll say, we are not aware of it. Who told us? You cannot make policies at your end and then expect us to follow them. So it should not be like that. It should not be a one-way process. It should be a two-way process. Take consensus from them. They don't get offended. Believe me, they don't. Once you involve them, yes, difficulty will be involving them. But once they are in the process, they will follow it. Then, infection control nurse, very, very important. Nursing head, CSSD in charge, housekeeping in charge, and quality manager. Then, as per your agenda, what is the agenda of the meeting, you have to call the different invitees. For example, there is an outbreak in your hospital, so the attendees will be different. Some other pest control problem, attendees will be different. So depending upon your agenda, your invitees, apart from these 8 people, will be different. Okay? Now, so what are the main functions of this team? The main function is, as I said, surveillance of hospital-acquired infection. Okay? Then education and training. Until and unless you do not educate like what you have done now, you will not train them. It's a common saying that if your mind is not knowledge, it doesn't know anything, elephants pass by. Even a big, huge elephant passes by, if you don't know it's an elephant, you will not recognize. But if your mind knows this is a rat, just in a blink of your eye, you'll say a rat passed by, because your mind knows that this is a rat. If you don't know an elephant, such a big elephant will just pass by your eye. So the importance of training and education is very important. Then ICRA. I don't know, this is a huge, there is a, I think 1 hour lecture for ICRA, but it is a very important element. That's why I have kept it in the core functions of the HIC committee. It is infection control, risk assessment and risk management. I'll just talk a little bit about it later. Then outbreak management, sir has told it very vastly. Antimicrobial stewardship plan. This is, as outbreak management, this was the last job responsibility which I still feel many of the hospitals are lagging. But thanks to the government of India, it has made it one of the major quality indicators now, presently. Staff health, very important. We have to scrutinize them. We at the joining, then annual health checkup, then their immunization. Support and guidance to the supportive department. Which supportive department? HIC is not one-man show. You have to take housekeeping with you. You have to take CSSD with you. You have to take nursing department with you. You have to take biomedical department with you. You have to take even maintenance department with you for water quality, for AC maintenance. There are so many infections which gets transferred by water if it is not correct. If the AC is not properly cleaned, so there can be an outbreak, especially there can be an outbreak of an SSI if your theater environment is not good. So maintenance department also comes under HIC. So then preparing a manual and a HIC meeting, conducting HIC meeting and bulletin. What do you mean by bulletin? Bulletin, what I do is that whatever activities I do in my hospital in 1 month, I prepare a bulletin, a report from my desk every month end, and within the first week of the second month, it is rotated to all the stakeholders so that they get to know that what all activities are being done by HIC and what all is happening in the hospital. So that is important, that your stakeholders should know that what is happening in your hospital. You are doing some work, you're keeping it with you. That doesn't help. You have to do the work and show the people that this is happening in your hospital so that they get to know what is the importance of your work. Risk assessment, I wanted to talk little because it's a very important role. Everything, whatever activities, all your hospital, throughout your hospital is happening. Whatever surgeries are happening, whatever procedures are happening, what new department is opening, what new people you have hired, you have to do risk assessment through this matrix. You have to see what is the risk, for example, of you started a new heart surgery procedure in your hospital, so you have to see what is the risk of infection in that category and likelihood, very unlikely, unlikely, possible, likely way, and severity. If it happens, what will be the severity of that infection? And if it falls in this matrix of red blocks, then you need to take very strict infection control practice. You have to be very vigilant with those kind of surgeries, procedures, activities. If it falls in this red, this is called as risk assessment matrix. Very important class. It is a complete new class. If I take, it is a 1 hour class. Just to have an idea of it, I wanted to share this slide. Okay, who is this person? When Mr. Chairman sees your message, what does he do? He doesn't? What's it written? He doesn't? Does it happen? Yes. This is what I say, a chairperson, top of the list, should be a person from the closest to the management. I say if you can involve directly from the management only. In my hospital, directly the owner of the hospital, I have made the chairperson of the HIC. Whatever I say, they'll follow. Because he has the pain of the hospital. He doesn't want his hospital to go down because of any hospital-acquired infection. I don't want a chairperson or any person, if you are sending a message to him and he does not respond, that person cannot be your chairperson. You have to make him feel that this chairperson, this post has been given for you to be responsible, for you to respond at proper time and give us proper provision. So what he has to do is establish an HIC team. He has to take a forefront and say that let us make an HIC team. Then what is the safety program? What we will do in this year? What is our plan of action for this year? Promote all educational and training activities like this. This has to be taken by the chairman. Okay? Then adequate resources and infrastructure and human resources. Very important. If the chairperson management does not give salary to an infection control officer, adequate number of infection control nurses, where does the infection control happen? That comes from the chairman. Okay? Not proper PPE, no good quality PPE. Worst quality PPE given by the purchase department. No quality check done by the HIC department. Why? This has to come from the chairperson. Approve and review the policies. Infection control officer will show the policies, he has to approve it. He cannot show at the time of an ABH that you did the policy, I simply signed it. No, no. It is his responsibility to approve and review the policies and establish an antimicrobial stewardship plan. I say that clinical microbiologist cannot talk that boldly because he feels that he's a non-clinical person, cannot talk that well to the clinician, they will not listen. But when a chairperson tells them, no, these are our policies, they have to be followed 100%, and if you do not follow, I will do this, loss of pay, loss of attendance, anything. It comes from a proper person, then the effect will be more. Now, so when I said about HIC committee, there are n number of people in it. But those n number of people do not work together every day. There is a team, which we called HIC team. These coordinate for the day-to-day functions every day. These are very few people, maybe an infection control nurse and an officer, quality person, and someone who is like a hospital admin who gives us some monetary benefits every day. A microbiologist may be your infection control person, and a microbiologist may overlap. And an environmental screening person means your housekeeping person. So these are the 4 to 5 people who every day report to each other. They are called as infection control team. This is not a committee. This team will meet each other every day and discuss what were today's activities, what we need to do tomorrow. Okay? So then only they can coordinate with the others depending upon the complaints. Now, who is this person? If everyone could stop spreading germs, that would be great. Who can say this to everyone all the time? You feel. All the time he keeps on saying this in hospital. Any guesses? Wake up. Who can say this? Please stop spreading germs. Please wash your hands. Please don't do this. Please don't do that. Sorry? ICO. Right. What is this symbol? What symbol is this? What symbol is this? Biohazard symbol. I feel this biohazard symbol should be put on infection control officer's head. Everyone is afraid of ICO. Enemy, worst enemy. But what I say to my infection control team, that when you are in hospital, you cannot be everyone's friend. Infection control cannot be everyone's friend. If you are worst enemies to them, in hospital, your infection control program is successful. Outside hospital, you please do friendship, you do whatever you want, but we have to be the worst enemies to them to do our job. It's just our job responsibility. That's it. Okay, so who is this person? ICO. He is a person who has a clinical and knowledge of diagnostic microbiology. Please, microbiologists, come out of your labs. Please, come out of your labs and reporting. Go to the clinical departments. Talk to the clinicians. Give them the rapport of, so that they can call you and tell you that what is happening. So that, what happens with that we get the first report. When the clinician directly calls you, you are the first person to be intimated. But first, we have a barrier in between clinicians and they say, they don't call. We say, they don't call. Who can break the ice? I say, you break the ice. What is there? You call. Anytime when you have any report which is of a particular consultant, call him. Say, this is so and patient is there. What can we do? That will break the ice between a clinician and a microbiologist. Be a clinical microbiologist. So this ICO has to be a clinical microbiologist. He should have knowledge in infectious disease, hospital epidemiology, yes, and surveillance and disinfection and sterilization. And now new addition of also antimicrobial stewardship program. All this knowledge he should have. He can be a microbiologist, he can be an IID specialist, he can be a general medicine specialist, anyone. So requirement is 1 ICO per 1,000 beds, but I feel as per NABH, 100 beds, 1 ICO is needed, okay? So majority is the same, what chairperson responsibilities, but he will just order. Chairperson has to initiate. What ICO has to do, he has to implement. He is the person who has to make it sure chairperson has given the orders. Those orders doesn't have to be on the paper. They have to be implemented, everything. Implemented and heading. He has to head everything. Head an outbreak management, head an HI surveillance, head an audit. Go to the, plan the audits, department-wise audit. Plan them so that people get to know that these people are coming. ICNs are coming, audits are happening. Some person is looking at us. ऊपर वाला देख रहा है CCTV camera, like that we should be. Okay? Then we should ensure, he should ensure the immunization. Vaccine is there in the stores, but it's not been given. It is the responsibility of ICO, AMR surveillance, antimicrobial resistance surveillance, okay? Then annual budget, that is important. He has to sit with the chairperson and tell him that last year this was the budget that was not sufficient for implementing a perfect infection control program. We need a hike of this much, okay? So he is the correct person to tell what quality PPE is needed, what quality hand rubs are needed, what quality disinfectants are needed. Purchase person doesn't have this knowledge. Purchase person should not be empowered with that. ICO is the correct person to see what is the quality of your various things which are being used in an infection control department. Then periodic HIC manual has to be reviewed by him. What are the updated guidelines? He has to review those things. Formulates the policies, and being the nodal officer of a needle stick in any occupational injury, his number should be displayed. He should be the preferably, we don't keep because he cannot be all the time present in the hospital, but he should be the nodal officer of a needle. Infection control nurse, I pity them. I really pity them. My infection control nurse, I feel they should be empowered. They should be empowered to do the wonderful job they are doing. So, I call them, this is my terminology, I call my nurses my eyes and ears. I sitting in one cabin doing periodic audits, I do go for audits, but they do. It is their responsibility to get every minute information from the nook and corner of the hospital and tell me, madam, this is happening here, this is happening here, this is happening there. And this training I give them on the induction. You have to be my eyes and ears, otherwise you are not being hired. If you are not loyal to me, I cannot take you. Okay, so what is there? They should be having additional, apart from being a nurse, they should be having academic and practical training in infection control, and at the time of hiring, they should be undergoing a competency test. Just don't hire them for being a nurse and they show you some infection control training. No. Depending upon their knowledge, how they efficaciously they can talk to people, what is their practical implementation of the knowledge they are having. So do their competency and periodic checkup. Regarding the requirement, 1 per 100 bedded hospital is enough, which I feel still it is deficient. So what they are doing, they will be doing hospital rounds, eyes and ears, then implement the HIC activities. They see whether these HIC activities which has been written in the HIC manual, are they being done properly? Data collection, hand hygiene audits, PPE audits, care bundle audits, HAI surveillance, because they go every day to every patient. I tell my nurse to start the rounds from the high-risk areas. Okay. So then provide immunization. Practically, it should be responsibility of the ICM to give the immunization. Then impart training sessions. I make the calendar, she gives the training. 6 months, 4 months once, I also take the class. Like that it should be. Reports to ICU, major responsibility. Every day with the register what all she has seen in the hospital. Then this is a new term, but very important. I have taken this from the Journal of Patient Safety and Infection Control, wherein the subject was, the title was Link Nursing Program in Indian Hospitals. Are we overlooking the low-hanging fruits in infection control? What do you mean by low-hanging fruits? Low-hanging fruits from the tree, the fruits which are just hanging below, they are easy to pick to eat. So they have told that this is one of the low-hanging fruit. Usually we say this term in antimicrobial stewardship plan. But here, they are saying that we can utilize all the nurses, select different nurses from different departments, so that, because ICN cannot be everywhere all the time. So we have to empower these nurses, train these nurses so that they give us proper information. This link nurse in between the infection control team and all of the hospital, clinicians, rest of the nurses, housekeeping department, they become our spies. In my hospital, I have not declared who are my infection control nurses. I have not declared them. Because if I say, all the data will be biased. That team is my team. That is my spy team. So that is how we can develop a bigger team. Okay? Then, what are the hurdles for this? 3 hurdles which I felt in my hospital is adequate training, because they are very busy. We cannot give them extra burden, call them for training. It becomes little difficult. If we can overcome, then it is marvelous. Lack of recognition, because I have kept them under the cover. So there is de-recognition of their role. They do not get extra payment. They don't get extra benefits of that because they are under the cover. So they become little hesitant to do that work. And bias, because that nurse is of that particular department. So she does not give proper data sometimes. If we have not developed confidence in her, she will not give you the proper data. So there is bias in their observation. They may say that my department should come best in hand hygiene audit. So they can give biased data. If we need to overcome that by counseling them. Infection control lab technician. Very few hospitals have this. If it is a large hospital where a lot of samples come, I say that you should have a separate lab technician who can do water surveillance, endotoxin, blood-borne viral screening, MRSA and MDRO screening, and disinfectant testing. But most of the hospitals don't have it. Last is, how do you plan your HI? You have done so much of work. Everything is there. HIC committee is there, team is there, everything is there. I said it has to go to the stakeholders. You have to upgrade your plan every time. So HIC meetings are very important. All the committee has to meet not less than once in a month. Not less than once in a month. It becomes stale. Then a circular has to be put 1 week before so that we want all the committee members to be present for that meeting. It should not be a sudden program. A reminder on the day of the meeting, and then on the circular, you should have an agenda. What are you going to see? Everyone speaking, he's speaking, no results. You should have an agenda that we are going to speak on this problem because this was seen throughout the month, that this was a recurrent problem regarding to the IPC practices in the hospital. Then what is extra is review of old minutes of meeting. 2 things. What we will talk new and what happened to the things which we have talked in the last session. What happened? What is the progress on that? Then all those points which have been discussed in the meeting have to be put in minutes, points of discussion like this. It should have these columns. What are the points of discussion? Plan of action, what is the target date, and who is the responsible person to do that activity. It should not be just as a paras. It should be in 4 columns showing that what did we discuss, who is the responsible person to do that action, what is the action plan, and what is the target date. Then we can follow it up. Then minutes of meeting has to be circulated to the stakeholders. Don't keep it in your files. Just to say to NABS that we have done HIC meeting, this is the last slide, that we have done the meeting. No, it has to be implemented, right? What does this picture tell you? Can you tell me one word? What does this picture tell you? One word. Yes, please. This is the last slide. I want one word for this picture. One word. Sorry? Leadership. Then? Sorry? Teamwork. One more. Support. Then? Direction. Then? All interconnected word. Very good. It is empowerment. You have made a team. Until and unless you do not empower your ICO to give those orders, ICO does not empower her nurse to do that role, no one will listen to you. My chairperson in HIC committee meeting, when I say something in my first HIC committee meeting, I said so many problems are there. At the closing statement, he said, if you do not listen to Dr. RC, what she has said, I will break your knees with the hammer. It was very rough, right? But what happened? This is in 2015 I'm telling. What did he say? He's the owner of the hospital. That is called empowerment. He gave me the empowerment to say, now everyone in the hospital says whatever she says we have to do. I empowered my ICN. If she is saying something, you have to listen. If you do not, loss of pay. If you do, you have chocolates, you have appraisals. Do two-way. You cannot always bring them down. You have to also, we have an HIC champion award every month, hand hygiene champion every month, each best hand hygiene department every month. Once we empower them, we give them applause, we have the other side also to bring them down if they are the chronic defaulters. That is empowerment. Everyone in specific role, everyone has to be empowered to become a proper HIC committee, and not to say HIC team. ICT team is very important because they are the core people who work together. Thank you so much for a very patient listen, my all healthcare heroes. Any questions are there? Please. Any questions regarding the topic? Any questions? Do you have an HIC team in your hospital? If you are, don't ask questions, I'll ask. Do you have an HIC committee? You have? All the hospitals? Yes. So please, one takeaway point from my side is, please empower them. Make your work visible to everyone. To everyone, to show infection control is not a backstage drama. We are backstage people, but we are working for the patient safety, for the upliftment of the hospital, for the better name of the hospital, so that we give proper care to the patient and safety of our healthcare workers. Thank you so much.
Promoting a culture of infection control in hospitals. Now I would request the audience to please be seated while we arrange the inaugural ceremony in 2 minutes. Thank you everyone for being patient. Now, for the inaugural session, I would like the audience to involve the Almighty. I request Janab Hafiz Maulana Samir Sahab to recite Qiraat.
Assalamu alaikum wa rahmatullahi wa barakatuh. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان. الشمس والقمر بحسبان والنجم والشجر يسجدان. والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تقصروا الميزان. والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان فبأي آلاء ربكما تكذبان. خلق الإنسان من صلصال كالفخار وخلق الجان من مارج من نار. فبأي آلاء ربكما تكذبان. صدق الله العظيم.
Shukriya Hafiz Saab. Now, I would like to request the volunteers to please escort the esteemed dignitaries onto the stage. Dr. Ali Raza Musfi sir, Honorable Vice Chancellor, Khaja Bandanawaz University. Sir, Professor Emeritus, KBN Teaching and General Hospital. Dr. Siddesh Sirvar sir, Dean, Faculty of Medical Sciences, Khaja Bandanawaz University. Dr. Siddhaling Shankti sir, Medical Superintendent, KBN Teaching and General Hospital. Dr. M.A. Basir sir, Professor in HOD, Department of Community Medicine and Director IQAC, KBN University. Thank you, sir. Now, I would like to request Dr. Siddesh Sirvar sir, Dean, Faculty of Medical Sciences, KBN University, and also the organizing chairman for today's conference to deliver the welcome speech.
A very good morning to all. It gives me an immense pleasure and utmost respect to welcome our Chief Patrons, His Holiness, Dr. Syed Shah Kushru Hussaini Sahib, Sajjad Nashin, Dargah Hazrat Khaja Bandanawaz, Honorable Chancellor Khaja Bandanawaz University and President Khaja Education Society. Sir has sent his best wishes and blessings to our CME. He was not able to make it due to Dargah Urs Sharif. And I also, with the deep sense of gratitude, I welcome Sayyid Muhammad Ali Hussaini Sahib, the Honorable Pro-Chancellor, Khaja Bandanawaz University, Vice President, Khaja Education Society, and I thank for his constant support and guidance for all our endeavors. It's my proud privilege to welcome our beloved director, Dr. Sayyid Mustafa Al Hussaini sir, Director Khaja Bandanawaz University, who is also not able to make it. I wholeheartedly welcome our patrons, Honorable Vice Chancellor, Professor Ali Raza Muswi sir, who is a constant source of motivation and inspiration for all the academic programs of our KBN University, who is a backbone for us and always encourages for such academic activities. You can see many visible changes, and also we have to see more changes in coming days. I am truly contented to welcome our patron, Professor Rukhsar Fatima Madam, Registered Khaja Bandanawaz University, and I thank for her constant support to all our programs. Even Madam was not able to make it. I am delighted to welcome our team of organizers, that is the organizing secretary, joint organizing secretaries, then organizing treasurers, and also the advisory committee members, our medical superintendent, Dr. Sidling Chengti, my mentor, Professor Shankar sir, Dr. Zama Muswi madam, heads of the department of surgery, Dr. Monidin sir, heads of the department, Dr. Vardhamane of pharmacology, heads of the department dermatology, Dr. Guru Prasad sir, head of the department medicine, Dr. Chandkala madam, and many more are there. So kindly pardon me if I am not able to take everybody's name. And I also welcome the postgraduates, interns, and all the delegates who have come from other parts and out of state and other colleges. I am also very glad to welcome our all the resource persons, the speakers who have arrived from far-off places to make this an academic feast. I welcome you all wholeheartedly for this first CME program, which we are organized from the Department of Microbiology in our college. And I also welcome the print and mass media for your wide coverage. And I once again welcome one and all. Thank you.
Thank you, sir. Now, to honor our patrons, I would like to request Dr. Siddesh Sirvar sir to present the bouquet and shawl to Dr. Ali Raza Muswi sir, Honorable Vice Chancellor, Khaja Bandanawaz University. Can we have a big round of applause? Thank you, sir. I request Dr. Mohammad Moinuddin sir, Professor and Head of the Department of General Surgery, to present the bouquet and shawl to Dr. P.A. Shankar sir, Professor Emeritus, KBN Teaching and General Hospital. Thank you, sir. I request Dr. Muhammad Ali Patel sir, Professor and Head of the Department of Dentistry, Faculty of Medical Sciences, to present a bouquet and shawl to Dr. Sidling Shenki Sir, Medical Superintendent, KBN Teaching and General Hospital. Thank you, sir. I request Dr. Nazir Ahmed Sir, Professor, Department of Anatomy, to present a bouquet and shawl to Dr. M.A. Basir Sir, Professor and HOD, Department of Community Medicine, and also the Director of IQAC, KBN University. Thank you, sir. I request Dr. Guru Prasad Sir, Professor and Head of the Department of Dermatology, to present a bouquet and a shawl to Dr. Siddesh Sirva Sir, Dean, Faculty of Medical Sciences, KBN University. Thank you, sir. Now we'll have the felicitation of our resource persons. I request Dr. Bilal Ahmed Mir Sir, Professor and in charge Head of the Department of Microbiology, to felicitate Dr. Muhammad Khalil Sir, Professor and HOD, Department of Microbiology, Mamta Institute of Medical Sciences, Hyderabad. Thank you, sir. I request Dr. Shilpa Pradhan Ma'am to felicitate Dr. R.C. Biloria Ma'am, Consultant Microbiologist, Lotus Hospitals for Women and Children, Hyderabad. Now I would request Dr. Javeria Firdaus Ma'am to felicitate Dr. Neelima Sudarshan Madam, Associate Professor, Department of Microbiology, Nizam's Institute of Medical Sciences, Hyderabad. Request Dr. Arshia Tazeen Ma'am to felicitate Dr. M. Rajeshwari Ma'am, Consultant Microbiologist, Aster CMI Hospitals, Bangalore. I request Dr. Baig Ahmed Sir, Professor and Head of the Department of Biochemistry, to felicitate Dr. Abdul Kaleem Bahadur Sir, Assistant Professor and also the Infection Control Officer of Rajiv Gandhi Institute of Medical Sciences, Raichur. Thank you, sir. Now, I request Dr. S.H. Vardhamani Sir, Professor and Head of the Department of Pharmacology, to felicitate Dr. Virendra Kashyati Sir, Professor, Ashwini Rural Medical College and Research Center, Sholapur. Thank you, sir. Now, I'd like to request Dr. Chandrakala Ma'am, Professor and Head of the Department of General Medicine, Faculty of Medical Sciences, to felicitate Dr. Nawaz Umar Ma'am, Professor and Head of the Department, Gulbarga Institute of Medical Sciences. Thank you, ma'am. I request Dr. Seher Ansari, sir, Professor and Head of the Department of Physiology, to felicitate Dr. Nagarkar Rajan, sir, Professor, ESIC, Kalaburagi. Thank you, sir. Now, we have a banner reveal for today's conference from the Department of Microbiology. To do this honor, I request Dr. Ali Raza Musvi, sir, Honorable Vice Chancellor, Keban University, to do the banner reveal. Sir. Can we have a big round of applause from the audience? Also request Dr. Ali Raza Musvi, sir, to please address the audience.
Very good morning to all of you. The experts who have joined us from various parts of the country, I mean, like from Telangana, Andhra, this state. This, I think, and you must tell me if I'm wrong, that this is one of the few CMEs that has been held in this college. I am very thankful to the Department of Microbiology and to the Dean who took this initiative. And as we try to build this university as an institution by involving people from outside, by opening up windows to other thoughts, other experts, because I think we learn a lot by learning from others. Professor Shankar, Professor Siddesh, Dr. Chengti, Professor Abdul Basir. We also have in the audience Professor Rajshri, who is the Dean Research of the University. Some of the members of our IQAC are here, the Internal Quality Assurance Cell. And of course, the experts who have taken time to be with us today. When I came in, I could only hear the tail end of what Dr. R.C. had to say about infection control. And I think that was a very pertinent speech. I'm sorry I missed Dr. Khalil. And I must also apologize in advance that I may not be here to hear the remaining speakers, not because I'm not interested, but because my office does not permit me to be away for a long time. So I will apologize if I leave after having some tea. We have some tea after? Thank you. and spending some time with all of you and leaving. Now, I am not a doctor, a medical doctor. This is the new world for me. Having spent 20 years in administration in many diverse universities like the English and Foreign Language University, the CUK here, some stints at NAC and the ministry. When I joined, I used to jokingly say that this hospital is a strange animal. I do not understand it. But it is a nearly 25-year-old institution. The only reason that I stand now and speak to you here is that, of course, the gracious invitation from the hosts, but apart from that, because I now share the responsibility of I would not like to use the word managing the hospital, but using it as an administrative unit, because the biggest difference between management and administration is that management is by objective, whereas administration is by rules. We are trained in the field where we believe that objectives are important, but the way we reach those objectives are also equally important. I have found 2 or 3 observations I would like to share here. The first is that when I was invited to speak here, I found out that I knew very little, scanty information about hospital infection control, and I even thought that, is that a real thing? It took me time to go and find out that yes, and then I came across some figures from the CDC which said that 1 in 30 deaths every month in the United States is due to a hospital infection. Unfortunately, I could not find the figures for India in this context. I don't know if it's higher or if it's lower, because we live in a tropical country, so we are born with bacteria, we grow up with them, we have a very healthy relationship with all these bacteria which surround us. But still, I'm sure that as far as the hospital is concerned, this is a big issue. And when I look back in the last 3-4 years, I have also started to hear, even among our own family and people whom we know, of people who frequently go to the hospital and catch some infection or the other. So it's proved that this is a real thing. Now, it is not a new thing, but it is something which demands our immediate attention. Something which demands that we take concrete, structured steps. Because you go to the hospital to get well, not to fall ill. So when we find that a visit to the hospital is equally, life-threatening, then we'll have to take steps. I think that the most initial and the basic step is proper hand hygiene. You'll have to keep your hands clean all the time, every member of the hospital, every staff member of the hospital. It sounds so simple, but the hospital is such a complex administrative structure. It caters to the needs of a highly intelligent or a highly educated doctor to an illiterate patient. How can one organization be tuned to deal with such a diverse range of people? Because I thought I'll speak only on as far as administrative structures are concerned, because that will make sense. I will not be able to give you any inputs or insights on what are the very effective ways of fighting hospital infection. For that, all of you are here, and I'm sure that you will provide the answers. But I believe that if you have a basic, very rigid protocol of hand sanitization, then isolation of patients who might be carrying communicable diseases. But, and here I would refer back to what Dr. R.C. was saying when I entered, training, orientation and training. I am happy to see that our hospital IMO is here, right? IMO, yeah, is here, and I would personally request the IMO who is here to spend a lot of attention and time here today, because being a teaching and general hospital, the first step I believe what we should take is that based on our inputs which we received today, we should come out with a very practical handbook. We should take it upon ourselves to also pass on this information in a structured way to so many clinics and hospitals which are in this town, in this city. Secondly, I think that we need to put in place a hospital advisory board or a hospital advisory committee. You can choose some of the experts who are here today call them over for at least once in 2 months, take their inputs, and not just to fill the files, but also to take action on them. We are in a time of change as far as this university is concerned. Change, as you know, is a very difficult process because ingrained cultural structures, attitudes, relationships exist. But change can happen only on one ground, that when you believe that change can happen, then change will happen. Change will not only happen because you are spending more money or you're building a new building or you are bringing in new blood. Change should be owned by the people and they should believe that we can change. I see this CME as one of the initial steps towards that direction where we believe that yes, we can make our hospital infection free. Let's believe in it. Even if it is not true for now, there's no harm in believing in that idea. Once we believe in that idea, then we start to implement it. Because we work only when we believe in things. If we don't believe in things, then we'll not work on them. I would not like to stand between the audience and the knowledge which has to flow. This was a formality, my being here, and I would like to take as less of your time as I can. I am confident and sure that throughout the day we will learn a lot from all of you. I am also confident and sure that the discussions will be fruitful, and I would encourage the audience after every expert speaks that you must ask questions, because unless you ask a question, you would not have understood. You will know a lot of things, but that would be information. Information translates into knowledge when you ask a question. So please ask questions. There are many students here, there are many of our own faculty here, and I would like to request the organizers that let there be a comprehensive report of what we have done this whole day, and let us also have a manual, a guideline, a manual which we can share with others, which we can also start to implement in the hospital. With these few words, I'd like to thank all of you. Thank you for being here. Thank you, Professor Siddesh, Dr. Bilal, for asking me to be here with you today, and I wish you all the very best. Thank you.
Thank you, sir. Thank you for your motivation for us to get better and better. Now, I'd like to request Dr. P.S. Shankar, sir, Professor Emeritus, KBN Teaching in General Hospital, to address the audience.
Professor Muswi, Honorable Vice Chancellor, Dr. Siddesh, Dr. Sidling, Dr. Bashir, staff and visiting faculty. The terminology we quite often use, CME program, and as we progress, the terminology has been changed to CPD, Continuous Professional Development. So this is an old terminology, CME. I request in future, people use the CPD, Continuous Professional Development. That's a proper terminology. And these programs, now today we are holding on the infection control. In any institution, the infection control, then the IQ-AC, the quality assurance, then the scientific committee, then the ethics committee, institutional committee. These are all very important committees in any institution. And this program is being held at a right time under the banner of our university. And the infection control is the key point in any institution, in any hospital. In very big hospitals, I have seen how this infection control program works so well. And for such programs, I request Bashir that we in Karnataka state, a lot of grants we give. Recently I was going through the applications for the Vision Group of Science and Technology, which is one of the unique organizations in the country, established under the chairmanship of the Professor C.N.R. Rao. We give a lot of money on various activities. One of that is organization of such programs for which 3 lakhs is being given. Many institutions apply for this. In addition, Karnataka State Science and Technology Academy also gives 1 lakh for such programs. Earlier, we had given through the Science Academy 3.5 lakhs to B.B. Roja College. So I request in future such programs when they are held, they can definitely make use. And I was going through the applications. Hardly for research we are giving a lot of grant, research activities. The amount varies from 6 lakhs to 60 lakhs. You can imagine the amount which we give. And there is only one institution in the whole of this Kalyan Karnataka area which made application this time. I was while going through, I found none of the institutions. I can recall only the institution in Bangalore, Mysore, Belagaum, and one institution in Kalaburagi. Barring them, no other place people had applied. Such a large amount we give and people are not utilizing. I request that in future, it requires a lot of preparation to apply, even make an application. And if you open the website of the VGST or the Vision, you can get, each year we call for applications. Lot of applications come, 3,000 applications. And they send for evaluation. And on base of then we interview, and then the grant is given. The amount is not small. Even people who make publications, they also get 25,000 rupees for best publications which they make, for which also is assessment made. So I request through this platform that our staff should make use of this particular opportunity. Bashir particularly I request to take this opportunity to make such applications. Even Karnataka Medical Council, which is given 2 points. So for a whole day program, 2 points are given, trade points. And we extend it. For 2 days, the number of points will increase. And half a day, only 1 point, so that people can make use of that one. So I wish this particular program all success. Thank you very much.
Thank you, sir. Thank you for enlightening us on how to conduct CPD programs better in the near future. Now, I'd like to request Dr. M.A. Basir, sir, Professor in HOD, Department of Community Medicine, and also the Director of IQAC KB University, to give the vote of thanks.
Good afternoon, everyone. Distinguished guests, esteemed speakers, participants, students, and all the ladies and gentlemen who are present here. On behalf of the organizing committee, it is my privilege to propose a heartfelt vote of thanks on this remarkable hospital infection control, CME. To begin with, His Holiness, Janab Sayyid Shah Khusro Hussaini Sahib, Sajjada Nashin, Dargah Hazrat, Bargah Khaja Bandanawaz Rahmatullah Alayh, His Excellency, Chancellor, Khaja Bandanawaz University, whose determination, which has been the driving force in setting up of Khaja Bandanawaz University. He left no stone unturned in fulfilling in the vision of his father, Janab Sayyid Shah Muhammad Al-Hussaini Sahib, our founder of Khaja Education Society. I would like to extend my heartfelt gratitude to Janab Sayyid Muhammad Ali Al-Hussaini Sahib, our Honorable Pro-Chancellor, Sir, of Khaja Bandanawaz University, for carry forwarding the same vision and enthusiasm of his father, our Chancellor, Sir. Also, Dr. Sayyid Mustafa Al-Hussaini Sahib, Director Khaja Bandanawaz University, whose passion and dedication to provide the university with remarkable opportunity for the progress. Our sincere gratitude goes to Professor Ali Raza Muswi, Sir, Honorable Vice Chancellor, Sir, of Khaja Bandanawaz University. Sir has always been supportive and motivating us to conduct more and more workshops, CMEs, and also the conferences, inshallah, in coming future days, which has been a remarkable achievement to the university, sir, so far. Thank you for supporting and guiding us. I would also like to thank Dr. Rukhsar Fatima, Registrar Madam, who is always accessible and always guided us in moving for the smooth conduction of the workshop. My special thanks to my sir, my dean, my Siddesh Sirwar sir, my inspiration. I am seeing him from my college days while pursuing my UGs. Thank you, sir, for guiding us from the day one of the workshop. I also thank to all the heads, faculties, staff, delegates, and also the other delegates who have come from other institutes We are very glad that we got the delegates from Raichur, from gyms, from ESIC, from other private nursing homes also who have come to attend this workshop. Lastly, I would like to thank my friend, Dr. Bilal. I have seen his tireless efforts, who is continuously working from past 1 month to getting the CMA at this stage. I also thank the administrative staff of KBN University and all the volunteers, members, and the event staff who have come here for the workshop and who helped us to organize the workshop. I also thank, lastly, all the resource person, all the 9 resource person who have come from different places, from Raichur, from Hyderabad. Thank you, ma'am. Thank you, sir. Thank you for coming from all the way and making this event successful. Thank you, one and all.
Request the volunteers to please escort the dignitaries for the tea break. And to the audience, we'll have a short tea break and we'll assemble again at 12 p.m. sharp to begin with the program. Welcome back, audience. Now to continue with today's event, I'd like to call upon Dr. Arshia Tazeen ma'am, Assistant Professor, Department of Microbiology, to introduce our speaker, Dr. Neelima Sudarshan ma'am, Associate Professor, Nizam's Institute of Medical Sciences, Hyderabad.
Good morning, everyone. I would like to introduce the next speaker for today's CME, Dr. Neelima Sudarshan ma'am, currently working as Associate Professor at Nizam's Institute of Medical Sciences, Hyderabad. She has completed her undergraduation and post-graduation from NTR University of Health Sciences. She has worked for 6 years in Medicity Institute of Medical Sciences. She is a PG and PhD guide with the academic experience of 12 years with 22 national and international publications. She has worked as principal investigator and co-investigator for many of the ICMR projects for bacteriology and mycology and RNTCP projects for tuberculosis. Ma'am has undergone research training program at Johns Hopkins Hospital, USA, mycology training program at PGI Chandigarh, and training at Institute of Genetics. She will be speaking today about surveillance and prevention of catheter-associated urinary tract infections, analysis and interpretation. Please welcome Dr. Neelima Sudarshan madam. Thank you.
Can we have a big round of applause from the audience, please?
Okay. Thanks for that wonderful introduction. A very good afternoon to all of you. Just let's move on to the topic. I'll be discussing about the surveillance of COTI. Can they settle down fast?
I request all the students, interns, postgraduates, and the faculty to please settle down so we can continue with our conference. The speaker is on the podium, waiting for you all to settle down.
I want the postgraduates to be active because the next slides, it is meant for you people. You need to answer a few questions. Shall I start?
Yes.
Okay. I'm not able to. Okay. Fine.
Can you all please quickly settle down?
Yeah, will be good. Okay. Now I can change the slide. It's logged there. Just move on to the next slide. Yeah, let us begin with the COTI. So this is one of the most common type of healthcare-associated infections, contributing to about 30% of the hospital-acquired infections. And about 5,60,000 nosocomial infections annually occur because of this COTI. It also contributes substantial increased morbidity and mortality, and also increasing the length of the hospital stay, in turn increasing the burden of the hospital, and because also it could be because of unnecessary antimicrobial usage. Yeah. I'm not able to change the slide. Now I can change? Yeah, thank you. So, urinary catheter usage itself, if you look at that, about 15 to 25% of the hospitalized patients are on catheters it's often placed for inappropriate indications without any proper indication. Physicians most of the times are unaware of this. And in a recent survey conducted in US, not in India, the statistics are from US hospitals, more than 50% did not monitor which patients were catheterized, and more than 75% did not monitor the duration of catheterization. So with that, we'll just move on to the pathogenesis of COTY. So what happens if there is a catheter insertion? Sorry, there's light. There is light, huh? Yeah, I got it. Okay. With the catheter insertion, it can be acting on the bladder wall, so with your defense mechanisms and the bacteria, it in turn can lead to biofilm formation, and these two mechanisms in turn will cause the urinary tract infection. These are the common routes of COTY. Mostly it could be extraluminal or intraluminal, and the sources being the endogenous or the exogenous. Mostly it could be the meatal or the vaginal colonization. So these are the risk factors for the COTY. Modifiable ones are those which are highlighted in red, like prolonged catheterization, disconnection of the drainage system, or improper training of insertion of the catheters. So I'll now next move on to the criteria. So what is catheter-associated urinary tract infection? SUT is nothing but symptomatic urinary tract infection. So you have three things. So one thing is the catheter criteria, second is the clinical criteria, and thirdly, microbiological criteria. If these three criteria are fulfilled, then you can categorize that case as a COTY. So catheter criteria, catheter should be, I don't want any disturbance, please. There's a lot of disturbance. Please maintain silence. If you're not interested, you can leave, but I don't want that disturbance. If catheter is in place, at least it should be there for more than 2 days, or if at all, on the date of event, at least 2 days, or at least 1 day before the date of event, if at all it is removed. And the clinical criteria would be fever, suprapubic tenderness, costovertebral angle tenderness, urgency, frequency, dysuria. This you cannot see with the COTY. The other UTI, you can have these complaints. And the microbiological criteria, at least the one organism with more than 10 parts 5 CFU per ml is reported, then your microbiological criteria is also satisfied. So once your catheter, clinical, and microbiological criteria is satisfied, you name the case as a COTY. So this is like based on the age. If it is less than 1 year of age, you have these clinical features like hypothermia, apnea, bradycardia, lethargy, or vomiting. Rest all will remain the same. This is asymptomatic bacteremic UTI. That means patient doesn't have symptom, but then you have a matching blood culture. Blood culture is also growing the same organism as it has grown in the urine. Now coming to the surveillance. So the key terms, I'll be going through these terms, like what is window period, date of event, hospital acquired infection, present on admission, event time frame. Just pay attention. Based on these definitions, there will be some questions where the postgraduates have to answer. So window period. What is the window period? So once the UTI case definition is met, as I already discussed, what are the criteria to qualify that as a case of UTI? So that should be met within a 7-day time frame called as window period. So how do you calculate this window period? So it indicates the date the first urine culture is collected and the 3 calendar days before that and after. So that together constitutes a 7-day window period. I have given an example. If on day 4 urine was collected, so 3 days before and 3 days after, that is how you calculate the window period. If symptoms, okay, before that I'll give you an example here. So microbiology lab calls you on 13 September to report that a urine culture collected from a patient in ICU on 12 September is growing Klebsiella pneumonia and E. coli. Here there are 2 organisms. As for the criteria, at least 2 organisms with 1 organism showing 10 power 5 CFU per ml will qualify the criteria. So this will fit into UTI criteria. So if so, what is the window period for this potential UTI? Can somebody quickly tell me? I can't wait much. What is the window period? You can just give me the dates. So on 13th, the urine was collected. So give me the dates, 7 days, 3 days before, 3 days after. Huh? 10 to 16. Okay, so 12th, 3 days before and 3 days after. Okay, 12th it was collected, 13th you got a call, 12th, that's why it is 9th to 15th, otherwise as you said 10 to 16. Okay, what is the date of event? Date of event is the date when the first element, we have seen all those 3 elements, when the first element used to meet the case definition occurs for the first time, that too within that window period. If the symptoms occur first, then you'll have to take that as the date of event, or if the urine sample was collected first, then that has to be taken as the date of event, whichever comes first, okay? I think I'm clear with the definitions, yes? Or there is confusion? So if you see this, in the previous example you have seen that urine was collected on 12th September, but patient complains of urine frequency on 10th September, suprapubic tenderness on 14th September, and he meets the UTI case definition. What is the date of event in this case? So you can see whichever comes first. So clinical symptom, he complains of frequency on 10th September. So what will be the date of event? Yeah, very good, 10th September. So whichever comes first. And it should be within that window period only. This all will help you when you do the surveillance. That's the reason why I'm going to this terminology. What is healthcare associated infection? So when the date of event is at least for more than 2 calendar days after the hospital admission, it's considered as HAI. What is present on admission? If it is less than 2 calendar days after hospital admission, then it's called as present on admission. There's one more term called as event time frame. So event time frame is nothing but, usually it is a 14-day time frame during which the UTI process is considered to be ongoing and no new UTIs are reported for one particular patient. So how do you calculate this event time frame? So you take it the date of event. The date of event is taken as the first day of event time frame. From that day onwards, 14 days you calculate, that becomes the event time frame. So if you look at this, already answer is here. Okay, the date of event was on 25th September. So if you calculate 14 days, it will be 8th October. So this period is the event time frame. During this period, whatever UTI, or if the organism is different, like for example, on 29th you got Klebsiella pneumoniae, on 5th you got Acinetto, but that is considered as one UTI episode only, though the organisms are different. So when you do the surveillance, this all terminology, make it clear. So this is not a one more episode, this is a single episode of UTI. Sorry. Okay. Coming to the inclusion criteria, I already said, so this is just the summary. Date of event should be more than 2 calendar days from the hospital admission, whether it is ICU or wherever you are conducting the surveillance, that unit, at least more than 2 days. Apart from this catheter criteria, which I already covered, so I'll just skip this slide. Just look at this example. So urinary catheter is in place for more than 2 calendar days. If you take this date of event, 21st October, so patient was on 19th as well as 20th. So when compared to date of event, 2 days earlier, he was already on catheter. So this will fit into catheter criteria or not? Do you consider this as COTI? Yes or no? Yeah. You can be a little loud. Okay, this is one example. Or when the catheter was removed just a day before the date of event. If you take this example, the date of event was on 6th November. Until 5th, patient was already on catheter for about 18 days and it was removed just 1 day before the date of event. In this case also, it will qualify catheter criteria. This also is considered as COTI. So 2 days before the date of event or the catheter removed just 1 day before the date of event. Both qualifies the catheter criteria. So you name this as COTI. Is this clear? Yeah. So I'm skipping this example. Now let us move on to the prevention. So what do you mean by bundle, first of all? Any idea, postgraduates? It's a group of intervention put together to bring down the, in case of this COTI rates. So that is called the bundle. So you have this, sorry, okay. So the prevention bundle, what all you include? Appropriate catheter use, proper insertion technique, maintenance technique, quality improvement programs, administrative infrastructure, and the surveillance. So always insert catheter only when there is a proper indication. Leave catheter in place only as long as needed, not just you'll put the catheter and forget about it. Ensure that only properly trained persons are putting the catheter. Insert using aseptic techniques. Following aseptic insertion, maintain a closed drainage system, unobstructed urine flow, follow your hand hygiene and standard precautions. So this is a long list of the indications where you are supposed to insert a catheter. So apart from these indications, you do not find unnecessarily they are inserting, please discourage the use of catheter. So I'm not going through this long list. I think you can just read it. Yeah. So prevention strategies we can classify as core prevention and supplemental prevention. Under core prevention, you have insertion practices, maintenance practices. So insert catheters only for the appropriate indications. Minimize the use in all patients, particularly those at higher risk of COTI. Avoid use just for the management of incontinence. Use catheters in operative patients only as long as it is necessary. Okay? And once post-operatively, remove the catheter as early as possible. So before that, also you need to select right catheter. The better one is always the smallest size catheter. So this is as per the age, the sizes. FR is nothing but French gauge. And you need to select the right type of catheter. These are the several types of catheters. Usually you go for an indwelling Foley's catheter, or if you're going for intermittent catheterization, you can go for a straight catheter. This is the other list of the catheters which you can use. And then coming to the technique, the proper insertion. So before that, you have to perform your hand hygiene before and after insertion. Only a trained person should do this. Use aseptic technique. So your standard precautions, sterile gloves, drapes, sponges, appropriate antiseptic or sterile solution should be available. Properly secure the catheter. Unless indicated, use smallest bore catheter. And perform intermittent catheterization if it is required. In such cases, at a regular intervals, it has to be done. So you have this a checklist. I think these are there freely available in the website, so you can just download and you can start using them to look at your insertion practices. Now coming to the maintenance, check whether catheter is secured, okay, and flow is unobstructed. Avoid the dependent loops. There should not be any kinking. Keep drainage bag just below the level of the bladder. Keep the bag off the floor. Empty the bag once it is less than 2/3. And use a separate containers for each individual patient, not a common container and keep on emptying the bags. So that will cause cross-contamination. Please stop that. Always try to maintain closed drainage system. Unobstructed urine flow should be there. Use standard precautions. Unless there is a clinical indication, do not use any antimicrobials to prevent COTI. Do not clean the periurethral area with antiseptics. Routine bladder irrigation with the antimicrobials is not recommended as of now. So this is the maintenance checklist. This is also freely downloadable. You can just have, or you can prepare your own checklist and start using it to see whether the insertion and maintenance practices are as per the criteria. So this a checklist for the urinary catheter, what all you can have. So whether appropriate indication is there, hand hygiene was performed, you can give the insertion techniques, catheter maintenance, catheter care and removal. And just give the checklist and you can just maintain this. So for the COTI, if you have to collect the urine sample, so how do you collect it? So obtain urine samples aseptically. Just a small volume is required for the culture. So you have to aspirate the urine from the needleless sampling port under aseptic precautions. And once the sample is collected, send the specimen promptly to the laboratory within 2 hours. So because you already know, most of the causative agent is Escherichia coli, the generation time is very less, so they rapidly multiply and you will not be able to know whether it is because of the infection or this colonization. So always transport it in a sterile container. If there is a delay in transport, you can use a preservative called boric acid. The rejection criteria, when you have to reject the sample, more than 2 hours without refrigeration. 24 hours urine sample is not for microbiology. Foley's catheter tips, you should not encourage, discourage, sample given from the bag, leaky containers, duplicate specimen. Just within 48 hours, you get one more urine sample for culture, you can straight away reject the sample. Coming to the culture, it provides a greater diagnostic reliability. So before you start the antimicrobial treatment, just give the sample, and you have to do if you want to do the quantification, it's a semi-quantitative method, using the standard calibrated nichrome vial loop, which can hold about 0.0001 ml. You can inoculate onto your routine media, but we usually use chrome at Nizams, incubated 37 and about 18 to 24 hours. This is the automated instrument that Vitek 2, I think everybody is having now this, where you can identify and give the antimicrobial susceptibility. Coming to the interpretation, if there is only one organism which has grown, less than 10,000 CFU, just only do ID. You don't have to perform any EST. If more than 10,000, then you have to do ID as well as AST. 2 uropathogens are there. At least one pathogen more than 10 power 5, just do ID and AST. 3 uropathogens, take it out as contamination, ask for a repeat sample. In case of uncomplicated UTI, culture usually not recommended. You can just straight away give the 3 days of antimicrobial therapy. Whenever there is sterile pyuria, Gram stain plays a very important role. You should also keep mycobacterium in mind and ask for 3 samples if you are suspecting mycobacterium tuberculosis. Sometimes false negatives could be because of interfering substances, diluted urine, low pH. This all should be kept in mind while you are reporting. So next we'll move on to what are the quality improvement programs. So what is the purpose of quality improvement programs? You want to assure that there is appropriate utilization of the catheter, to identify and remove the catheter once it is not needed, to ensure the adherence to the hand hygiene, and reduce the risk of COTI. You can have, I'm given some examples, like catheter, you can create your own catheter reminders, alerts, or stop orders. Like example, I have given one catheter reminder here, where there are some indications. Whether these indications were there when catheter was inserted, you can just check it and give the dates, and then if not removed, what could be the reason why it was not removed. In this way, you can avoid prolonged catheterization. Apart from the quality improvement, you also need to have the administrative infrastructure, like you should have provision of good guidelines. Education and training is a must. Supplies, when you want to do COTI surveillance, when you want to put the catheter, when you want to insert, like those standard precautions you want to maintain, your gloves, etc., all those supplies should be in place. Proper documentation should be done. I have given you the checklist. With that checklist, you can maintain this documentation. You can do the auditing also, whether your documentation is good or not, and then the surveillance resources. So surveillance, key terms I've already mentioned. We'll just see when you should do the surveillance. So consider surveillance for COTI only when it is indicated, like depending upon your rates, infection rates, whichever unit is requiring the surveillance, you can select that. Based on the risk assessment, you can perform the surveillance. So use a standardized methodology to do this surveillance. You also, while doing surveillance, you need to keep these metrics in mind, like how do you calculate the COTI rates, device utilization ratio. Use the CDC or NHSN criteria for identifying the patients who have SUT, that is SUT is symptomatic urinary tract infection. I've already given the criteria. Just don't calculate and keep it for yourself, it's of no use. Please give the feedback to the nursing staff or the appropriate medical staff, and try to work on like how you can bring down those rates. So this is the flow chart which we follow at Nizams. This is given by, I have 1 minute? 5 minutes, okay, I think I'll finish. At Nizams, this is given by CDC. We are also part of the, I think many other hospitals are also part of that CDC infection control project, so we are also part of that. So once urine culture is performed, yes or no, based on the criteria you can select from your registers which patient is fitting into this criteria. So once it has grown, you can see whether it is two organisms, at least one should have more than 10 power 5 CFU per ml, then the symptoms criteria. If all these are met, then you look at the criteria. I already said clinical, catheter, and symptoms. Clinical, catheter. What was the other criteria? Microbiological criteria, that is 10 power 5 organisms. So once all this is met, we classify that case as COTI and then do the surveillance. So this is the case report form which we follow at Nizams. This is a worksheet which we have. This is how we calculate the window period, date of event, event time frame. This is how we record for each case. We are not doing for the entire hospital. We have chosen few ICUs and then we are doing this. It's highly impossible to do for the entire hospitals. And then you also have to keep in mind some denominator data where you have to calculate like urinary catheter days and patient days. So catheter days is like number of patients who are on catheter in that unit, and patient days is number of patients in that unit. So this is also very important. You will have to collect the denominator data always at the same time every day so that there is no bias in the data. Even on the weekdays, holidays, it has to be collected. So you will have to make your arrangements how you're going to do that. So this is how the denominator data collection form which we follow at Nizams. And these things you will have to calculate. UTI incidence rate or the COTI. So since we're talking about COTI, I'll talk this. Number of COTI by number of urinary catheter days into 1,000 gives you the COTI rate, and the device utilization ratio. That is number of urinary catheter days by number of patient days. So why are we doing all these numbers? So this will also give you some important information. So this was the surveillance which was performed last 3 years at Nizams. So we have chosen AMC, ARCU and SSCU. So our COTI rates are like this and the device utilization ratio. So I'll give you one more example of one more center, AIMS Bhopal, which is also doing similarly. They're also part of this project. So what does this information give? So you're not just calculating and leaving. So this will give whether your device utilization ratio is highest or not, which indicates that most of the patients in that, the proportion of the patients in that unit are on catheter. So if the proportion is high, then you'll have to sit and work whether they really require catheter or whether prolonged catheterization is there. Are they stopping? Are they inserting only when there is a right indication? So this you'll have to sit and work out. And this also gives, you can see, the higher COTI rates. And if you see this, for example, in the month of Jan, 92 and 85, which indicates 85% of the patients are on catheter, so the usage is very high. Such information can be drawn with these metrics. It's not just calculations, right? Just keep in mind why we are doing all this, so that you can assess it and you can take the measures how to improve that. So to summarize, you have this core measures and supplemental measures. Core measures I have already discussed, like you have to insert only when there's a proper indication, leave in place only once it is needed, include only trained people, closed drainage system, unobstructed urine flow, hand hygiene. Supplemental measures, these are the alternatives to indwelling catheter, portable ultrasound devices. You can also have an algorithm, nurse-driven, like you can make this bladder scan to assess the volume of the urine. You don't have to put catheter in that patient. You can just make the scan, ultrasound scan, and then decide. Antimicrobial or antiseptic impregnated catheter. These are the supplemental measures. So with this, I conclude, and I think I am on time. Thank you. So, any doubts? I'm ready to take it up. No doubts.
Thank you, ma'am. Any questions from the audience?
Postgraduates, you understood the terms, date of event, event time frame, window period. Have you understood? No response? Yes or no?
They're probably hungry, ma'am.
They are hungry?
Yeah.
So early? 12:30?
They've been working really hard.
Okay. No questions?
Yeah.
Okay. Thank you.
Thank you, ma'am. Thank you for enlightening us on surveillance and prevention of COTI. Now, moving on, I would like to invite Dr. Shilpa Pradhan, ma'am, Associate Professor, Department of Microbiology, to introduce our next speaker, Dr. Rajeshwari KG, madam, Consultant Microbiologist, Aster CMI Hospital, Bangalore.
Thank you, sir. So let me introduce our next eminent speaker, Dr. Rajeshwari KG, ma'am. Ma'am has done her MBBS from Sri Devraj Urs Medical College, Kolar in 2006 and her Masters from JSS Medical College, Mysuru in 2010. Ma'am has got a CIC degree that is a board certified in the infection prevention and control, which is being certified by the Canada IPC control in 2021. And ma'am is also having a diploma degree in infection prevention control by University of Hyderabad, and she's waiting for her results. Ma'am is currently working as a consultant microbiologist and infection control officer at Aster CMI Hospitals, Bengaluru. Ma'am has attended 30 to 34 national, international conferences, CMEs, and workshops. And to her credit, she has got 6 oral papers, 6 guest lectures, and 16 papers to her credit. Ma'am is an active member of an organizing committee for workshop on PCR, biochip, and she has participated in Sepsicon held at JSS Medical College, Mysuru. Ma'am is a review committee member of International Journal of Health and Allied Sciences also. Ma'am was a NAC coordinator, NABH coordinator, SRL coordinator, RNTCP coordinator in the Department of Microbiology at JSS Medical College, Mysuru. Ma'am is a life member of Indian Association of Medical Microbiology, life member of IMA, as well as Association for Professional of Infections and annual member of SHIA. So dear colleagues, let us welcome our next speaker, Dr. Rajeshwari ma'am, to speak on antibiotic policy and antimicrobial stewardship program. Welcome ma'am. Thank you.
For that very nice introduction. At the outside, I would like to thank Dr. Bilal Ahmed sir, the entire management of Khaja Bandanawaz University for giving me an opportunity to be a part of this CME. When first sir called, I was in two thoughts, should I travel this far? But when an organization is taking such an initiative, it is mandatory to attend and probably improve infection control, especially in our state. So before I could start, I can see so many MBBS students here. How many of you take antibiotics whenever you get a cold or cough? Can I see some hands up? Very good. How many of you share the same prescriptions because your brother had the same cough, cold, your mother had it, your uncle had it, your neighbor had it? So how many of you tell them, I took this, please take this. Azithromycin works very well. Cipodem works very well. How many of you do that? Okay. So being educated professionals, being in the medical fraternity, if we are the so-called misusing antibiotics, then imagine what is going on with patients or illiterates. So basically the theme of my talk today is antimicrobial stewardship and antibiotic policy. So I would like to start off my talk with a quote from Alexander Fleming, the discoverer of penicillin, who said, "The thoughtless person playing with the treatment is morally responsible for the death of man who succumbs to the penicillin-resistant organisms." So the worst fear of Alexander Fleming has come true, and today we are in the day and age where we do not have antibiotics to treat patients. So every year, WHO conducts a week-long program from November 18 to 24, which is called the World Antimicrobial Awareness Week, to improve the knowledge and the usefulness and also the appropriate use of antimicrobials in preventing antimicrobial resistance. The theme of last year was prevention of antimicrobial resistance, or together. It calls people from all fraternities. It's not only hospitals, public sectors, veterinarians, the administrators, everybody to work together to prevent antimicrobial resistance. So why am I being asked to talk today on this topic? Precisely because we know there are designated areas for department. We know earmarked areas where we sit, but where does MDR bugs sit? They are present all over. Rather, they have become omnipresent and omnipotent. So talking about the burden of antimicrobial resistance, all of us know that it is a global public health threat. We all of us speak about corona or COVID, but please remember, COVID is also, antimicrobial resistance is also a pandemic. Rather, it's a silent pandemic, which all of us are not noticing. Infectious diseases are becoming very difficult to treat because of antimicrobial resistance. As a result, WHO has identified this as one of the top 10 global public health threats. So coming to the Indian scenario, we believe in this new concept of Make in India. Is it that antibiotics we are making to create or to prevent all these MDR bugs? But no, unfortunately, it is resistance that we are contributing to. So coming to the burden in the world, approximately 7 lakh deaths globally has been attributed because of antimicrobial resistance. And also it has been noted that about 1 lakh deaths occur in USA alone because of HAIs or healthcare associated infections. As all of us know, healthcare associated infections majority of the times are because of multi-drug bacteria, and with the so-called superbugs are responsible. Unfortunately, India is the highest consumption of antibiotics and also attributes or contributes significantly to the burden of antimicrobial resistance. So what we are seeing today is the tip of the iceberg for all the deeds that we have done over the centuries of abusing antibiotics, inappropriate and also misuse of antibiotics. Lancet, in its article in 2019, said that 1.27 million deaths were attributed to AMR in the year 2019. If the same trend continues, by 2050, about 10 million lives will be lost to antimicrobial resistance, which is an alarming number, 1 death in every 3 seconds. It is worse than COVID or whatever pandemic we think of. So it is time that we all are awakened now and make sure that we use these antibiotics judiciously. The ICMR surveillance network between June to August 2020, which was the COVID period, studied about 18,000 inpatient admissions and saw that 3.6% of the COVID patients developed secondary bacterial infections. So what? The problem is the mortality in these patients who developed secondary bacterial infections was 56%. That is, if 10 people developed COVID and had secondary bacterial infection, 5 of them died because of MDR bugs. So therefore, antimicrobial resistance killed more people than did COVID. So this should ring a bell to all of us and treat this problem. So the Center for Disease Dynamics Economic Policy also points out that India is contributing significantly in terms of carbapenem-resistant bacteria, fluoroquinolone resistance, and also we are not falling short even in gram-positives also. Karnataka, as you see, daily defined doses, we are somewhere near 15, but we need to improve, we need to cut down on the daily defined doses of usage of antibiotics also. So this is also another study of 2021, the recent data from ICMR, where they've studied about 1 lakh isolates for the entire year. As Dr. Nilima was mentioning, majority of the premier institutes in the country are contributing for this isolate data. You can see in this slide that not only they are becoming drug resistant, overall antibiotics or organisms have developing reduced susceptibility to majority of the antibiotics. It could be E. coli, Klebsiella, gram-positives, gram-negatives, and not far behind are also the fungi, especially Candida and other fungi. So therefore, India along with WHO has created this priority pathogen list, which basically is to make sure that we target the critical alert pathogens. That is, we need to come up with interventions or antibiotics to treat such deadly pathogens. Otherwise, it is probably the end of an era of humankind. So what are the causes of antibiotic resistance? Very much to the questions that I asked you all in the beginning. Over-prescribing of antibiotics. I know it is a flu, I know it's a virus, but I still take antibiotics. Not completing the course. I took 5 tablets, I've given 5 tablets to my sister, brother, mother, father. Overuse of antibiotics in livestock, very, very important. Poor infection control practices, lack of hygiene, and also lack of, there is rather we are at the end of the tunnel where no more new antibiotics are developed. So basically, why does this prescription takes place? Because the patient concerns like, I want clear explanation, doctor, can you explain me why I should not take antibiotics? There is a green nasal discharge and you're telling it's viral. Please tell me it is bacterial and we need to convince patient not to take antibiotics. It is rather easier to prescribe antibiotics to a patient rather than convincing them not to take antibiotics. So if the prescription is 2 seconds, convincing the patient goes as long as half an hour. So therefore, most of the practitioners feel it is easier to prescribe antibiotics rather than convincing, educating, and telling them the harmful effects of antibiotics. So therefore, what happens if resistance develop? There is excess length of stay in the hospital, there is interference with the normal microbial flora of the patient, untreatable infections because over a period of time they become multi-drug resistance, increased mortality, obviously morbidity associated with, and because of the selective pressure, there's increase in the drug-resistant pathogens. Obviously, the bill also exponentially increased. No infections, you come for a surgery, your bill is 1 page, especially in corporate hospitals like mine where I work. If in case you get a HI, a bill is a 4-pager, and the wrath of it is faced after the bill is come. So therefore, it is time to unlearn. We need to wipe the slate clean and start, otherwise probably we are looking at the extinct of antibiotics and mankind. So what is antimicrobial stewardship? Most of the times this topic is very boring, everybody tells it's only definitions, but no, we can incorporate this in all setups also. So basically, if you're looking at the definition, it is a set of activities designed to promote optimal drug dosing duration of therapy. That is, if you're taking any antibiotic, take the right antibiotic for the right time and the right dosage also. That is what is antimicrobial stewardship. So that is why CDC calls it the right antibiotic for the right patient at the right time with the right dose, the right route, and cause least harm to the patients. So this is what, it's a mixture of all rights so that we don't lead to antimicrobial resistance. So what are the basic steps? I understand if there's a committee, it's more easier. I'll just brush through these. So basically, perform a situation analysis. So do we have an antimicrobial stewardship committee? Yes, good. Then follow the next step. If not, then we need to obtain approval for AMS activities, assemble a team, like all other previous speakers told. Teamwork, we always believe unity in diversity, and only then we can make progress. Obviously, teamwork is very important. Set goals. If we do not set goals, we understand, as you know, students MBBS also, this internals I'll pass into, next one in, next internals the other 2, or probably I'll finish 4 chapters. So setting goal is very, very important. After setting goals, you should select interventions. So basically, we should understand how to get about these goals. Perform key performance indicator, we need to select it, because only if we get a marks card, we'll know how well we have studied or prepared. Implement, educate, and train. I know we have had goals, we have done policies, but if nobody is implementing it, there's no point again. And then monitor and report progress. So progress card is very important. So the next slides is just about the steps, as to various steps that has to be followed, what I explained just now. So I'll just skip through them. What are the core components of an antimicrobial stewardship program? Leadership commitment. Like Dr. Arsia was telling earlier, if there is no leadership commitment, absolutely it is not possible. Accountability. There must be people who are accountable for actions. That is, if somebody has prescribed an antibiotic, they must be able to accept it. Yes, I was the person, or I was the prescriber. Drug expertise. People should know about antibiotics. Mechanism of action, does it work on gram positives, does it work on gram negatives, is it antiviral, is it antifungal, very, very important. And also about the dosage. Most of the time, it is either underdose or overdose, and also the side effects are not known, and in case of organ dysfunctions like renal or hepatic, proper dose adjustment is also vital. Action to be taken when these interventions come in, we need to track, we need to report, and obviously, based on the report, education needs to be done. So looking at the team, AMS team, most of us will tell, madam, we do not have all these people. Is it possible to implement? Very, very, yes, it is possible without any one of them. Just having the basic setup, like in medical colleges, we do have physicians who know so much about antibiotics or antimicrobials. We have a microbiology lab. We have physicians, surgeons who are willing to do appropriate prescribing practices. It's very much a possibility. Not necessary all these have to be there. So it's not only for corporate hospitals. It's not only for colleges where they have money or everything. Without anything, also it can be implemented in this own very college. Ideally, this is what ideally must have a physician or a pharmacist or a specialized ID training, a clinical microbiologist, an infection control expert, an IT expert to analyze the data or trends, other physicians, pharmacists, nurses, hospital epidemiologists, hospital administration, and clinical pharmacies for the various PK, PD, and other parameters. we must always understand formal ID training is beneficial but not absolutely necessary. So this is what I said, not necessary. All of them should be there for a tick box. Even with whatever faculty we have, we can still form an AMS team and implement AMS even in this college also. So these are the various roles and responsibilities. Obviously, when it comes to physician, or the expert, we look at developing and implementing AMS. The hospital administrator must support this AMS. Pharmacist co-leader must basically track the AMS activities every day. And microbiology lab do what is called as diagnostic stewardship, where we process samples which are collected appropriately. That is, samples are not collected after antibiotics. Samples should not be mixed or contaminated. So all these points need to be kept in mind. So what are the AMS interventions whenever we are following an AMS plan in the hospital? Pre-authorization. We need to pre-authorize certain antibiotics. So basically, it starts off with what is there in the formulary. What is a drug formulary? The list of antimicrobials which is there in our pharmacy is nothing but the drug formulary. It is very important that the right kind of medicines, right combinations should be there in the pharmacy, and irrational combinations, banned drugs should not be there in the pharmacy. And in case somebody is treating an MDR bug, it is important that an expert opinion is sought. Audit and feedback should be done always. Then we need to follow standard treatment guidelines and also develop specific guidelines for the hospital. How is this guidelines formed? Basically by the antibiogram, which is given out by the microbiology department. De-escalation. When an antibiotic is not required for a patient, de-escalate as per the culture reports. Lastly, IV to oral conversion, very, very important because it reduces the risks and other risks basically, and dose optimization is very, very important intervention in terms of AMS. So when you're talking about pre-authorization, that's what I meant. So basically giving the right antibiotic, storing the right antimicrobial is what is pre-authorization. Prospective audit and feedback. So there must be a AMS leader who does the audit and gives feedback. So basically primary review by the leader or infectious disease or a pharmacist or a physician. So after that they have to give a feedback. Then they do a second detailed review of the case and then give a feedback in the midday meeting. If optimal dose, route, everything is followed, then good, enter the same. If not, then obviously feedback has to be given. What is most important in terms of feedback, we must understand. As Dr. Arshia was mentioning, you see a ICU, everybody in the hospital gets scared. But this is not something it's scaring, or it is not something of dialogue or war between doctors telling that I know antibiotics better, you don't know, you have given the wrong choice. It is not a war, it is a healthy discussion. So therefore, a Cochrane review on what works to improve the quality of prescription in AMS program. So basically, handshake model. So basically discussion, having a dialogue with our colleagues face to face is what is most important and what has been most successful. So I mentioned prescription-based, whenever a doctor is prescribing an antibiotic or antimicrobial to a patient, we should make sure either empiric antibiotic policy or the national guidelines is followed. Make sure that standard treatment guidelines, example, standard treatment guidelines for MDR gram-negatives, standard treatment guidelines for MRSA should be available so that everybody in the hospital follow the same policy. And also surgical antimicrobial prophylaxis should be followed, where most of us know we do follow surgical antibiotic prophylaxis based on the choice, the duration and the doses, and continuation beyond 24 hours. So for developing hospital-specific guidelines, so basically we have to have a care bundle. We must know which is the most common pathogen in our hospital. So a policy which I develop in Bangalore may not hold good for this hospital because the pathogens may be different and the infectious syndromes may be different. So therefore, we must know the most common pathogens and also review the latest international guidelines. So now talking about the antibiotic policy. Why should an antibiotic policy be there in a hospital? Is it mandatory? Yes. For what? Basically to improve the prescribing practices of the clinicians and also an NABH requirement. So it basically reduces the morbidity and mortality due to AMR bugs, preserves the effectiveness of antimicrobials for later use, and prevention of communicable diseases. So these are very, very important. So what are the objectives of antibiotic policy? It detects the resistant organisms, ensures effective treatment, recognizes the trends. Trends in the sense, last year in medical ICU, we had lots of MDR Klebsiella. But this year we are seeing a steady increase in MDR Acinetobacter. So that is also important. In NICU, probably we had gram-positive sepsis. Now gram-negative sepsis. So that is what is most important. Now looking at what is an antibiogram is a report of the overall susceptibility of the pathogens done. So basically any hospital will receive cultures. So after culture, whatever bacterial isolates we have to make the organism profile and susceptibility pattern and put it across. So that is what is called the antibiogram. So what does it contain? It contains the antimicrobial susceptibility pattern across the hospital over a specified period of time. So how frequently should you prepare an antibiogram? Ideally, once in every 6 months. If the isolate data is not enough, once a year, at least mandatorily it must be done. So what does an antibiogram can be used for? Can be used to guide clinician in selection of appropriate antimicrobial therapy. If you ask me how, example, a patient comes to your medical ICU, you know that your medical ICU in the last antibiogram, you have seen that most of them are ESBL producing. More than 70% of isolates are ESBL producing. The patient has just entered in. Patient is in shock. You don't know what is the disease or you don't know what organ is affected. In those cases, your antibiogram will tell you that you can use a carbapenem because you know majority of your isolates are ESBL producers. It can help in developing hospital prescribing guidelines, monitor antimicrobial resistance over time, identify outbreaks like Dr. Khalil spoke, compare antimicrobial resistance across infections, provide rationale for policies and decisions for antimicrobial use, plan and evaluate AMS interventions. So antibiogram can be used for all of these. So therefore, we have an antibiogram from which we can prepare an antibiotic policy, which can be used as a basis for standard treatment guidelines, which together all of them form what is called as the antimicrobial stewardship program. So direction of the antibiotic policy, what should it basically contain? It should contain the first-line drugs, reserved drugs, restricted agents. That means first-line drugs can be used by any of the doctors or practicing doctors in the hospital. Reserved drugs need to be used with caution. Restricted drugs should be used only after consultation with a superior. If ID consultant is there, then ID consultant or a superior in terms of HOD and other people. So that is what is first-line reserved and restricted drugs, and make sure withdrawn agents are not a part of the policy. So basically, antibiograms also help us to know what is prophylaxis, empiric therapy, pathogen-directed therapy, and susceptibility-guided therapy. Empiric therapy is something where we do not have any culture report or we don't know any background data of the patient. So the antibiotic that we use is called empiric therapy. Like madam was telling, you have sent a urine culture today, 2 days later you get a urine culture report. You know that there is a E. coli which is sensitive to ceftriaxone. The patient was an ertapenem. You bring it down to ceftriaxone. That is what is called pathogen-directed or therapeutic therapy. That is also called de-escalation. So basically, the generalized principles of antibiotic use in hospitals, which are good practices, is always, what is the diagnosis or most likely cause of infection? What is the risk of infection with drug-resistant organism? Does the patient have an antibiotic allergy? These are all the questions that every physician or every prescribing doctor should go through before writing a prescription. How severe is the infection? Is the patient immunocompromised? Very much important. If we do not treat or act rightly, the immunocompromised patient can succumb to infections. What is the status of patient's renal and hepatic function? All these needs to be kept in mind, and suitably de-escalation has to be done. IV to oral conversion, very good, as early as possible, because obviously there are side effects of IV, easy administration, the compliance becomes better, and early discharge opportunities. We know that every day stay in the hospitals increases the risk of MDR acquisition or HI by about 8 to 10%. So therefore, very, very important. Dose optimization, the PK/PD, which probably later they'll discuss, but very, very important that we need to optimize. One rule does not fit all, or one size does not fit all. Each patient is different. That's how we need to consider. Also important is key performance indicators as to what are the marks, how do we do it, theory, practicals, internal assessment. So basically, this is what is called as peak performance indicators. That is called as process measures and outcome measures. Process measures basically to see, are we doing enough? Outcome measures to see if we are making a difference. So I'll just skip to these slides, basically. in AMS program, what is in and out of antimicrobial stewardship program in 2022? So basically, lots of changes have happened. What is there presently now is it is integrated into the clinical governance system. So before, if somebody was giving antibiotic irrationally, they would ask, where is the infection control? Now they'll ask, where is the CEO, where is the COO, where is the chairman? So that is what has become now, because they are accountable, also accountable. It's an integrated model of diagnostics, clinical management of infection control. So initially it was only antibiotic prescriptions. Nowadays, if cultures has been sent, diagnostics have been sent, and the interventions are based on prospective audit and feedback. And the feedback is given on a real-time basis, on a bedside, hand to hand, and it is a cordial relationship and not an argumentative relationship like before. Feedback is educative, informative, flexible, and patient-specific. Now, what we are looking at is clinical outcome measures. Before, they would see only at process measures, but now it is basically clinical outcome measures. So how do we sustain AMS programs? The leaders, the team leader is the most important, or the pivot in a program. We have to monitor, assess AMS programs' performance, report AMS programs' performance, modify and adapt the program as per your institution. Pre-specified process and outcome measures should be tracked. Basically, long-term trends is as important as this initiation. Just because we had a CME, we start, and after the next month nothing happens, is wrong. It should sustain for long term. So to stop with, what are the good practices? Send for all appropriated infections, investigations in all infections. All antibiotic initiation should be done after sending cultures. So we must develop the culture of sending cultures. Follow hospital policy when choosing antimicrobial therapy whenever possible. Check for factors that will affect the drug choice, renal functions, allergy. Check for appropriate dose. The need for antimicrobial therapy should be reviewed every day. That is why we also, like Dr. Arshia was telling, we have empowered our nurses in our hospital. When somebody charts down an antibiotic, they automatically ask, ma'am, for how many days? So they make sure we write into 48 hours and review later. So that has to be penned down in the chart. Once culture reports are available, the physician should step down to the narrow spectrum, most effective and most effective option. Very, very important. We understand an E. coli is an ESBL producer. Patient is on meropenem. Can we step it down? Yes, very much. You can step it down to ertapenem, which is sensitive, which is a narrow spectrum, does work as efficiently as ertapenem, as meropenem, sorry. So to summarize, AMS is a set of activities to design to promote the selection of optimal antibiotic. AMS is required to tackle the rising antimicrobial resistance. AMS can be established by performing, forming a team, setting KPIs, selecting interventions, can be sustained by development of antibiograms, adherence to various KPIs, can be achieved by leadership support, team effort, and determined mindset across the hospital. So it does not require whatever I said, it's just the last point, support, leadership support, team effort, determined mindset across the hospital is what is required. So like some of the slides, I'm sick, the kids are also sick, I can't sleep, there's so much of coughing, I can't cope, surely an antibiotic can help. So probably a cold or fever could be a viral. I'm not telling that does not happen in bacterial, but just we cannot sleep or kids are having cough for 7 days is not a need for antibiotic. Fever is surely not a sign of ceftriaxone deficiency. And most importantly, treating patients and not lab reports. Just because we have given a report in a patient with E. coli, 1 lakh colony-forming units, it's a multi-drug resistant bacteria, does not mean we need to bombard the patient with colistin, because in the list only that is available. We must always see if the patient has symptoms, clinical symptoms, how was the sample collected, when was the sample sent. All these are very, very important before we start or prescribe an antibiotic. Thank you very much. Before I end, a last sentence. You might ask, in this hospital, if I have to improve, as students, what you would look at. A classical example I would like to give, treatment of enteric fever, typhoid fever. First of all, make sure that your pharmacy has ceftriaxone, the approved brand of ceftriaxone. Make sure culture is sent, blood culture beautifully grows, salmonella, typhi, para-A, whatever. As students, you make sure that ceftriaxone only is prescribed because other antibiotics are not optimal and do not work. make sure that the patient takes IV ceftriaxone only. Just because the patient crips, IV line is painful, I have to go home. Do not switch to other alternative cephalosporins like first or second generation, and make sure you follow it up with a culture. So this is what, even in small setups or medical colleges as students or as professors, we can do, bring up AMS even in small settings like us. Thank you very much.
Thank you, ma'am, for highlighting and creating awareness on antibiotic resistance and also how to use antibiotics efficiently. Moving on to the next presentation, I would like to invite Dr. Javeria Firdaus ma'am to introduce our next speaker for today's program, Dr. Virendra Kasheti sir, Professor, Ashwini Rural Medical College and Research Center, Sholapur.
I'd like to introduce our next speaker, Dr. Virendra Kasheti sir. Sir has completed his MBBS and MD Microbiology from VM Government Medical College, Sholapur. He has completed his Diploma in Clinical Pathology from Government Medical College, Meerut. Sir is presently working as Professor, Consultant Microbiologist and Hospital Infection Control Officer in Ashwini Rural Medical College, Sholapur. He is the Director and in charge of Molecular Biology Lab, Ashwini Medical College and Rural Hospital. Sir has published various articles in various national and international index journals. He has served as the Secretary of IMMM, that is Indian Association of Medical Microbiologists, Maharashtra branch, from 2016 to 2017. Today, sir will be enlightening us about surveillance and prevention of ventilator-associated pneumonia and ventilator-associated events, its analysis and interpretations. So, dear colleagues, please welcome Dr. Virendra Kasheti sir.
Introduction, and I was part of KBN College. I served here for short duration of 15 months in year 2005 and 6. Now, I will start. This is a very tough topic and tough time before lunch, just before lunch, and I know the much attention is towards the stomach, then the brain is not working much, and the toughest lecture just before but I can't help. Okay, in the next 20 to 25 minutes, I would like to tell the complex topic. I would like to make it easy to understand because the terms keep on changing. Initially, we had few terms like HAP and VAP. What is HAP? Hospital-acquired pneumonias. Patient was not having pneumonia before the admission in the hospital, and he develops the pneumonia during the hospital stay. That is HAP, irrespective of patient is on mechanical ventilator or not. If he is on mechanical ventilator, we designate one more term, that is VAP, that is ventilator-associated pneumonia. And now, there was very complex things to tell whether it is a VAP or not, because not designated or not strict criteria were there to define the case of VAP. But in 2013, the NHSN has not able to change the slide. Next slide. So, although there were many challenges to define the case of VAP, the National Healthcare Safety Network developed, again the first, now it is working? No. In 2013, the term VAP is replaced by the new term that is VAE, that is ventilator-associated events. So, I would like to discuss here the ventilator-associated events surveillance. The surveillance reports are strictly made for surveillance, not for the diagnosis of ventilator-associated pneumonias. Keep in mind. Okay. So there are two types of ventilator-associated events. One is adult type and second is pediatric type. But because of the time, 20 minutes given to me, I would like to discuss only adult type of ventilator-associated events. And this is a slide showing what are the different terms we use in the surveillance. If patient is on the ventilator, mechanical ventilation, we call it as adult VAE, and offline it is adult VAE or PNEU or VAP. In neonatal, again pediatric VAE, the previous guidelines were same. And these are the other terms which we use in the surveillance. So this is a very important slide, the algorithm of ventilator-associated events. There are three important conditions when the patient is on mechanical ventilator. The first is VAC, that is ventilator-associated condition. Second is IVAC, that is infection-related ventilator-associated condition. Third is PVAP, that is possible ventilator-associated pneumonia. So these are the three different terms we should keep in mind, and all these three terms are included under one heading, that is ventilator-associated events. This slide again I'll discuss after the definitions of the terminologies. The adult VAE, already we have discussed these three. The first term is DOE. Dr. Nilima has elaborated well in COTI what is date of event. What is date of event in the VAE? The date of event of VAE is date of onset of worsening of oxygenation after the 2 days of stabilization of the oxygenation. Means patient is on the ventilator for initial 2 days of that stabilization. What is stabilization? When the oxygen requirement is constant or decreasing for 2 days, followed by when it will start worsening of the oxygenation, the oxygen requirement is increasing, that day is considered as date of event. Next is ventilator associated event window period. This is very important to categorize different terms. What it is? It is a 5 days period which includes 2 days before the date of event, next date of event, and 2 days after the date of events. So total 5 days of window period, and it should exclude the 2 initial days of mechanical ventilators. Okay, so the window period should not come in the first 2 days of mechanical ventilation. Patient is intubated today and tomorrow should be excluded from the window period, and then wherever the date of event will be there, that should be considered 2 days before and 2 days after, maximum 5 days. It can be shortened for 3 days or 4 days depending upon the date of event. I'll give some examples. The first example is, which is the pointer? Okay, so the first scenario is the first 2 days of mechanical ventilator, patient is on the first 2 days of mechanical ventilator. Third day is stabilization. 4 days stabilization, patient's oxygen requirement is not increasing. And if the patient's oxygenation is getting worse, on day 5, that is the date of event. So the first 2 days before the date of event, and 2 days after the date of events. That should be included in ventilator window period. The second VAE window period. The second scenario is the first 2 days stability, patient is on ventilator. Third day, the patient is oxygenation is worsening and requirement is increasing. It should not be taken in the window period. Why? Because the first 2 days should be excluded. Patient is intubated on day 1, and day 3 patient is developing the worsening. The window period should not include these 2 days because these are the initial 2 days. Those should be excluded. So the window period here is 1, 2, and maximum 3. Okay. And third scenario is the first day is totally excluded. Second day stability in third day, and 4 days worsening. So first 2 days should not be included. Here only 3 days are included. Next is what do you mean by stabilization? How we conclude patient is having the phase of stabilization. This is based on two different parameters. One is FiO2 and second is PEEP. Those who are working in the ICUs and maintaining the ventilators, they know very well what you mean by FiO2 and what you mean by PEEP. What is FiO2? It is a fraction of the air in which the oxygen is there. Normally we are having 21% of oxygen in the air, atmospheric air. So the normal air is having FiO2 that is 0.21. Okay, but when we put the patient on ventilator, it is in between 30 to 100%. That is 0.3 to 1. Okay, so FiO2, what is FiO2? It is fraction of oxygenation in the volume of air being measured. So already I have explained. So how we conclude whether patient's oxygenation is worsening? So if FiO2 requirement is equal or more than 2 in one day, that is considered as worsening of the oxygenation. Okay, either or patient's PEEP should increase or requirement of PEEP is increased by 3. What is PEEP? That is positive end expiratory pressure. Normal value is what it is, a pressure applied by a ventilator at the end of the each breath, that is expiration, to maintain the airway pressure greater than the surrounding atmospheric pressure, so that there will be prevention of collapsing of alveoli. So normal range is 0 to 5 centimeter of H2O. The increase of anything more than 3 or more than 3, PEEP should be considered as worsening of the oxygenation. Either FiO2 requirement is increased or PEEP is increased. That data you can collect with the help of your intensivist. So daily minimum, so in a day there may be different PEEP or there may be different FiO2. How to calculate? So the daily minimum FiO2 should be considered as minimum FiO2 of that particular day, and that should be considered. And daily minimum PEEP is also taken in a similar way. How to monitor the how to conclude the daily minimum FiO2 or PEEP? If you are monitoring hourly basis, if you are monitoring 30 minutes basis, if you are monitoring every 15 minutes, the criteria are different. The first one is if you are recording every hourly, minimum 2 successive readings should be considered if they are having the same values or decreasing values or minimum values. In 15 minutes, 5 successive readings, 30 minutes, 3 successive readings, more than 1 hour, lowest value. There are 2 scenarios I would like to give. The PEEP at 6 p.m., 10, 8, 5, 5, 8, 8. So what is the daily minimum PEEP is? We are monitoring hourly basis. So 2 consecutive means 5. Okay. In the first scenario, it is 5. And in second scenario, if the PEEP is 8, 8, 5, 8, 5, 8. So here 5 is the lowest, but we are not considering as 5 as the lowest because 2 consecutive readings should be there. So what is the 2 consecutive readings? What are the 2 consecutive readings? The 8. So in this scenario, the daily minimum PEEP is 8. So now the baseline period of stability or improvement, what it is. So in window period, we mentioned the date of event and 2 days before. Okay, 2 days before, that is the what it is? The date of stabilization. The oxygenation requirement is constant or rather improving. So what it is? Either PEEP or FiO2 should be, either of these can be taken as the indicator of oxygenation requirement. The first is the PEEP. Here you can see the 6, 2, 5, 9 and 8, 8. So where it is increased? The day 3. So 2 to 5. How much is the requirement? So anything below 5 PEEP is considered as 5 only. Okay. So here the 2 readings, 2 and 5 are considered as 5 only. So these are the 2 days of stabilization. Patient is having constant requirement of oxygen. And again the second scenario, 6 and 4. 6, 6 and 4. Here the not much increase in the requirement, but rather it is decrease in the requirement. So these are 2 days should be considered as date of stabilization. Next, the same thing, the same scenarios I have given. Next is 6699. What it is? 2 days 66 are stabilization, and immediately there is increase in the requirement of oxygen. That is with the help, we can make out with the help of PEEP values or FiO2 values. FiO2 values are also increased by more than 0.2, and PEEP is increased by 0.3. So here this day is date of event. Next is 87, it is decreased, and 76 is also decreased. So first these 2 days should be considered as date of stabilization, and then there is sudden increase in the requirement of oxygen, that is worsening of the oxygenation. So here 5, 6, 7 and 10. 6, 7, there is slow increase, not by 2. Okay, there is no 6, 6, 5, 6, there is slow increase. There is slow increase, not more than 2. That's why we should not consider this as VAE. Okay, why? Because the rise is, according to definition, rise is not more than 2. Every day, 1 by 1 PEEP is increasing, and simultaneously the FiO2 is also increasing by 0.1. Okay. Now is IVAC. What is IVAC? Infection-related ventilator-associated complication. What it is? This is the second scenario. When the patient is having temperature high or low, hyperpyrexia or hypothermia, WBC count more than 12,000 or less than 4,000, along with VAC. If these are the criteria, we conclude patient is in IVAC. What is IVAC? Infection is possible, infection is there. Next is, in IVAC, what is included? One more criteria is included, that is new antimicrobial therapy is included in this period. What it is? It is started in VAE, it should be started in VAE window period, already I have mentioned. 1 day, that is date of event, 2 days before that and 2 days after. Next is, it must not be given on 2 successive days. Okay, it must not be given on 2 successive days. Continued for at least for 4 days, that is antimicrobial qualifying days. What are these antimicrobial qualifying days? I'll discuss in the next slide. And there are extensive list of antibiotics where we can give the antibiotics. Here, remember one thing. Many times in ICUs, we start new antibiotic when patient is already on the ventilator, not because the patient's ventilator-associated events are there. If patient is having COT or urinary tract infection or a fever of other origin, those scenarios also considered as the new antimicrobial agents. So what do you mean by qualifying antimicrobial days? The first is days on which the new antimicrobial given. Already I have mentioned that should be started in the VAE window period. Okay. How long they should be given? 4 days, minimum 4 days should be there. If there is gap of 1 day, fine. Those gap days can also be considered as qualifying days. If more than 1 antibiotic is given simultaneously for 2 on the same day, we consider as day 1. Okay. If more than 1 antibiotic is given on different days with a gap of 1 day, we are not considering those days. Okay. And the gap of equal or more than 1 day for 2 antimicrobial agents not considered as QAD. QAD is independent of frequency, doses and renal adjustment. I'll give some scenarios. So first 2 days of mechanical ventilators should be included. The antibiotic should not be started in first 2 days to say these are the qualifying days. The first scenario is patient is having date of worsening of the oxygenation on day 5 in all scenarios, and the window period is first 2 days and 2 days after. Okay, the amikacin is started on the date of event and it is continued for 4 days. Whether these are qualifying days? Yes. Meropenem is given for 2 days and then the antibiotic is changed in, that is amikacin, for 4 days. 1, 2, 3, 4. Yes. Here 2 antibiotics are given. The 2 antibiotics, even though they are given on 1 day, it should be considered as 1 qualifying day. 1 and 2. So this is not, even though it is started in window period, it is not continued for 4 days. So this is not a qualifying days. So amikacin is given with a gap of 1 day. day 1, day 2 is not given, 3, again gap of 1 day. So those gap days can also be considered. 1, 2, 3, 4, 5. So yes, this is a antibiotic qualifying days. So there is gap of 2 days in between, but the antibiotic is changed. Even though it is having 4 qualifying days, we are not considering as 4 qualifying days. Again, the criteria is same with various doses depending upon the renal adjustment and other things. So last term is PVAP. What is PVAP? Possible ventilator associated pneumonia. How to consider it? It is a third or terminal event. What it is? Along with the IVAP, there should be clinical, the laboratory criteria should be there. Or patient should have the secondary bloodstream infection, and that should be proved in the laboratory. So what it is? Reported PVAP if blood has matching organism similar to respiratory. Patient is having the Klebsiella in the ETT, and after 4, 5 days or 7 days, patient is showing Klebsiella in the blood sample as well. So what it indicates? Patient is having PVAP, and patient is in the terminal stage of VAE. Okay. So respiratory culture positive during VAE window period, and blood culture should be positive in next 14 days. It is not reported for VAC or IVAC. What are the exceptions? It should not. It should meet the histopath criteria. So what are this exclusion? I'll discuss after the next slide. So these are the laboratory criteria. What are those? Either of the criteria should be there to say this is IVAP. What is IVAP? That is infection, or PVAP, possible ventilator associated VAP. So the first criteria is positive quantitative or semi-quantitative culture depending upon the number of colleagues depending upon the clinical specimen. The criteria 2, positive qualitative cultures along with the gram stain showing purulent or pus cells or epithelial cells. And third criteria are other than culture methods, the other methods are showing the possibility of infection. So either of these should be there, either criteria 1, 2 or 3. Now coming to the exceptions. What are the exceptions? PVAP made with histopath criteria plus culture or non-culture test not performed, plus positive blood culture, no evidence of secondary bloodstream infection to the VAE. Culture or non-culture test performed plus matching organism, no. What is the criteria? There has to be 2 cultures. One is of the respiratory secretions. Maybe it is ETT, maybe it is a sputum, it may be ball, mini ball, whatever it is, or maybe biopsy sample. And second is the blood culture in next 14 days. Now the exclusion of VAE surveillance. There are some scenarios where we exclude those scenarios from VAE. Patients on high frequency ventilator or extracorporeal life support or brain dead, or patient is on IPPV and nasal positive end respiratory pressure, that is nasal PEEP, continuous nasal positive airway pressure. All these conditions are excluded from the surveillance of VAE. Pathogens excluded. Not every pathogen is considered as the infective cause of ventilator associated lung infections. The first is normal respiratory flora. That is in early stage when the patient will have signs of infection. Those are mainly because of normal flora. So those should be excluded. Candida or otherwise not otherwise specified. The coagulase negative or enterococcus should not be considered for the surveillance. Dimorphic fungi should not be considered for the surveillance. Next is how to calculate the ventilator associated events. So all these events, the first is VAC, second is IVAC, third is PVAC. So all these should be considered as VAC. So how to calculate? VAC rate should be calculated. That is number of VAE cases multiplied by 1000 divided by total number of ventilator days in a hospital. Okay. So in the normal, the benchmark should be as low as possible. Indian scenario, very few institutes have participated to share their data. Currently, it is shown that we are around 6.1 to 6.2 from prime institutes per 1,000 days, but it is considered as anything between 3 to 45 per 1,000 days is a worldwide data is showing the rate of VAE. In US, it is much lower, that is 1.48 VAE per 1,000 days. Okay. Next, again, we have come to the same algorithm. Now we'll review what we have learned. The first is mechanical ventilator criteria. What is required first? The 2 days of baseline period, that is stable or decreasing oxygenation, that is based on daily minimum FiO2 or daily minimum PEEP. Next is 2 days of worsening of oxygenation, that is increase in FiO2 or PEEP. That is known as ventilator associated condition. There is no fever, nothing, no secretion, increase in the secretion, patient just showing the sign of worsening of oxygenation. That is VAC. Next is when VAC along with the increase or decrease in the temperature or increase or decrease in the WBC count and new antimicrobial is introduced in that window period for 4 days, it should be considered as IVAC, that is infection related ventilator associated condition. Next, IVAC with any one of these, that is culture, quantitative or semi-quantitative, or gram stain plus epithelial cells, and culture qualitative or non-cultural methods. Already I have mentioned in the criteria 3. So that condition is labeled as possible ventilator associated pneumonia. So now coming to last 2 slides, the prevention of VAP. So there are generalized prevention criteria and specific prevention criteria. In generalized, educating the staff along with the intensivists, because we have to stop the getting infection in the ICUs, because once the patient will land up with the IVAP, the mortality rate is highest. Okay, so Dr. Nilima has told the COTI is the leading cause of hospital-acquired infection. Ventilator-associated events is the second leading hospital-acquired infection or hospital-related infection, and the most leading cause or leading cause of mortality in ICUs. Okay, so what is required? Educating the staff and training of the staff. Hand hygiene practices should be improved at optimum level. The use of PPE should be there while handling the secretions. The disinfection of the material or equipments, whatever you are using during mechanical ventilators. Overcrowding should be avoided. The surveillance of VAE should be strict. If there is any increase in the VAE, the CAPA should be done. What is CAPA? Corrective action and preventive actions along with root cause analysis. Staffing level for ventilator patient, it is advised or it is mandatory to have 1:1 ratio should be maintained. The screening of patients on environment or their environment, screening of the patient mainly against for the resistant organisms like MRSA or VRE or whatever the ESBL or KPC. The antimicrobial stewardship program should be implemented. No need to tell, Dr. Rajeshwari has elaborated very well. Next is specific measures, avoid mechanical ventilator as far as possible. If it is mandatory, then only put your patient on mechanical ventilator. The alternatives you can use like NPPV. Avoid re-intubation. It has shown that re-intubation is associated with high degree of VAE cases. Silver-coated ET tube should be used. Silver-coated ET tube is having advantage to prevent the biofilm synthesis. The tracheostomy should be given to the patient if possible, because it will give much more comfort to the patient. Along with it will reduce the period of sedation. It will reduce the chances of getting VAE. Heat and moisture exchanger should be used. I'll just go fast. The specific measures again, ET suction apparatus. There are 2 types, closed and open. Closed are multiple times we can suction with the same tube. Open at one time, the one suction catheter should be used only once. Nasogastric tube and enteral feeding, again we have to be very careful while feeding these because the ventilator associated events are much more associated with the aspiration, that is endemic VAE. the disinfection of the material should be done. Positional strategy, 30 to 45 degree head up should be there. Sedation interruption, so that the patient will have minimum aspiration. Aspirations are micro or macro aspirations are observed when the patient is having continuous under the sedation. Stress ulcer prophylaxis, selective oropharyngeal decontamination, selective digestion decontamination, respiratory physiotherapy, prevention of biofilm by using the silver coated ET tube, probiotics. So these are all the specific measures. And last slide about the ventilator bundle. This is a checklist how you will keep the ventilator associated even in check. The first is elevation of head and 30 to 45 degree. Every day, at least twice, you should monitor these things, these points. The elevation of head end, that is 30 to 45 degree. The daily sedation vacation, assessment of readiness to be extubated. There is one risk when we give the vacation or the gap for the sedation, patient may become the irritable and may do the self-extubation. That balance you have to keep. The daily oral care with chlorhexidine, strict aseptic techniques, sterile suction catheter used for suction. Single-use material should be used only at once, not reuse of the material. Subglottic suctioning of the respiratory secretion should be done. DVD prophylaxis should be done. Peptic ulcer disease prophylaxis. This is a checklist to prevent the VRE cases. Thank you for patient listening. This is a complicated topic. I do understand. It is very difficult to complete this topic in 20 or 25 minutes. This is a topic to understand. It takes minimum 2 hours. Minimum. And to interpret and to practice, it is more challenging. Again, as Dr. Asi has told, it is a teamwork. We microbiologists or only physician can go to the ventilator patient, and we cannot have that data. For that, the assessment system, the analysis system should be so, the documentation should be so meticulous. You have to make out the daily minimum FiO2, daily minimum PEEP. Unless you will have that data, you cannot make out the worsening of the oxygenation. Okay, thank you. If there are any questions, please. Thank you.
Awaited event for the day, the lunch break. Okay, so 1:30 to 2:30 will be the lunch break. We'll all assemble at 2:30 to proceed further with the program. Thank you. Good afternoon, everyone. I hope you all had a wholesome meal with a little microbes inside. Moving on to the next presentation for the day, I'd like to request Dr. Javeria Firdaus ma'am, Associate Professor, Department of Microbiology, to introduce the next speaker, Dr. Nawaz Umar ma'am, Professor and HOD, Department of Microbiology from Gulbarga Institute of Medical Sciences.
Good next session. Today, I have the honor of introducing my esteemed teacher, Dr. Nawaz Umar ma'am, Professor and Head, Department of Microbiology, the Gulbarga Institute of Medical Sciences, Gulbarga. Madam is the Principal Investigator of Viral Research and Diagnostic Laboratory, JIMS, Kalaburagi. She is the Head of Hospital Infection Control Committee, JIMS, Gulbarga. She is the Nodal Officer of Genome Sequence Laboratory, State Reference Laboratory for Diphtheria Pertussis, JIMS, Kalaburagi. Serosurveillance of COVID antibody for Kalaburagi district. Madam is also a National Medical Council assessor. Madam has a teaching experience of 16 years. Madam has published research articles in various national and international index journals. Today, Madam will be enlightening us about infection prevention in multi-drug resistant pathogens. So dear colleagues, please welcome Dr. Nawaz Umar ma'am.
Colleagues, very good noon to everybody. My topic for today, infection prevention for multi-drug resistant pathogens. I'll be covering this under the layout of multi-drug resistant organisms which are encountered in the healthcare settings. What are the usual multi-drug organisms which we are encountering? Then the factors that are associated for the rise of the MDROs. Increased incidences are seen in these recent days. Then prevention and control of the MDROs. So to begin with, the definition of the multi-drug resistant organisms. These are nothing but the bacterial isolates which are not susceptible to at least one agent in more than 3 antibacterial classes tested. Certain MDROs are there like MRSA, methicillin resistant Staph aureus, or VRE, vancomycin resistant enterococci, which are indicated by a single antibiotic agent, but they usually show the antibiotic resistance to a number of agents, antimicrobial agents. So the simplest approach would be multi-drug resistant means more than one resistant to more than one drug. Now when we are speaking about MDRs, the phenotypes XDR and PDR have to be seen upon. So MDR isolates which are not susceptible to at least one agent in all, but less than 2 antimicrobial classes are the extensively drug-resistant organisms. Pan-drug resistant, the name suggests itself, pan. They are resistant to all the antimicrobial agents in all the antimicrobial classes. Coming to the importance, what is the importance of MDRO? Okay. One thing what is seen in this one decade is MDROs are associated with higher morbidity and mortality. We see morbidity and mortality is substantially higher in these patients. Then increases the financial burden on the healthcare, increases the patient stay, long stay of the patient is seen with this kind of infections, and clinical outcome is more dreadful as compared to the other organisms. So therefore, stringent strategies has to be prepared, which has to be strictly followed so that such kind of infections will not be encountered both with the patients and the healthcare personnel. So what is the current scenario? The recent trends, we see more number of immunocompromised patients. We see extensive medical devices and supportive measures. Both the patient also is happy and the private sector people are also happy with increased medical intervention or supportive measures, and irrational use of antibiotics and fungal prophylaxis in a number of patients. And overcrowding, this is one of the very important things. Overcrowding of the hospital wards lead to spread of the organisms on the healthcare worker, which is very important mode of transmission of the MDROs. Then carbapenem resistant and colistin resistant gram-negative organisms are on rise, and VRE and other gram-positive organisms pose challenge for the infection and prevention. So 2 categories are there, endemic and emerging MDROs, or you can also call them as epidemic MDROs. So endemic ones are the ones which are highly prevalent in the hospitals, and emerging or the epidemic MDROs are the ones which are of low prevalence. So these are the list of gram-positive and gram-negative organisms. Among the gram-positives, we are having MRSA, that is methicillin-resistant Staphylococcus aureus, VRE, vancomycin-resistant Enterococcus, HLAR Enterococcus, that is high-level aminoglycoside-resistant Enterococcus species, and group A Streptococcus pyogenes, and MDR non-diphtheritic corniform organisms. We all are very much familiar with the peak-me infections, which include all the MDR Enterobacteriaceae, MDR Pseudomonas aeruginosa, MDR Acinetobacter baumannii, and increased resistance with coli, E. coli, and pneumoniae, and other less commonly encountered are the Burkholderia cepacia, Elizabethia kingia, Meningoseptica, and Ralstonia piquetii, and like that the list goes on. The most emerging of now, of the latest ones are the MDROs are the VRSA, vancomycin-resistant Staph aureus, and the colistin-resistant Klebsiella. Now coming, the percentage of infections, what we see on the clinical side is more with the gram-negatives. Almost 75 to 80% of the infections are seen with the gram-negative MDROs. And they are almost resistant to 3 to 5 classes of the antibiotics, and they show a paucity of agents are there, for especially for the gram-negative organisms. So we need to introduce more number of antibiotics to combat this MDRO burden. Then gram-positive organisms, they are fewer as compared to the gram-negative organisms. They are only 25 to 30% of the total MDRO infections, and spread is faster with the VRE and MRSA. And here we have good number of agents for the treatment. Coming to the antimicrobial resistance, I'll say it in the short. So we have the chromosomally mediated enzymes and non-enzyme mediated mechanisms like porin. You all must be well versed. Porin channel block or active efflux. So certain organisms like beta-lactamases or metallobeta-lactamases, aminoglycosides are the ones which poses the MDRO resistance severely in the hospital side, and so we have to recycle the antibiotic use such that there will not be a selective pressure on any one set of bacteria, so that the other bacteria in turn become resistant and other group of the bacteria die. So these such kind of the resistant bacteria enter the environment with genes coding, and later they attack on the definitely on the immunocompromised patients, and from there to the other patients and the hospital care personnel. The other important things are water effluent bodies and waste bodies. These are very important, and they act as a major reservoir for the organisms with especially the plasmid mediated enzymes, and these spread from the environment and colonizing patients with comorbidities and underlying immunocompromise. So what is the source? Definitely the source is from the hospital as well as from the community. So we have hospital acquired strains as well as the community acquired strains. So, and we can also see the sources are also the long-term care facilities like hospices, wherein the aged people take care for their long-term illnesses or bedridden patients like that in the hospices and the nursing homes. They are the most important source for the MDROs. And next, coming to the limitations. The limitations is little bit blurred here because the patient is moved from one set of ward to the other or for the investigations. So actually where the patient has picked up the infection is little bit blurred. So usually if the samples are done, if the cultures are done at the admission, this it can be more distinct. Then infections become more apparent after the hospital discharge. Now, it is very commonly seen. A patient comes with an upper lobe pneumonia, stays for some time, gets discharged. After some time again, it comes, the patient comes back with the lower lobe pneumonia. So these all things have to be taken. These are the important sources. I have put on certain important MDROs like Enterobacteriaceae, that is AMC beta-lactamase Enterobacteriaceae, and carbapenem-resistant Acinetobacter and Pseudomonas aeruginosa with their sources and the risk factors and their intervention. So sources for especially for the ESBL, that is AMC beta-lactamases Enterobacteriaceae, is gastrostomy or urinary catheterization or nasogastric tubes. For carbapenem-resistant Acinetobacter, usually it is contaminated, seen in the contaminated ventilators or moist and dry surfaces. Pseudomonas aeruginosa is particularly seen in the moist and wet surfaces like sinks, etc. And vancomycin resistant and methicillin resistant. So vancomycin usually it is seen in the hospitalized patients who are who have undergone surgical interventions or with the weakened immune systems, etc. And methicillin resistant, of course, it is due to the overcrowding or skin-to-skin contact of the patients or the attenders. So what are the interventions? Interventions can be done by screening of the carriers and isolation of the patients, proper hand hygiene, and we can do time-to-time surveillance has to be done. Hand hygiene, environmental care reduces the transmission, and isolation of the patients to separate room if possible in the facility, and contact with the contaminated surfaces should be reduced, and good hand hygiene and environmental hygiene will take care of these infections. This is a very beautiful slide showing the acquisition of nosocomial MDRO infections. You can see a group of population, that is population of patients who are infected with antibiotics, who are not infected with the antibiotics, and here is a subpopulation of patients who have become infected. So the factors are at the individual factors are there and faculty level factors are there. So at the individual level factors, of course it is antibiotic use, okay, ages, the extreme of the ages, the infants and the aged, old age people, severity of the illness, and immunocompromised systems, comorbid conditions, and colonization of the organism. These are the individual level factors, okay? And here are the faculty level factors. Definitely, first we have to speak about the hand hygiene, and you have to see the cleanliness of the surrounding. Overcrowding has to be taken care of, and healthcare worker compliance has to be done, and gloves, gowns, masks, of course, whenever it is essential. So these two factors, when it is not done in appropriate manner, it leads to the normal population, it leads to the normal population gets colonized and go into a subpopulation of the patient with the infections. Now, infection control measures, okay? So infection control measures are recommended under two categories, that is the core strategies and the organism-specific strategies. What is core strategies? Core strategies are applicable in any situation where MDRO infection or colonization is of suspicion. It is suspected, okay? What is organism-specific or resistant mechanism-based approach? Here, applicable of the incident, applicable if incidence or prevalence of MDROs is not decreasing despite the implementation of the core strategies. So under the core strategies, first we have to speak about the contact precaution. Under that we have hand hygiene, personal protective equipments, single use or patient dedicated equipments, patient placement, transfer of patients, and disinfection and environmental cleaning and bundle care, okay? So contact precaution. Contact precaution can be direct or indirect. Most of the times it is by the direct precaution from one patient to the another by the hand contact or any direct contact without any intermediate object, okay? So components of the contact precautions are gloves, gowns, single-use non-critical equipments, that is wherever disposable single-use equipments can be used, we can use that. Otherwise, at least we have to decontaminate the equipment and reuse on the other patients. Then enhanced high hygiene. Enhanced high hand hygiene is very important here for us, and restricted entry to the rooms and restricted visitor entry. And if the hospitals have the isolation wards, special isolation wards, single patients can be isolated in the rooms with anti-rooms wherein the case sheets or anything whichever from where the infection is being transmitted can be kept into, or separate rooms or end of ward bay with cohort nursing is very important. Dedicated nursing staff, patient and nurse ratio should be maintained, and contact isolation precautions with signages on the door should be done. Signages on the doors, curtains or bedspread or the patient file has to be done. Then next is the surrogate marker of efficacy. Surrogate marker, here we do the surveillance cultures for the colonization of the patients or those who are not colonized previously. So random such kind of samples can be given for the surveillance, and cohorting of the newly identified patients can be done. Hand hygiene, very important aspect of contact precaution. Here the hand carriage could be due to contact with the patients or the patient surroundings such as bed railings or handling of the bed linen and curtains of the patients or medications, or by manipulating the wound of the dressings. It could be anything. These are the 5 WHO movements. This is field-tested movements by WHO. So 5 movements are: 1, before touching a patient; secondly, before a clean or aseptic procedures; then next, thirdly, by the after body fluid exposure risk; and fourthly, after touching the patient; and fifth is the after touching patient's surroundings. So these are the 5 moments of the hand hygiene by the WHO. Now coming to the personal protective equipment. Surgical mask and eyewear has to be worn, especially in the places wherein blood splashes can be possible, and hand hygiene before donning and after doffing. If necessary, in between the steps of donning also, we have to do the hand hygiene. PPE waste to be discarded in appropriate bins. Normally, we discard it into the yellow bin. If any blood splashes are there, we can discard those PPEs into the red bins. Then single-use or patient-dedicated equipment. This is the single-use patient-dedicated equipments, preferably to be used. If not possible, we can use the same equipment by disinfecting with the 0.5% sodium hypochlorite solution. Patient placement, very important aspect. Patient placement, as I told, if there is possibility, then we can do the patient isolation. Rooms can be given to the single patients. Otherwise, cohorting of the similar patient is a very good alternative. Cohorting of the patients with the similar infections can be cohorted. Then if this is done, then spatial separation, spatial distance between each patient, at least 3 feet distance between beds have to be done, and curtains can be left between the beds so that the common use of the instruments or any other things is reduced to less. And visual cue, this is the color tape indication that has to be placed on the floor of the patient ward or on the bed linen or the patient file, etc. Environmental cleaning, okay? Choices of sites. So these has to be selective, especially wherein from the sites where the cross-contamination from the patient to the healthcare worker is possible. Such kind of spaces has to be identified. That is the immediate surfaces beside the patient, or the computer boards, or the bed railings, are the usual surfaces which has to be taken care of. And if it is a respiratory equipment, never decontaminate near any patient, or there should be no water washes, there should be no body fluid or secretions put into the bins or into the hand wash basins. If accidentally it's been put, then it has to be decontaminated at that point by using sodium hypochlorite solution. Then MDROs, why we should take so much care with this MDRO environmental cleaning is because they can survive, especially the Acinetobacter species can survive up to 5 months, and Klebsiella species up to 30 months. So that is the level they can survive. And bundle care, of course, when we take the bundle care, the patient improvement is better, and antiseptic wipes or decontamination of the bedridden patients, if this reduces the bioburden of the patient with the MDROs. Then specific guidance on emerging MDROs. What are the specific guidances? We have the look back review of preceding 1 year. So 1 year previous, what are the microbiological reports? Have we missed any MDROs? If missed, we have to do the patient tracing, contact tracing, and we have to monitor the environmental levels, and proper notification has to be put on. So these are the organism-specific or resistant mechanism-based approaches. So here we have prioritization of the isolation. How do we prioritize the isolation? Depending on the MDRO scores. So MDRO scores have been given to the patients with more severity. Long-standing MDROs are very severe kind of MDROs. So depends on the score of the patient, that is called as the Lewisham isolation, prioritizing according to the scoring system. Then next is the targeted screening and decolonization. Surveillance and antimicrobial stewardship. So active screening cultures. Active screening cultures have to be done depending on the virulence of the organisms that are to be isolated, and patient population and quality of the IPC instituted, and methods used to detect the same. Then who and when to screen? This is a very important question. Whom to screen and when to screen? So these are the persons who have received the antibiotic therapy in recent. So recent antimicrobial treatment given to a patient are the persons whom can be screened, and presence of any indwelling catheters or devices, and severity of the illness, admission in the ICUs, and transfer of the patient from one hospital to the other. And these are other reasons like previous surgery or solid organ transplantation, or patients on the ventilators, or if there is any epidemiological link. So here we have the conventional culture technique. Phenotypic tests are best for our kind of setups, and whatever is the isolation, that has to be communicated to the clinical departments. This is very important here. And sites, we can take the various sites mentioned here for the culture. Then coming to the antimicrobial stewardship, as you all are aware, that includes the appropriate selection, dosing, route, and duration of antimicrobial therapy, so that the focus to the patient care can be given by instilling the right antibiotic, right dosage to the patient at the right time. Then here are some of the important points like antibiotic restrictions. So as you all know, we have to do the justified use of antibiotics and antibiotic cycling. So scheduled alteration of the antibiotic classes has to be done to reduce the emergence of the more resistant MDROs, and usually applicable to the high risk with the MDRO concerns. So site-specific or organism-specific rotations, optimal duration, and optimal density of the antibiotic use. So this is a flow chart showing the emergence and transmission, wherein the native organisms are converting into the resistant organisms. So for the emergence, we have the antibiotic exposure and the genetic transfer. Antibiotic exposure can be taken care with the appropriate antibiotic management. Coming to the transmission, we have environmental factors, human factors, animal factors. Environmental factors, we can decontaminate appropriately, and isolation and barrier precautions can be done. From humans, hand hygiene can be followed, and for animals, appropriate health policies have to be instilled. Administrative support, of course, the human resource has to be seen properly. That is, trained infection control professionals should be there. Patient nurses ratio should be maintained, and healthcare compliance has to be monitored, and support for the system change, that is communicating and rapid laboratory testing. This is very important for the successful working of the HIC, and facilities and environmental changes like hand hygiene facilities, environmental cleaning, and written plan and implementation. Whatever we are doing, monthly one HICC meeting will not take care of anything. Whatever we have decided for this month has to be noted and checked in the next month what is been implemented, and this should be in a written form. And this is for the juniors, especially the PGs and the interns, what are the things that lead to the failure of the MDRO prevention and control? That is lack of compliance with hand hygiene. Okay, just wearing gloves is not a substitute for hand hygiene. No. Hand hygiene with proper hand washes or hand rubs or hand scrub is very important, and lack of education. Lack of education and non-prudent use of the antibiotics, low level of the healthcare staffing levels, and lack of financial resources, and lack of diagnostic typing and screening, and so many other administrative factors that lead to the failure of the MDRO prevention and control. These are my references. Thank you.
Enlightening us on infection prevention in multi-drug resistant pathogens. Moving forward with today's conference, I would like to call upon Dr. Shilpa Pradhan ma'am to introduce the next speaker, Dr. Batala Naga Srilata madam, Associate Professor, Government Medical College, Kadapa.
Good afternoon, everybody. So let me introduce her to our next speaker, that is Dr. Naga Srilata Batala ma'am, who is currently working as Associate Professor in Government Medical College, Kadapa, Andhra Pradesh. Ma'am has done her MBBS and MD from Kurnool Medical College, and she has got 17 years of professional experience as microbiologist and teaching faculty. Ma'am is a Principal Investigating Officer, VDRL, Government of Medical College, Kadapa, and she has got 26 research publications in various national and international journals on communicable diseases and on the medical education. She was a nodal officer for HIV under NACO, and she also is a PhD guide. So dear colleagues, let us welcome Srilata ma'am to deliver her lecture on surveillance and prevention of CLABC.
Good afternoon. May I have a little bit attention from the junior dynamic doctors that those will start their business after 5 years? Instead of shouting, shall I? Shall I? Shall I? Shall I? So from morning onwards, you are listening to so many speakers regarding hospital-acquired infections. How, when we suspect, these are to be managed, and what you are supposed to learn and how you practice. Handling and management of hospital-acquired infections, you had a lecture. Multi-drug resistant organisms, handling these MDRs, you had a lecture. CORTI, you had a lecture. Antibiotic stewardship, you had a lecture. After completion of all this, whether to treat the patient is important or better patient is not infected. If we think in a commercial way, if patient is infected, a microbiologist will be gained, a doctor will be gained, an anesthetist will be gained, everything will be gained, but the loser will be the patient. If at all, if the circumstances are like this, suppose, if the patient is not infected at all, we will have a healthy society. The burden on the government, burden on the society, burden on the house financial things, all will be decreased. So my entire presentation is towards on preventive aspects rather than the treatment aspects. And today the allotted topic for me is surveillance and prevention of CLABSI, that is central line associated bloodstream infections. Before going to all the preventive aspects, what is central venous catheter? As per definition, it is an intravascular device that terminates at or close to the heart, one of the great vessels. These can be either permanent or temporary or sometimes implanted. So among all these, it can be categorized to tunneled CVCs, dialysis CVCs, peripherally inserted central catheters or implanted catheters. Even umbilical catheter can also be considered as central line. And when you start your practice, approximately after 5 to 10 years you start your practice. Previously, these using of central line catheters was very less, but this usage is being increasing day by day, as these are providing a short-term, medium, and a long-term accessibility for treatment. Almost in the corporate setup to the normal setups also it will come. The impact of this CLABSI means it is central line associated bloodstream infections. Among all bloodstream infections, the estimated rate of this CLABSI will be 90% of all bloodstream infections. Those are catheter associated. Either it might be IV line catheter, IV catheters, or it might be urinary catheters. If it is catheter associated bloodstream infection is there, it is 90% is by central line associated. And in India, the range is very wide range, the CLABSI rate. It is of 0.48 to 16 because the reporting data is minimal when compared to other countries. When we start reporting, this range might be decreased, that is 0.48 to 16 is very wide range. But the studies I have come across are very, comparatively with other countries, we are having less reported cases. Only certain hospitals are participating in these reporting hospital-acquired infections. And these CLABSIs are attributing the mortality rate up to 25%, may range from 12 to 25%, but up to 25% is there is mortality rate. So we have, it is better to prevent to occur CLABSI rather than treating a CLABSI. And the attributable cost as per CDC, it is per episode, you can imagine, it is of $20,000 to $56,000 per episode. How much cost it is, you can imagine. So why do we complete this orientation? We are adding CAR-T, everything it is there. And CLABSI, it is central line associated, central line catheters are nowadays not using in every hospital, but still why it is needed? Because if these vascular access devices associated infections increase morbidity, mortality, and length of hospital stay for the two. And it definitely the cost of treatment can also be increased further. This can be overcome by education of health workers. These, if the healthcare workers are educated from staff nurses, class 4 employees, intensivists, microbiologists, general physicians, if everyone is educated on these handling of hospital-acquired infections or healthcare-associated infections, definitely the burden will be decreased. So how this will be trained? So unless there is any mandatory course in India, it will not be completed. So in my perspective, it is mandatory course to achieve this burden has to be decreased. It is our motto. then a mandatory course should be initiated for every healthcare persons, especially on CLAPSI. So the expected outcome, if it is all done, the expected outcome is definitely there will be relative reduction in infections. For every procedures, there should be a timeout, whether we are doing correct, whether the procedure is correct, whether the patient is correct. So for every procedure, as it is an invasive procedure, so it is required for timeout. The rules for timeout, everyone can stop the procedure. That means the team of healthcare providers are there, from staff nurse, intensivist, radiologist, patient. Suppose a team of workers are there. So everyone can stop. Is it needed? Stop means it is not completely, there should be no central line catheter. It's not like that. Is it needed? Are we choosing correct patient? Are we choosing correct vessel? Like that, everyone can have a question. And sometimes we can include patient also. Patient can also ask a question that, is it necessary for me? Then we are supposed to answer the patient. If suppose only one healthcare provider is there, is it required to follow timeout? Definitely yes. Definitely yes. They have to question themselves whether I am following these 3 points in the checklist, or am I following correct or not. These 3 points are the correct patient, correct procedure, based on the evidence-based practices, and choosing of correct site. Especially when femoral vein is selected for central line catheter, the medical condition should also be included in timeout. To treat this medical condition, is it necessary to choose femoral vein compulsory? We are supposed to check out. If suppose any question comes from the team members, or all the team members should agree, or there is a possibility of disagree also, then each question should be discussed, and it should, the person who raised a question can come with certain solutions also. Just raising a question is not enough. So all the team members, irrespective of their seniority, senior doctor, junior doctor, senior resident, intern, it's irrespective of their seniority, irrespective of their status, either it is staff nurse or the provider or the position, HOD, professor, like that, irrespective of the position, if these healthcare providers work in cooperation, it is possible. Why these are supposed to work cooperatively? It is because to resolve the problem that was arised in timeout sessions, and to ensure every patient receives the safest care. That is our ultimate motto in healthcare system, is that every patient is receiving the correct treatment in the correct time. The evidence-based practices, these are very, very important in practicing when in the hospital or in your corporate setup or in your self setup also. These 5 evidence-based practices are maintaining good health, good hand hygiene, maximum barrier precautions should be taken, use of alcohol-based chlorhexidine for preparation of skin, optimal catheter site selection. Yes, we have discussed that femoral vein once again we are supposed to think. And daily review of line necessity with prompt removal of unnecessary lines. If this line is unnecessary, then remove. Today, shall we continue CVC? If the question arises, answer, and if it is not required, then remove the catheter. And why do we always say that hand hygiene, hand hygiene, hand hygiene? From morning onwards, you are vexed with this term, hand hygiene, hand hygiene, hand hygiene. If any microbiologist is here, they might have aware of Ignaz Semmelweis. Are you aware of Ignaz Semmelweis, students? Ignaz Semmelweis? In 1800s itself, he was a consultant in a labor ward. He observed, he is a Hungarian scientist, Hungarian doctor. he observed maternal mortality was high due to puerperal sepsis. This puerperal sepsis, if the incidence of puerperal sepsis will come down, then definitely maternal mortality can also be decreased. With this motto, he proposed his team members, why can't we attend a labor after hand washing? Only after doing hand washing, we attend labor, we attend delivery. And after completion of labor, again do hand washing. So you can imagine that was the era that hand wash, without hand washing, not even glove, without hand washing, labor was conducted. And this has become, the incidence of puerperal sepsis has come down, and definitely maternal mortality has also come down. So when hand washing importance was proved in early 1800s itself, but it gained its importance in recent past decades. Yes, we are accustomed to portable hand sanitizers. These hand sanitizers, instead of soap and water, as per CDC, alcohol hand rubs can be used, alcohol-based hand rubs, which are chlorhexidine. Alcohol-based chlorhexidine hand rubs can be used instead of soap and water, as these are active against many bacteria, fungi, mycobacteria, even enveloped viruses. And it is easy to carry, and it can be used in many times, many areas also. So I repeat one again and again and again, from morning onwards, though hand hygiene is important in prevention of healthcare associated infections. So our next one is maximum barrier protection. Who has to wear these maximum barrier precautions? Who has to follow these maximum barrier precautions? Only the provider? No. The provider and the person who is assisting also after maintaining proper hand hygiene, then they should wear head cap and ensure that this head cap covers all the hair, and wear mask. This mask should cover their beard, mustache, and it should be tied to their nose and mouth, and wear sterile gloves and sterile gowns. Not only the provider, not only the person who is performing, the assistant should also wear the same thing. And for the patient, as the maximum area should be covered with sterile drape. I show you one picture. I show you one picture afterwards. Then what you have observed, the last students, especially interns and PGs are there. Are there any interns and PGs? Definitely, I will get the answer no. So after maximum barrier precautions, performing aseptic technique. This aseptic technique is with alcohol-based chlorhexidine. This alcohol-based chlorhexidine is effective than betadine. It is proved by so many studies. And by using this alcohol-based chlorhexidine, the CLABSI rate was decreased by 49%, which was mentioned in the so-called study that was mentioned in down. Skin is prepared with alcohol-based chlorhexidine, which contains not less than 0.5% up to 2% of chlorhexidine containing 70% of isopropyl alcohol. And then if you observe, it is ample which is having this alcohol-based chlorhexidine. This ample is pinched off, hold the applicator down to allow the solution and saturate the pad. Press the sponge against the skin, apply chlorhexidine solution using a back and forth direction, and then it is important the excess fluid, excess solution should not be wiped off. It has to be allowed dry by itself. Approximately it may take 2 to 3 minutes. Then after that, the site selection is important. Correct site. Here so many clinical trials in patients, ICU patients, proved that if the femoral vein is selected, there is increased rate of infections as well as thrombotic complications. Higher rate of infections was noticed if femoral vein was selected, and higher thrombotic complications was noticed if femoral vein was selected. So whenever femoral vein is the choice of central venous catheter, think again and again. So the preferable order for central venous catheter is, the preferred one first is subclavian, then internal jugular, and the least will be for femoral. Yes, have you gone through the picture? By seeing this, a team of healthcare providers are there doing some work. This ultrasound guided insertion of central venous catheter. If you observe, the only one is with complete maximum barrier protection, that is mask, head cap, gown and gloves, and the rest of the two are like you. It is this fellow and this fellow. They are watching and they are near to the procedure also. So as per the evidence-based practice strategies, these assisted persons should also wear these sterile gown, sterile gloves, head cap and mask, if available, even goggles. As we have all crossed anatomy, and where the subclavian artery is present, it is from the substernal notch of this, from this much distance, and from the clavicle just below these inches, it is the anatomical landmark. When the procedure is performed by doing anatomical landmark, when the procedure is performed by US guided, there is a lot of difference. It was observed in different cohort studies that if the procedure is performed by US guided, the failed placement can be decreased, complications can be decreased, as well as first attempt failure can be decreased, and the duration of the procedure can be decreased. So as the advancement is, healthcare system is advanced day by day, better insert central venous catheter by US guided rather than by anatomical landmark. And special considerations for the site selection, these are if the person is having any anatomical deformity, or if the individual is having any coagulopathies, on hemodialysis patient. And as per 2000 National Kidney Guidelines, it is recommended against the use of subclavian vein for any central line unless use of internal jugular vein is absolutely contraindicated due to stenosis, due to the risk of subclavian vein stenosis. Suppose instead of subclavian, internal jugular vein is chosen for central venous catheter. It is better to choose left side, better to use right side to reduce the risk of mechanical complications rather than left side. So after insertion, apply sterile dressing to the insertion site before the sterile barriers are removed. And the dressing should be transparent, which is if available, it is preferred. And why it is preferred means to allow the insertion site. If the insertion site is oozing, then gauze pad can be used. And replace dressings when it becomes damp or loosened or soiled, or after lifting the dressing to inspect the CVC site. Then the other one, daily review of necessity. Daily review of necessity always when the team go for rounds, always check whether continuation of CVC is required or not. So daily necessity, evaluate medical necessity of intravenous catheter daily with the patient care team. The team of healthcare providers discuss the necessity of continuation of CVC. if the care team understands and communicates the reason for continuation of central line. If at all it is indicated that we can remove the central line, then remove these intravenous catheters as soon as possible to reduce the risk of catheter-related bloodstream infections. The another side, we are having central line guideware exchange. This guideware exchange is acceptable when replacing a malfunctioning catheter, changing a multi-lumen catheter to a single-lumen catheter, clinically stable patients with suspected CLABSI and limited venous access, and this catheter tip should be cultured and bled for culture, and sample should be sent for culture. If CLABSI is confirmed, then this CVC has to be removed. And guideware exchange is not allowed in the presence of tunnel or exit site infection. And the technique for guideware exchange, the procedure that is followed for insertion of CVC, the same procedure has to be followed. And remember, that is very important, remember to switch to a new set of sterile gloves prior to handling the new catheter. So, better to wear 2 sets of gloves before starting the procedure. And in summary of these all 5 evidence-based practices, all the correct indication, correct site, correct skin preparation, correct compliance, correct reason for continuation, and correct communication with the team to assure compliance with all the above. Instead of all these things, there is a possibility of CLABSI. Whenever this CLABSI is suspected, remove all dressings. There is a collection of blood is by two methods. It is by first method, remove all dressings and cap off all herb spots, then paint the site with antiseptic solutions and include within the sterile field. Remove line and block. Under no circumstances, that is, precaution should be taken that this catheter should not be cut prior to the removal. Remove the catheter aseptically. Avoid contact with patient's skin or catheter tray. So after removal, with the sterile scissors, 5 centimeters segment can be cut, and that is sent to the microbiology laboratory. In microbiology laboratory, semi-quantitative technique, by means of semi-quantitative method, it is cultured. If colonies are more than 15, then it is considered as CLABSI, and no other site is recognized as a source of infection. And a positive catheter tip by itself is not a diagnostic for CLABSI, and do not routinely culture catheter tips on removal unless there are clinical signs and symptoms of infection. The another method is draw blood, one set of blood through device and another set of blood from a separate venipuncture. Blood from both these lines must be positive for the same organism with clinical signs and symptoms and no longer recognized source. A positive culture from the line only is probably a contaminant and should not be treated. And the another alternative method for this, the time to detect is, I discuss in the next slide instead of duplication. We are having this, to say it is CLABSI, as per NHSN criteria, we are having surveillance definition and clinical definition. Surveillance definition means it is a laboratory confirmed infection where a CVC is in place for 2 or more than 2 days, 2 calendar days prior to a positive culture, and in also in place and a day or before prior to culture. So here we are having 2 scenarios. In example 1, if peripherally inserted central catheter was inserted on June 1st, patient became febrile on 3rd, and still PICC is in place, cultures were positive for Staphylococcus aureus. Can we consider it as CLABSI? Definitely yes. And in another set, PICC placed June 2nd, removed on 5th, and patient became febrile on 6th. And sample was sent for culture, and cultures were positive for coagulase negative staphylococci. Shall we consider it as CLABSI? If the organism is same from blood and the tip, then it can be considered as CLABSI if it is the only pure isolate. Then clinical definition means when it fills all these three criteria: clinical signs and symptoms, having fever, rigors, altered mental status, hypotension, no alternate source of bloodstream infection is noticed, positive blood culture from a peripheral vein with any one of the following, like catheter tip or segment culture that matches the organism grown from blood, at least five-fold number of organisms, grown from the catheter versus peripheral blood culture on simultaneously drawn cultures. And growth from the catheter drawn blood culture occur at least 2 hours before growth of the same organism from a percutaneously drawn blood. Here we are having a checklist whether we are performing a good procedure or we following all these procedures correctly or not. For clinicians and for facilities we are having. For clinicians, it is as per 2011 CDC guidelines. For clinicians, perform daily audits to assess whether each central line is still needed, perform hand hygiene before insertion, adhere to antiseptic techniques, use maximum sterile barrier precautions, perform skin antisepsis with alcohol-based chlorhexidine, choose the best site and cover the site with sterile gauze or the sterile dressings, and handle and maintain of central lines appropriately. And for facilities, empower staff to stop non-emergent insertion if proper procedures are not followed, bundle supplies to ensure items are readily available for use, provide the checklist above to clinicians to ensure all insertion practices are followed or not to follow, ensure efficient access to hand hygiene, monitor and provide prompt feedback for adherence to hand hygiene, provide recurring education sessions on central line insertion, handling and maintenance. Supplemental strategies for consideration. If at all these will be provided, it will be fine. To summarize the entire topic, a multi-pronged approach encompasses all the areas discussed above, only can lead us to solve the vexing issues of healthcare associated infections, and that too in particular CLABSI. These issues have acquired a global character and we do not exist in isolation. We are a part of globe. While respecting the international recommendations, we need to customize them to Indian conditions, keeping our strength and weakness in view. And multidimensional approach on CLABSI can reduce the rate. So, which will you prefer if multiple choice is given, prevention and cure? Definitely prevention. Definitely prevention. From ancient times, we believe that prevention is better than cure. Any queries? Thank you.
Thank you, ma'am. Now I'd like to request Dr. Zama Musi, madam, Professor, Department of Forensics Medicine, to felicitate Dr. Srilata, madam. Moving on to the next presentation, I would like to request Dr. Arshia Tazeen ma'am to introduce our next speaker for the day, Dr. Abdul Karim Bahadur sir, Assistant Professor and Infection Control Officer, Raichur Institute of Medical Sciences.
Good afternoon, everyone. I would like to introduce the next speaker for today's CME, Dr. Abdul Karim Bahadur sir, who is currently working as Assistant Professor and Infection Control Officer in the Department of Microbiology, Raichur Institute of Medical Sciences and Waqf Hospital, Raichur. He is a lead member of the infection control team for Lakshya and Kayakalp national programs. He is working as nodal officer for RT-PCR lab and tuberculosis culture and drug susceptibility testing lab, which is situated at the RIMS, Raichur. Today he will be speaking about surveillance and prevention of surgical site infections, analysis and interpretation. Please welcome Dr. Abdul Karim Bahadur sir. Thank you.
A very good afternoon to all of you. Am I audible? For those who are with me, can you raise the hands? Yeah? Okay. Thank you. So, I'm not going to discuss a topic today. I'm going to tell a story to you, right? So, all of are with me, right? Okay. So, from the morning we have learned so much about surveillance. I think we have become MD surveillance now, right? Okay. So, I will give you 2 tasks, okay, to see that how much efficiently we have learned surveillance. Okay. First task is, please, are you listening? Okay. The first task is the person right to you and the person left to you, you should not let him sleep. Fine? Okay. So that is the first surveillance target. Okay. The second surveillance is, you should see that the person right to you and the left to you is not peeping into the phone. Fine? Okay. So we have started our session with the 2 important surveillance targets. Let us see how much we achieve, right? And rest of the thing I will try to do. Now, we all know that the infection prevention started with Lister, right? So, in 1985 or in 1850s, the concept of disinfection and sterilization started. Using antiseptics started in 1850s, right? Before 1850s, whether there were no surgeries done, surgeries were done. Very, very efficient surgeons were also present. We talk about Ibn Sina, we talk about Charaka. They all used to perform surgeries. Excellent surgeons were there, but the mortality after the surgery used to be more than 50%. It was not because the surgeons were not perfect or they were less skilled. It was because of the infection. They used to perform excellent surgery, but ultimately the patient after post-surgery landed up in what? Landed up in infection. The patient lands up in infection, so fantastic surgery was done by an excellent surgeon, but unfortunately the patient lands up in infection and maybe the patient, the outcome may be very bad. Sometimes it may be a death of the patient, right? So this is what started. Now, after the Lister, we learned that we can use antiseptics and we can kill the organism. Those are causing these infections, right? But very soon we realized that the story is not that simple, right? The story is not that simple. We thought that we have won the game. After discovering very wonderful antiseptics, colorful antiseptics we keep seeing all the way in the wards, right? So we thought that we have won the race and we will be getting rid of all these hospital-acquired infections and post-surgical infections, but it was not true. What happened? Right. So we thought that we have won the game, but the organisms, we could kill the organisms where we can get access to. The organisms which are superficial we can kill. If the organisms are hiding somewhere, then it is very difficult. So we will be applying our disinfectants somewhere else, but the organisms are hiding somewhere else, right? So this is what has happened. You can see that the surface Staphylococcus aureus, the surface organisms which are present on the skin, our disinfectants can kill these surface organisms. But deep inside you can see that there are around 20 to 25% of the Staphylococcus, even if it is an MRSA or MSSA, will be hidden deep inside the appendages of the skin. So it is almost impossible. It is almost impossible to kill these organisms using antiseptics, and that is the reason that we are never going to get zero-level post-surgical infections. Whatever we do, United States have not been able to do, UK was not able to do, even we are we are toddlers in that particular race, but we can't expect that we will go zero. So definitely we will have some infection rates after surgery. But why what we are doing now in the CME? we all are planning and we all are strategizing, we are all are learning the way how to minimize the preventable infections. Those infections that we can prevent, at least those infections we can prevent and save the patient, right? So that is our target. So surgical site infections, so let us in short discuss about when do we say that the patient has got surgical site infection? Okay, so what is that criteria when we say that it is surgical site infections, right? Then how big is the problem, right? Is it the problem which needs a lot of attention or what? So what is the magnitude of the problem, right? That we'll see. And then what are there any risk factors? Are there specific patients who gets this infection more than others? If there are risk factors, what are the risk factors? That we'll see. And can we do something about it, right? Do we have something to do or something can we add up to reduce these infections? And lastly, we all know that something which we can't measure, we can't improve upon, right? Something which we can't measure, we cannot improve upon unless and until we measure the rate of hospital-acquired infection or SSIs, that is surgical site infection, will not be able to improve upon. Or even if we improve, we can't say that whether we have improved or not because we don't know what are our figures or what are our numbers. So when do we say hospital-acquired infection? This is very, very simple. Last benches, can you see the things? Is it visible? Say loudly. Okay. So it is very simple definition. What is after the surgery, wash for the patient for 30 days. If the patient is having infection at the site of your incision, then you categorize that as hospital-acquired infection. That is SSI, that is surgical site infection. But there are 3 surgeries that you need to remember. The surgeries related to the breast, cardiac surgery, and the joint-related surgery. In these 3 specific surgeries, you need to follow the patient for 90 days. How many days? 90 days. So rest all the surgeries, you need to follow the patient for 30 days. If there is an infection at the site of surgery, it is surgical site infection. If there is no infection, no. But for these particular 3 surgeries, you need to follow for 90 days. What are the types of this one? There are only 3 types of surgical site infection. It is not at all complicated. And it is very simple, right? 3 types, superficial. Superficial involving the skin and the subcutaneous tissue. So if only the skin and the subcutaneous tissue is involved, that is called as superficial surgical site infection, right? And you see for 30 days. Now there is no 90 days here. Even for the cardiac surgery or the breast surgery, you are going to wash only for 30 days when it comes to superficial SSI, right? But deep SSI, what is deep? Just go deeper to the subcutaneous tissue. What is there? Muscle and fascia. So if your infection has gone to the level of muscle and fascia, then we are going to call it as a deep SSI, that is surgical site infection. Here again the 30% rule and the 90% rule applies here, right? Now thirdly, more deeper than this, where the infection can go. Infection can go into the organ spaces. It can be peritoneal cavity, it can be pleural cavity, wherever. Whatever organ spaces are there, there if the infection is there and there is a pus formation, that is what is called as the organ space infection. Again, it is the criteria which remains same. What is not SSI? Okay, sometimes when we start seeing SSI, sometimes there are certain things which are not included into the definition of SSI. What is that? Commonly, cellulitis around the surgical area, right? If there is a cellulitis around the surgical area, that is not going to be called as surgical site infection, right? Then stitch abscess, only stitch abscess with minimum where you have put up the stitch, right? At the site of the stitch, there is small pustule formation. There is minimal inflammation. That is not going to be called as what? Surgical site infection. That is not going to be called as, that does not qualify the criteria for surgical site infection. Then you have again pin site infection. If you have staples and all that, if there is a pin site infection, those small infections are not going to be very localized with minimal infection. Inflammation is not going to be counted as surgical site infection. Burns infection, you operated and all that, but you don't know whether the patient is infected because of the burns and all that. All those cases are excluded from the surgical site infection. How big is the problem? Right. This is the Indian rate. What is the Indian rate? The best of the best premier institutes, they have 4.1. 4.1 patient. You mean to say if you perform 400 surgeries, 4 patients will get infected. If you do it in AIMS and PGI Chandigarh. Right. So that is the rate, right? I'm just giving an example for that one, right? Not necessarily meaning to like specifics of the this one, right? And 11, right? And this is what the author says, that it is optimal estimate. The figures even can go higher than this one, right? So up to 11, so you perform 100 surgeries, 11 patients out of 11 patients out of 100 will get hospital-acquired infection in form of SSIs. So that is the problem. Right. What is the rate in the US? The US rate is 0.3 to 2. So US, United States, it is 0.2 to 3. Right. So this is the this one. So this is the journey that we have to go and achieve. Readmission. Once the patient gets SSI, then there is a 15 times higher chances that the patient will come back and get readmitted to seek the treatment for SSI. 15 times higher chances. And then admission to ICU, right? 60% risk of getting admitted to ICU, right? This is again a problem because all things, everything is going to be converted into either the morbidity, mortality or the health cost, right? Excess of hospital stay. On an average, SSI patient, once the patient gets SSI, 9 extra days of hospital stay, right? And then cost of each SSI, $3,000 per SSI. Can you convert into rupees? Around 2.5 lakhs. Suppose if the government says yes, at least you pay half because it was because of you, this surgical site infection happened, you can pay half, the hospital may pay a half. So 1.5 lakh rupees we have to shell out for each hospital acquired infection, if that is the case, right? So that is just to understand how the dynamics goes. SSI mortality is 3%, right? Around 3% of the patient may land up into or succumb to this one, right? What are the risk factors for SSIs? Risk factor, right? Patient-related risk factors. Wound class. I'm going to discuss. We have 4 classes of wound on the basis of how much contamination is there in the wound. What is the amount of contamination? How much? What is the like inoculum, right? 1 to 4. The higher the grade, more chances of getting the patient infected. Age more than 60 years. Malnutrition, diabetes mellitus, immunocompromised patient. Age more than 6 years. Now, age is again an interesting this one. Some of these studies have shown that as the age increases, actually SSI decreases. If you take care of other things, right, like diabetes, if you take immunocompromised status and all that, if you adjust the rates, then actually the age is not an important factor which increases the hospital. Malnutrition. Please see that the patient is very well nourished and at least the albumin level, the serum albumin level of the patient is maintained, right? If not, put the patient on supplements and then take for the surgery if it is an elective surgery. If it is an emergency surgery, you can't do anything. But if you have a choice, then if you feel that the patient is having a very low BMI or the serum albumin is not appropriate, you can put the patient on supplements, nutritious supplements, let the patient pick up and then you take the patient for surgery because it is a very, very important factor. Diabetes mellitus, right? Patients have multiple problems like staphylococcal MRSA carriers are more seen in diabetes. Healing is delayed and all that. Immunosuppressed states and all that, right? MRSA carrier, right? If the patient is having MRSA in the nostrils, it is proven that these patients who have MRSA in their nostrils, they are 4 times more, they get 4 times more infections than the other patients. So they are 4 times more prone to get surgical site infections than others. Longer the stay, right? Longer Longer they stay, more. Now, I visit to the post-op ward, I visit to so many ward and all that, and I ask the patient how many days post-surgical this one you are there. So sometimes the patient is there for 10 days, 15 days, sometimes 20 days. Nobody knows that why the patient is still admitted, right? Sometimes something happens and why the patients are admitted so long, we don't know. We need to keep this in check, right? More the patient is going to stay in the hospital, more chances, pre as well as post. Don't call the patient 4 days before surgery, get admitted, and we'll do all the things and all that. No. Please call the patient when it is really needed, right? Don't just pull on after the surgery, right? Obesity, you have to be careful. If you are dealing with an obese patient, there is chances of SSI more, and hypoxemia. Poor skin preparation in the procedure-related thing. If we have not taken care of the skin preparation properly, chances of SSI will be more. Then, shaving. Now, it is a custom. It is a custom and a tradition that we shave the patient before we take the patient to the surgery. Is it fine? All of you know that? Yes? Yes or no? We shave the part, right? We shave the part before we take the patient for the surgery, right? So this is the a tradition, and this is the custom that we following from a very long period of time. But now this is beyond doubt. It is clearly now evident that it is a practice that we need to discourage now. It is a practice we need to discourage. If you are shaving, what we have to do, we will discuss. But shaving has to be stopped, right? Then long operating time, like the patient, the surgeon was on phone for something like maybe 10 minutes or, this is the thing, right? Every minute in the operation theater counts, right? Longer it is going to take for the operation, more chances of SSI. So we need to be eager to complete the surgery and put the patient out of OT, right? Rather than pulling on, right? So that is, and again, longer it takes, there are multiple factors why the long surgeries, because long surgeries are complicated, long surgeries are hemodynamic, and oxygen saturation will not be maintaining all that. Multiple factors will be there that will lead the patient to land up into the SSIs. Inadequate antimicrobial prophylaxis, right? All the patients who are having electively selected for the surgery, we have to put on antimicrobial agents, right? There are very few exceptions otherwise, right? Glycemic control, right? Strict glycemic control has to be monitored. If glycemic control, if it is more than 180 to more than 200, then definitely the patient has higher chances of SSI, right? Hypothermia, this is very, very important. So, recent studies, I'll just discuss that one later, right? Hypothermia, we are not concentrating whether the patient is shivering, going into the OT or what, right? So, hypothermia, maintaining normal temperature of the body while surgery, during the surgery, and even in the post-op period is very, very important. So, this is the class of this one, 4 classes. Class 1, clean infection. Not clean infection means all those procedures wherein there is no infection at the site of incision and no hollow viscous is entered. No hollow viscous is entered and there is no infection. It is a clean wound. Second, clean contaminated wound. Clean contaminated wound, hollow viscous is entered. Hollow viscous is entered but in a controlled manner. For example, appendicectomy. So you have done an appendicectomy. You have entered into the hollow viscous but in a controlled manner, right? That is what is the, or biliary surgeries, right? Class 3, contaminated wound. Contaminated wound, open wounds, accidental open wounds. These are contaminated wounds. And if there is a gross spillage from the GI, colonic surgeries. If you do a colonic surgery, a lot of colonic content may spill into the abdominal cavity. Such wounds or procedures are going to be categorized as 3, that is contaminated. 4, these are dirty wounds. Dirty wounds means already there is a established peritonitis or already there is a intraperitoneal or subhepatic abscess and etc. So already there is an infection which is already there, and then you open the abdomen and you find that it is a peritonitis, and that type of infection are going to be categorized as type 4 infection. So type 1, you see that 2% chances of getting surgical infection. Then in the second one, 3 to 11% chances. Third one, more than 10%. Then in the dirty wound, if the patient is already having established peritonitis and there is a lot of debris in the wound and there is a lot of infectious material that is already you are seeing before you are starting the operation, that means that the patient is again going to have chances to around near to 40% chances of getting infected post-surgery. So what can we do about it? Right. Preoperative bath. Right. So can we give the patient preoperative bath with chlorhexidine 4% solution and reduce the bioburden, reduce the organisms that are present in the body, right? So this was very logical and we did it for a very long period of time, but unfortunately WHO says that there is no evidence, right? By giving a chlorhexidine wash, hardly there is any evidence, but very recent studies have shown that no evidence was because of the very short contact period of chlorhexidine. If you keep the chlorhexidine for 2 to 3 minutes, then definitely people are expecting, the researchers are expecting that you will definitely have a beneficial effect. Plain or plain antimicrobial soap, or so the bath is compulsory. So WHO says that any patient that you are taking for surgery, you need to make the patient bath, right? Using the soap, let it be an antimicrobial soap or it is a normal soap, but the bathing is compulsory. That is WHO what it says. Decolonization of MRSA. Check the patients, high-risk patients, those patients who are going for knee surgeries or the cardiac surgeries, check for nasal carriage of the MRSA. If the nasal carriage is present, clear of the nasal carriage before taking for the surgery. So that is what is the this one, orthopedic surgeries and CT surgeries, we need to follow this rule, but not the other surgeries. Routine surgeries, it may not be required, right? But if there is a past history of MRSA carriage for the patient and if any other part of the body is having MRSA, then you can still go for MRSA, this one, therapy, right? Decolonization therapy. How do we decolonize? We use 2% mupirocin nasal ointment 2 times a day for 5 days. So you start it 1 day before the surgery and during the after the 3-4 days after the surgery. So this is the regime that you follow, and this is the decolonization of the MRSA, and this is going to definitely decrease the SSI. Hair removal, it is not the shaving. Shaving should not be done. WHO says that if it is possible for you to perform the surgery without removing the hair, you perform it. Right? Why there is a need for removing of the shaving of this one, anything, why? Right? So that is what is the WHO's recommendation. But it also says that wherever it is required, you can use the clippers or you can use the creams. Now creams is not said by the WHO, but other agency recommends the cream that dissolves the hairs, right? Time, it is the same day. Usually what happens, the shaving happens one night before or 1 day before, something like that, right? But whatever is evidence, it says that the same day, on the same day of the surgery, right? If the patient is going to go for surgery at 10 o'clock, just have a shaving a few hours before, right? So that is the standard practice, what is recommended by the NICE. Surgical site preparation, most of the literature says that it is alcohol, but recent literature suggests that alcohol plus chlorhexidine, and which is also recommended by WHO. So alcohol plus chlorhexidine is the best solution that you can use to prepare the part of the body before giving the incision. But povidone iodine and aqueous solution of povidone iodine is also available. WHO says that WHO doesn't say or doesn't recommend, but it doesn't say that no also. You can use those things also. Preoperative glucose. So it is one of the very critical thing, right? 140 to 200 glucose should be maintained. But again, very recent studies, I was just seeing, very recent studies have shown that even lesser till the level of 110, right? 110. If you can bring down the glucose level to 110, then still you can reduce the chances of post-operative infections. But again, if you go that low, there is a chances of hypoglycemia. That is a problem. post-operative oxygenation, just sir was discussing, right? So instead of giving normally 30% oxygen FiO2, if we increase the FiO2 80%, there is a drastic reduction in the SSI, right? Surgical site infections will be controlled just by this particular single, just give the patient. So all the patients who are taking general anesthesia, right? All the patients to whom we are putting on general anesthesia, instead of giving 30%, go for 80% FiO2, then there will be substantial decrease in this one. But not only this one, not only at the time of surgery, post-surgery also for 3 to 4 hours, like, or 2 to 6 hours, you need to maintain 80% oxygen. Maintain body temperature. This was the thing that I was telling, right? It is like, why the body temperature? I got a question. Why it is so much important? So many randomized controlled trial has been done on the hypothermia. Why hypothermia is increasing the chances of surgical site infection? The important thing here is to understand, the lower the body temperature, lower is the capacity of the neutrophil to kill the bacteria. So the immune system is directly affected. Okay, so immune system is directly affected. That's the reason that we need to maintain the temperature, right? And special arrangements can be made for circulating hot water circulating devices, blankets and all that we can use to maintain the body temperature. Now, we all know that we have to maintain the if it is a hypovolemia, we have to correct the hypovolemia before taking the patient for the surgery. Now, this is the antimicrobial prophylaxis. So, it is indicated in almost all the wound except few of the clean wound. We have to put the patient on antimicrobial agent, right? Timing. Now, this is very important. This is a very, very controversial topic. There is no controversy whether we have to give antibiotics before the surgery or not. It is clear. We have to give only. The discussion is only when we have to give, right? When we have to give. So, WHO recommends us 120 minutes, but most of the other agencies says that 1 hour before taking the incision. 1 hour before taking the incision, right? So, that is very, very important. We need to maintain. Now, if tourniquet is tied up, 15 minutes before inflating the tourniquet, you have to push all the drug, right? Vancomycin, it takes long time for infusion. That's why 2 hours before you need to start, because the infusion of vancomycin itself takes 2 hours. Even the fluoroquinolones. Redosing, if your surgery is more than 4 hours, if the surgery is prolonging for more than 4 hours, again give another dose, right? Now, how long we need to give this antibiotic? I have seen patients admitted for some surgery, for 10 days they are taking the same antibiotic. 7 days they are taking the same antibiotic that was given as a prophylaxis for the surgery. That is not the case. It is more than clear that it is only the single dose, right? It is only the single dose. It is only the single dose that the WHO mentions. Only a single dose. If there are risk factors associated, then you can add up or increase it for 24 hours or 48 hours, depending upon the risk of the surgery. But never more than 48 hours. SAP never goes. That is the prophylaxis that you give for surgical, this one, it never goes beyond 48 hours in any situation. Even for the cardiothoracic surgery, it is not going to go beyond 48 hours. So, leave about pulling it for days together. These are the agents that we use. Now, detailed recommendations are available. You can download from the NCDC website. What are the different procedures and what are this one. Now, one important thing I just wanted to, this one, cefazolin is the most common agent that is used. Those who are surgeons here, please, I just wanted to share one thing. Cefazolin, a lot of work has been done on cefazolin. A lot of randomized controlled trials has been done on cefazolin. So, we started with 1 gram of cefazolin, and now the standard dosage is, if the patient is less than 80 kg, 1 gram. If the patient is more than 80 kg but less than 120 kg, it is 2 gram. If the patient is more than 120 kg, it is 3 gram of cefazolin that we are recommending now, right? Okay, I'll skip this one because now there are certain novel agents, antimicrobial skin sealants, right? Like this. Okay, after the surgery, there is a gel-like thing which is having antimicrobial activity. After the surgery, can we just put it these sealants, right? But there is no benefit of doing this one. Secondly, plastic antimicrobial adhesive drapes. Instead of using normal cotton drapes and all that, can we go for antimicrobial plastic drapes can that bring down the infection? WHO says that there is no benefit in that one also. Right. Incision, incisional wound irrigation with antibiotic. Can we put antibiotic into the wound and then we can close? Okay, povidone, iodine, these that we put, but whether can antibiotic affect? Antibiotic have also shown that there is no benefit of that one. Right. Advanced dressing. There are so many post-operative dressing have come. Okay, very different dressings have come. Whether they are useful, WHO says that please don't use them. Here it is a discouraging. WHO is discouraging use of newer dressings. Laminar airflow. Now it is very, very controversial. Being a microbiologist, I'll say that it's a very, very, WHO says that there is no evidence of laminar airflow, but still a lot of work has to be done onto this particular, especially when it comes to the cardiothoracic surgery, neurosurgery, and joint replacement surgery. Still, this is, the evidence is evolving. Right. Something which works, double gloves. Right. Although WHO doesn't say that double gloves helps, but other agencies says that you put double gloves, there is a possibility of decrease in SSI. Then antimicrobial coated sutures. When you are suturing, can you use antimicrobial coated sutures? Yes, WHO shows that you can use it and that reduces the surgical site infection. Wound protector devices. There are certain wound protector devices. We pull the wound edges and all that and then use some instruments to pull, and there is a chances of trauma that happens onto the border of the wounds that we create. So to avoid that one, there are special devices that I will just show you that we can use, and it can reduce the surgical site infection. Prophylactic negative pressure wound therapy. Now again, this is also a very, very upcoming thing, and WHO says that please go for it wherever at least it is recommended. These are the wound protector devices. Now once you make a wound and then you insert this one, and then you can increase or decrease the lumen of the wound so that it is not giving any pressure onto the borders of the wound, and safely it is curtailing the possibility of infection also. So this is recommended. Now this is the negative pressure wound, especially for the obese people. Especially for the obese people, after the surgery we can put this negative pressure therapy, and there are different designs that has come up into the market, and we can use that one, and that has its own advantage, and WHO recommends that one. Surveillance for this one. Now surveillance, we all are master of surveillance, right? Right? You all have become master of surveillance, right? So I'm not going to go into much details of the surveillance now, but only thing is that please remember that definition. 30 days you need to follow the patient. After doing surgery, patient will go to a village. You have to keep calling the patient till 30 days to know that whether the patient is developed. So it is not easy. So surveillance of SSI is more difficult than the surveillance of any other hospital-acquired infections. So that is one important challenge, right? So you need to keep calling the patient, telephonic conversation and all that, and there are terminologies and all that. I'll not go into detail of all these terminologies because you people have to get trained before you get into the surveillance of this one, right? So these are the two important rates. What? So how many surgeries you have performed in the last month? Okay. How many surgeries were performed by the Department of Surgery last month, and how many patients got infected? So number of SSIs reported and number of surgeries done into 100, that will give you the SSI rate. Okay. Why it is useful? It is useful to check last month what was the rate, this month what is the rate, next month what is going to be the rate. So it will help you to have a check that whether your infection rate is going up or under control or going down. So to keep this one. Now this is very much useful to keep the records, keep checking inside your hospital. So to your in facility this one. But if you want to compare the infection rate of your facility or your hospital with some other hospital that is there in the United States of America, right? How can you do that one? So that you can do by using what is called as the standard infection ratio. There is a number of SSIs observed, number of SSIs predicted. Now predicted SSIs is going to be calculated by the international, national or this one standards, right? So this can be done. So either this can be more than one. That means that to the center that you are comparing, your rate is more, right? That means that SI is more, right? So this is how you are going to interpret the results of your surveillance. So hope this is done. Thank you.
Thank you, sir. for your extensive coverage on surveillance and prevention of surgical site infection. Moving on to the final presentation for the day, I'd like to invite Dr. Javeria Firdaus ma'am to introduce the speaker, Dr. Nagarkar Rajan sir, Professor, Department of Microbiology, ESI.
Good evening, everyone. I hope you all are having a good time. Now, I'd like to introduce our last speaker for today's CME, Dr. Nagarkar Rajhans Kishan Rao sir. Sir is presently working as Professor in Department of Microbiology, ESI Medical College, Kalaburagi. Sir has completed his MBBS from MGM Medical College, Aurangabad, Maharashtra, and MD Microbiology from GMC Medical College, Aurangabad, Maharashtra. Sir has a teaching experience of 14 years. Sir has published various articles in various national and international index journals. He is the coordinator of Medical Education Unit since 6 years. He is a resource person for revised basic course workshop and CISP trainings. He is the nodal officer for biomedical waste management in ESIFC Medical College, Kalaburagi. He is also the resource person for sensitization program on BMW management for doctors. Today, sir will be enlightening us about biomedical waste management. So please welcome Dr. Rajan, sir.
Good afternoon for this introduction. At the outset, I would like to thank Siddesh sir, Bilal sir for giving me this opportunity. And I congratulate KBN University for organizing such a wonderful CME. And all the topics were relevant for the UG students. I am taking the last session, so I will try to cover it as early as possible, guys. Don't worry about it. I just want to know the students who have made the models. Just raise your hands. Students who have made the models. So, big round of applause for them, guys, because all the models are too good. And regarding few models related to my topic are only there. So, this symbol, anyone knows what is this symbol? What is this symbol, guys? This is a car, okay? This is a car symbol, and this is the well-known brand in the cars, that is BMW. And this car, the full form of this BMW is, yes. So this one is the BMW full form. I don't know how many of you are knowing this, but
Check, check, check.
And this symbol, what is this symbol? In the morning, RC ma'am told this. What is this symbol? This is biohazard symbol. So this was developed in 1966, and it is used for labeling the biohazard, the material which is generated in the hospitals, and it will cause infections to many people if this is not properly managed. Now this is another symbol used in biomedical waste management, and it is related to the cytotoxic waste which we generate. We will go into details of this. Only thing I would like to highlight here, guys, biomedical waste management is one of the most important thing, but maximum neglected in the hospitals. So here, what we will discuss in this particular session, segregation of the biomedical waste will be most highlighted. Then standard protocols. We have to manage the biomedical waste management very nicely. In the morning session, at the inauguration session, Ali sir told us that difference between management and administration. So administrations have rules, but in management, we try to manage the things. But for managing the things also, protocols should be followed. Then we have integrated system for this biomedical waste management. Integration means we have to come together. Now due to CBME, we all know there is an integrated class also for you. Similarly, biomedical waste management should be managed in an integrated way. So what comes, we have Gazette. This is a legal document in India. Unless a document becomes legal, nobody listens most of the time. That's why for biomedical waste management also, there is a legal document, and this document was released in 20th March 2016. Then small changes were done in these legal documents. They are called as amendments. So to amend means to make a minor change, and these amendments were done in 16th March 2018, in which the hospitals were told to update biomedical waste data on their respective websites. Then again 19th February 2019 and 10th May 2019, biomedical waste management amendments are done. So now recent guidelines, if you ask me, we follow 10th May 2019 guidelines, in which 2016 guidelines are the base. Coming to next, what is biomedical waste management? In that, the waste generated during diagnosis, treatment, immunization of human beings, research activities, and the most important thing, production and testing of biological products. So all these comes under biomedical waste. We have to manage this. How to manage this biomedical waste and why? Because every time we should ask ourselves why I should listen to this topic. Because if this biomedical waste is not properly managed, we can have human and animal soil waste can have health hazards like HIV, hepatitis B. The sharp equipments which are generated in our hospitals, they can cause transmission of HIV and hepatitis B virus. Another thing, on 5th June, there was one day. Anybody remembers what was 5th June? World Environment Day. So this biomedical waste management, if it is not managed properly, it can damage our environment also. So it has, our biomedical waste has cytotoxic as well as radioactive waste. So that is another disadvantage. It can cause cancer, genetic mutations. More than that, the thing is that chemical waste which we are generating, they are also having dangerous health hazards like poisoning, dermatitis, conjunctivitis, and bronchitis. After knowing at least these hazards, guys, you should concentrate on your biomedical waste management. The interns who are sitting here, day to day we generate waste. Once we are a doctor, we are generating biomedical waste because during procedures, number of biomedical waste we can generate during a single procedure also. So how to manage that? For that these guidelines are there. And why I am talking this again and again, health hazards we know, but WHO has told that biomedical waste is lowest priority. Biomedical waste management is considered as the lowest priority in most of the institutions. To overcome this, we will know how to do the biomedical waste management. For this, we have Ministry of Environment, Forest and Climate Change. This ministry gives us the guidelines, and these guidelines will be first given by CPCB. This is Central Pollution Control Board. Here, if you don't listen to me also, I request you, please go to this website of CPCB. You will know all the guidelines which I am going to discuss in the next slides. So CPCB, after that we have Central Pollution Control Board. These two boards, they take care of biomedical waste management in the clinic, in the medical college, or in any hospital. Then we have DLMC, that is district level monitoring committee is there for biomedical waste management. Now, why we should be worried? Why we should be worried? Because Central Pollution Control Board, it gives show cause notices. So this last line you can see, if a hospital is not doing biomedical waste management properly, in the year 2022, they have given 13,389 show cause notices. I request the organizing committee to look after this, because to a medical college that particular show cause notice will be given, and occupier, that is highest person in the chair, is responsible for mismanagement of biomedical waste, and for this fine is also there. So the biomedical waste management is more hazardous because it is incinerated. The waste is incinerated. Any UG student second year knows the definition of incineration? Burning to ash. Burning to ash is incinerator. So this incinerator, they release pollutants in the environment. Other than that, these incinerators, they are responsible for releasing POPs. These POPs are unintentionally produced persistent organic pollutants. Please remember, guys, these are dioxins and furans which can cause cancer to us. So don't think that incinerator is working 75 kilometers away from us. From there, the air can come and the dioxins and furans can go in our body also. That's why biomedical waste management is important. The main steps of biomedical waste management, in that the first and foremost step is segregation. I request all the students, segregation is our role. Our means doctors, nurses. Segregation at the point of generation. I can see few technicians are also there. When you are doing a test, how to segregate that biomedical waste is your role. Unless you do it properly, the whole thing will fall to zero. So this is a signal. What is this signal? This is the traffic signal. Which are the colors in this traffic signal? Yellow, red, and green. In biomedical waste management, we have 4 color codes. Just imagine, in previous guidelines, 2016, I told you, new guidelines are released. Previous guidelines were 10 categories. In the 10 components, the categories were divided. It was made easy now, and we have only 4 categories. The categories are divided based on the color code. First category is red category, then yellow, blue, and white. We have to just segregate the waste according to these 4 categories. So this is a video. It is available on the Central Pollution Control Board website also, and IMPRI has given this video. Instead of going into details of that, I will just try to tell you the categories I told you: red, yellow, blue, and white. So here you can see yellow, red, blue, and white. This is white, guys, not the stool. Stool is not the criteria. Otherwise, you will all go and throw the biomedical waste on the stool. On that stool, white container is kept. That is a category. Please remember it properly. Then we have, in yellow containers, we have to segregate the waste. This is completely theory. I won't make you bore by just reading this theory point, but all the atoms, the components which needs to be put in yellow, that you should memorize. I always tell to the students, some things we should memorize, and this is one of the components. Unless you memorize this, you won't be able to segregate the waste. When it is important, just simple example, when you are in, those who are interns, if you do dressing, just one example, if you do dressing of a patient, if you remove the dressing, you want to put a new dressing, that dressing material should be discarded into yellow bin, guys. So this is the most important criteria. Then, other than that, the biohazard symbol will be there on each container. Then, this is new guideline. This was amended. It was a minor change from the 2016 guidelines. And as per the new change, blood bags needs to be disposed in yellow bags. Blood bags needs to be disposed in yellow bags. Blood color is red. But this is the only red and yellow combination. There is another red and yellow combination that I will tell you in subsequent slides. Blood bags needs to be discarded into yellow bags, but it needs to be pre-treated. The bags needs to be pre-treated, and that is another criteria. So we have to, we have to tie the bags. We should not just throw them or just give it to someone. After this, the microbiology, pathology, and biochemistry waste will also go to microbiology, yellow bag, and that should be autoclaved. The waste generated in the laboratory needs to be pre-treatment, and it is autoclaving, then it should be given into the yellow bag. Now coming to this criteria, in which that C symbol was there. We have seen this C symbol. This is related to the cytotoxic drug or anti-cancer drug. We cannot throw the anti-cancer drug wherever we like. So they needs to be going into these yellow bags only, and these yellow bags will have discarded expired medicines as well as cytotoxic drugs. Now, pre-treatment is for laboratory waste, microbiological waste, and blood bags. How pre-treatment can be done? Other than autoclaving, we have microwaving, hydroclaving, and disinfection at site. So in this disinfection at site, we should not use chlorine disinfectants because that chlorine will be burned in the incinerator and hypochlorite ions will be released, which are again dangerous to environment as well as to us. Now red color code. In this red color code, simple criteria, guys. All plastic, all contaminated plastic will go to red bags. And only one yellow atom will go into this is gloves. Gloves will go to red bag. Gloves will go to red bag. And this is the key point here. Most of the hospitals, they are having mistakes. The gloves are discarded into yellow bag. This, if you remember, that is more than sufficient. Then blue color code, in this, all glass material will go. All the glass material, but other than glass material, in the blue color code bin, we can also discard the implants. Any orthopedician here, the implant should go into blue color coded bin. I have seen doctors not at all following the guidelines because we have worked in the hospital. Just a message, if you do this segregation correctly, it is our duty to do segregation at the point of generation. Then this is a new guideline, guys. If we don't have a container, which is plastic bin, we can use cardboard boxes and convert them into blue color coded bins. We can use the cardboard boxes, medicine boxes. On that blue tape we have to put, and such type of biohazard symbol is more than sufficient, and then it will work out. Then metal implants and prosthetic waste can also go into this. The last white container in which sharp item will go. We have to take care as a doctor about this, because in our hospital we have seen the needles were thrown or discarded into wrong container, and a housekeeping person picked up the bag and they got the injury. So these were practical difficulties. When you will go internship, then also you will get needle stick injuries, but that cause is different. Just imagine a housekeeping person is getting HIV or hepatitis B due to our mistake. That is doctor and nurse not discarding the needle correctly into the white container. So this is our duty. We have to do it. And the next thing is such containers were previously used, but nowadays more modified containers are available for biomedical waste management of sharps. This particular thing is, guys, ETP. In medical college, STP and ETP is must as per Central Pollution Control Board. Anybody knows the full form of STP? Sewage Treatment Plant. And ETP is Effluent Treatment Plant. Till now, whatever we have seen was solid waste. But when we want to discard the liquid waste, we should use Effluent Treatment Plant. And the liquid waste generated in hospital is ascites fluid, pleural tapping fluid, or urine sample also. It should not go into bin. It should not go into the basin. It should go into a basin which is connected to the effluent treatment plant. Then it will be taken care and chemically it will be treated, and then it will go to the sewage treatment plant. This is one of the criteria. If you open your own hospital also, you have to get a ETP. So aspirates, as I told, ascitic fluid and other aspirates, X-ray developing solution and X-ray fixing solution can also go to this particular thing. This is one entity related to administrative thing. The biomedical waste which we are generating, as I'm repeatedly telling, segregation at the point of generation is the main key. After that, the waste will be given to CBWTF, and this CBWTF is Common Biomedical Waste Treatment Facility. In a 75-kilometer area, it will be given one CBWTF away from the hospital. It will be nearer to 75 kilometers, and they will treat the waste. So don't worry what will happen to the waste. It will be treated by CBWTF. But whole efforts of CBWTF will be futile if we don't do the segregation correctly. So most important message from my talk is segregate the waste at point of generation. If you pick up anything in your hand while working in the hospital, you must remind to yourself first whether it will go to yellow bag, red bag, white or blue container. Then since morning we have seen many committees are there, HICC, Hospital Infection Control Committee, but Biomedical Waste Management Committee is also recommended by National Medical Commission. And you can see here in that many people you can include so that the biomedical waste management will be done properly. So in the Biomedical Waste Management Committee takes care of training to the people whom we should train: housekeeping staff, nursing staff and doctors. In our institute, we are conducting, once the induction training is over, this training must be conducted yearly once. Once in a year, refresher training is required for biomedical waste management in the hospitals. So during the biomedical waste management, if any accident happens, there are two categories: major accidents and minor accidents. The major accidents is any truck which is carrying the biomedical waste topples. If it falls down or if any accident happens to that truck, then it is called as major accident. Similarly, accidental release of biomedical waste in the water body will be called as major accident. And in the minor accident, needle prick injury and mercury spills are the minor accidents. Please remember, guys, you will run if you get a needle prick injury to medicine OPD. Instead of that, as everyone is telling you, prevention is better than cure. So try not to get the needle prick injury whenever you are working in the hospital. The steps for post-exposure management, this is given theoretically in our second year books also, so you can go through it. Monitoring the biomedical waste management, committee needs to monitor the biomedical waste. There is a formula for whether the auditing is done properly or not. For that formula is there, but it is practically difficult. We have to take out all the waste from the bin, then count it whether it is correct, then we have to report it. Instead of that, I request you, once in a while, that is in the afternoon session, just go in the wards, take the photograph, whatever waste is seen in that bin. And if there you find any mistake, you have to tell the nursing staff, you have to tell the concerned doctor that this particular thing went wrong. Our experiences, due to training in our institute, biomedical waste is done up to the 90% correction. Compliance is 90%, I can assure you. Repeated training is important, and commonest non-compliance we have found in our institute is gloves were discarded in wrong bin. Gloves should be discarded into red color coded bins. It were discarded into yellow bins. So as a medical educationist, guys please be attentive. Last slide. Who is this hero? Who is this hero? Ayushman Khurrana. There was one movie, Dr. G came, and in that Ayushman Khurrana does, he is with a nurse who is, they are talking about a case. You can see here, the nurse is discarding the gloves in a bin which is blue color, and the cover to that blue bin is yellow, and she is discarding that into it. So here only we can remember lifelong. If in Ayushman Khurrana movie it has gone wrong, I will never repeat this and I will never do this mistake. Like that, this is called as cinema education. Through cinema we can learn many things. So this was my attempt to tell you one take-home message through my slide. So thank you very much, guys. Thank you for listening patiently.
Check. Thank you, sir. Thank you so much on that wonderful presentation on BMW. Not the car, but biomedical waste management. Moving on to the last segment for the day, we have the valedictory ceremony. So there was a microbiology model presentation, and KBN Medical College and Gulbarga Institute of Medical Sciences had participated, the second year students. There's going to be a prize distribution. We'll find out who won what. I would like to invite Dr. Siddesh Sarwar sir, Dean, Faculty of Medical Sciences, KBN University, to give away the prizes. So who do you think won the first prize? KBN or gyms? I'll say gyms. Let's not be biased. Who do you think won the first prize? Which group in KBN? Which group? 4. Group 5. Can we have the group 5 representative to come up on the stage to collect the prize? Can we have a big round of applause? So these models were judged by the resource persons who had attended today's conference. There was a criteria on which the marks were given. The second and third position is shared between two groups, Group 4 and Group 3. So can we have the representatives from Group 4 and 3 to come up on the stage?
KBN, Group 4.
Yeah, Group 4 and 3 from KBN. Yeah, we also have gyms, which is going to come. And do you guys know what is in the envelope? Envelope has a brochure on antibiotic resistance and sensitivity. Because it's all about microbiology today. Okay? And the third place is again shared by two groups. Group 8 from KBN and Group 3 from gyms. So can we have the representatives? Gyms representatives and KBN. Group 8 from KBN, Group 3 from gyms. I'd also like to request all the participating members from these respective groups to please come up on the stage for a group picture. Quickly. KBN, gyms and everyone. Yeah, all the members of these groups, please come up on the stage for a group picture. Quick. Quick, quick, quick. Group 5, Group 4, Group 3, Group 8, and Group 3 from gyms. And the other group representatives who have not won today, please come up on the stage. Apart from this group 5, 4, 3, 8, the other representatives from other groups, please come up on the stage. Come, come, come. Come.
Good evening, everybody. Now I would like to request Dr. Irfan Ali sir, postgraduate in the Department of General Medicine, to give the valedictory speech.
Thank you, ma'am. Good evening, distinguished guests, esteemed speakers, delegates, ladies and gentlemen. As we come to the closing of the Hospital Infection Control Conference, I stand before you to deliver this valedictory speech on behalf of the organizing committee. I would like to express my heartfelt gratitude to all the esteemed speakers who graced this conference with their presence and shared their expertise. Your knowledge, passion, and dedication have enlightened us all, expanding our understanding of infection control practices and also inspiring us to strive for excellence. Your contributions have left an inedible mark on this conference, and we thank you for your invaluable insights. I also extend my sincere appreciation to each and every participant who attended this conference. Your active engagement, your collaborative spirit have made this event truly remarkable. A special acknowledgement goes to the organizing committee, volunteers, and even staff who have worked tirelessly to ensure the success of this conference. Lastly, I would like to express our appreciation to the healthcare professionals, researchers, and organizations who are committed to the cause of infection control. Your relentless pursuit of excellence, tireless efforts, and dedication to patient safety are commendable. Together, we are making a difference in preventing hospital-acquired infections and creating safer healthcare environments. With this, thank you all. I'd like to request Dr. Bilal Ahmed Mir sir, Professor and in charge head of the Department of Microbiology, to deliver the vote of thanks.
Good evening, all. It's a great honor and privilege to present the vote of thanks on this memorable occasion. Let me first of all start by giving glory to the Almighty Allah for making today's occasion a resounding success. I, on behalf of organizing committee, convey deep regards and hearty thanks to His Holiness Dr. Sayyid Shah Khusru Hussaini Sahib, Sajada Nashin Dargah, Hazrat Khaja Bandanawaz Rahmatullahi Alah, His Excellency Chancellor, Khaja Bandanawaz University, and Janab Sayyid Muhammad Ali Al-Husseini Sahib, Pro-Chancellor, Khaja Bandanawaz University, Dr. Mustafa Al-Husseini Sahib, Director, Khaja Bandanawaz University. I thank them for allowing us to organize this national CME. My hearty thanks to our Honorable Vice Chancellor, Professor Ali Raza Muswi Sir, Khaja Bandanawaz University Vice Chancellor, and Registrar, Khaja Bandanawaz University, Dr. Rukhsar Fatima Ma'am. They helped us in obtaining the necessary administrative approval and supported in all possible manner to organize this event. My special thanks to Dr. Ajay Kumar Sir, KMC Zonal Chairman from Karnataka. I request all of you to put your hands together to give a round of applause to all the speakers who came from the different parts of the country and emphasize us about the hospital infection control and its preventions. I would like to give a big thank you to our beloved Dean and organizing chairman and my mentor, Dr. Siddesh Sir, for his constant help and guidance that radiated a source of energy within us. We will ever remain thankful to you, sir. My sincere thanks to my friend, Dr. Basir, Director IQAC Khaja Bandanawaz University, for his help and constant support at various stages. I am very much thankful to all the heads of the department, senior faculties, colleagues, students present here, and non-teaching staff members who glorifies today's event. I feel proud and thank you for making this event a successful one. An event of this dimension cannot happen overnight. The wheel starts rolling months in advance. We have been fortunate enough to be backed by a team who are very well motivated and dedicated staff, committee members, students, and volunteers. I cannot thank everyone enough for the involvement they have shown and the willingness they have expressed to take on the completion of tasks beyond their comfort zones. I am very much thankful to the administrative staff of Khaja Bandanawaz University, sponsoring agencies and media, print and press media. At the end, I would like to thank my team members, Dr. M.A. Basir Sir, Dr. Javeria, Dr. Chilpa Pradhan, Dr. Archia Tazeen, Dr. Sanjeev Kumar, Dr. Rimsha, Dr. Firdaus, and Dr. Irfan, and all the non-teaching staff of Department of Microbiology who joined hands to organize this CME. If time is money, today you have spent millions for us. Thanks to all for making this event successful.
Final segment of today's program, very costly affair. We have a small tea break. Please take tea and you all can disperse. Thank you so much for attending today's conference. It was lovely having you all. Thank you. A big